U.S. soybean farmers are proud, resilient. Some even call us, yep, we admit it, stubborn. We keep our promises to our families, our community, and to the earth. Sustainability isn't just a label, it's our livelihood. Our grandfathers remember when drought and over-farming in the 1930s turned our land to dust. That was about 75 years ago when our country put into place some of the world's most stringent resource protection laws. Today, U.S. soybean farmers are partners in trust to protect the land. We approach our mission as if the world depends on us, because in many ways, it does. More soybeans are grown here than anywhere in the world. Roughly 80 million metric tons a year are raised on over 30 million hectares of land. As a result of sound science and continued research over the past 30 years, we have increased soybean yields by 55% on roughly the same amount of land. U.S. soybean farmers have reduced carbon emissions, energy use, greenhouse gas, and soil erosion. We're licensed to use pesticides, insured to protect workers' rights and safety, and our assurance programs are verified. We're meeting U.S. laws and international sustainability standards. And to validate our compliance, a team of 3,000 career conservation agents throughout the country and continual verification through surveys, interviews, field observations, and electronic data that we're operating our farms in compliance with stringent environmental laws. Our commitment is more than just a neighborly agreement. Independent peer-reviewed research verifies U.S. soy is sustainably produced, with comprehensive data demonstrating that U.S. producers are compliant with the vast majority of our hectares already subject to annual audit by the USDA. And because we are driven by a commitment to continuous improvement, we're incorporating soil testing, plant tissue analysis, satellite positioning that precisely adjusts crop inputs, and much more. Why? To ensure that every link in soybean production is sustainable and to live up to our commitment as stewards of the land. If a U.S. soybean farm could tell its own story, it would be a legend, complete with dedication, resilience, compassion, and above all, successful, sustainable perseverance that lives to tell the story all over again. United States soy, verified sustainable. Learn more about our U.S. Soy Sustainability Pledge at ussec.org.
In the United States, there are about 2.2 million farms. We stand together and ready to continue to grow and produce the food that fuels the world.
the second day of the 73rd Scientific Sessions of the Sri Lanka Veterinary Association. And I hope you had an exciting day yesterday with our sessions on animal health, public health, and poster presentations. Well, ladies and gentlemen, as the day 2, we have 3 sessions lined up for you. Well, of course, we have the session on clinicals, the lengthy one, and quite interestingly, we have the session on animal production and wildlife and aquaculture. Well, without wasting any time and to stick to the agenda, of course, I'll start off with the clinical session. Well, before we move on to the clinical session, we have the plenary speech by Dr. N. Horadagoda. In order to introduce the speaker, let me most warmly welcome Dr. Suranj Vijayakon, Senior Lecturer, Department of Veterinary Clinical Sciences, Faculty of Veterinary Medicine and Animal Science, University of Peradeniya.
Good morning, ladies and gentlemen. So you all are welcome to the clinical session at 73rd Annual Scientific Session of Sri Lanka Veterinary Association. So it's great pleasure for me to introduce our plenary speaker today, who is going to talk us about the cytology, a fascinating diagnostic aids in our day-to-day clinical practices. His research interests were in a diagnostic pathology with a special focus on pathogenesis of hemorrhagic septicemia affecting cattle and buffaloes. He moved to Australia in early 2000 and joined the University of Sydney, where he continued his work as a veterinary pathologist attached to the veterinary teaching hospital based in Canada. In his current position, he is involved in many aspects of diagnostic pathology covering infectious diseases and the broad disciplinary of clinical and anatomical pathology relating to all creatures, great and small. He is a passion of cytology and the interest in the use of acute phase protein in early diagnostic techniques. So please put your hands together to warmly welcome our plenary speaker, none other than Dr. Neil Horadagoda. Dr. Horadagoda, screen is yours. Thank you.
Hi, everyone. It's good to connect with you all virtually through this recording. At the outset, I wish to thank the Executive Committee of the SLVA, in particularly the Scientific Committee, for inviting me to make this presentation. It's an honor, and I wish to share some of my information which I'm passionate about. I'm aware that it is not often that a pathologist is invited to make a presentation at a clinical session. Well, I have been here at this teaching hospital for many years, and I'm aware of the expectations of the clinicians, and I hope I will be able to make, to make up for the expectations of the clinicians in Sri Lanka as well. I'll do my best. I know that infectious diseases form a very important part of clinical practice in Sri Lanka, but I think the skin diseases also are an important aspect. And over the years, I've seen many papers on skin diseases presented at the SLVA. And this year in particular, I've seen several tumors being discussed. Some of these are reported for the first time, while others are presenting with unusual presentations. So I thought I might expand this discussion by talking about a diagnostic approach to skin tumors. I've called them lumps and bumps here. And I want to give you a pathologist's viewpoint or a perspective as how we go about diagnosis and also what we expect from our clinicians in making a proper diagnosis. I'm targeting in my presentation the more recent graduates who have joined veterinary practice, small animal practice in particular, and those graduates who might be going into small animal practice. So in my presentation, you might find more breadth than actual depth. I have put the information together in a most practical way with the objective of making you all to implement these things, implement and also establish some of these practices in your day-to-day practice in Sri Lanka. I know Harsha Ariratna has returned to the faculty from a recent PhD from Massey University in New Zealand. Now, Massey University has an eminent group of pathologists in tumor pathology whom Harsha has been working with. So I feel that what I'm talking to today would have a follow-up of some sort where you can get back to her if you want more information on what I'm talking about. I have a very ambitious plan for these few minutes. I want to talk about cytology, discussing sampling, staining, microscopy, and basic interpretation. I want to touch about histopathology, biopsies in particular, the types of biopsies, biopsy selection, handling, and tumor margins. So first of all, we just talk about the common clinical presentation of these lumps and bumps or skin tumors and how you go about approaching it. What's the common clinical complaint? It's often that you find a client coming to you having noticed a small lump, it could be 1 to 2 centimeters, sometimes even much smaller, while the animal is being bathed or while grooming, and that's a concern to the client or the owner. Or you might actually feel a dermal mass during a routine health inspection or during vaccination. That's the usual thing what happens. And then the client comes to you, or you have detected something. So you need to get some questions going. So you need to ask, how long has this mass have been there? So if it's a mass which has been there for many months, up to a year or even more, it's likely going to be a benign tumor or even maybe an epidermal cyst or a cyst of some nature. If it has come up very quickly, just overnight or in the last couple of days, it's going to be something more inflammatory. So just looking at that history, you can get a feel for what the mass is going to be and what your vague diagnosis is going to be. The general well-being of the animal is also important. Example like losing weight. Now, this is not so common when you have a small mass in the skin, but if you have multiple masses and if they have been growing bigger over time, then the animal could be losing weight and there may be other systemic changes as well. For example, animal being going off feed. There may be pain expressed, particularly if the animal has got a perianal gland tumor. So there may be pain at defecation. So some of these are the things you can inquire from the owners. So then you move on to the physical examination. We talk about the signalment. And talking about the breeds, just one breed which comes out to mind is the boxer breed, in which mast cell tumors are rather common. But I mean, here in our lab, when a boxer comes in with a mass, we always try to rule out mast cell tumor first before we start looking at other skin tumors. So it's that common. Sorry for talking adversely about the boxers, but that's the story you will see in the literature as well. The age of the animal is important. For example, if the animal is a young dog, between less than 3 to 4 years old, you find that histiocytomas are more common. And of course, the animals, as they age, you get much more a range of tumors. The location of the mass is also important. I've given here an example of the lip mass. And so plasmacytomas are more common in the lips. And then, of course, they are common also in the digits. So the location is an important feature as where you find tumors. The size, the shape, the color is an important feature. For example, if the mass is red, it's more likely going to be a vascular tumor like hemangioma or hemangiosarcoma. If it's a black tumor, a black mass, it's more likely going to be a melanocytic tumor. And I've given here an example of melanocytoma, which is a benign tumor of the melanocytes. Then, of course, in your inspection, you might find single mass, or the owner would have seen noted only one single mass. But in the clinical examination, it's important that you look for other masses. So you might find other masses in the body apart from one. And before you wind up, it's also important that in your clinical examination, you include the lymph nodes, superficial lymph nodes, because some of these masses which are growing may even spread to the lymph node. And if they are moved to the lymph node, then obviously you have an example of a malignancy. Then, of course, moving on to the investigations, if the animal has systemic signs in particular, it's important to have a baseline data. The baseline data would be hematology, biochemistry, and a urine analysis. And then, of course, your diagnostic approach would be, first of all, cytology. So why cytology? So cytology is, as a practitioner, is a rapid test you can do. It's inexpensive. It's relatively non-invasive. I know you're going to put a needle in, but compared to a biopsy, it's relatively non-invasive. You can establish a diagnosis almost immediately and work out a treatment plan. For example, if it's a round cell tumor, you might discuss with the owner of surgical excision of the mass. So depending upon, and if it's an inflammatory process, you might discuss about antibiotics. The process does not require any anesthesia, and the interpretation can be performed in the clinic itself. So I'll just go through the process very quickly to you. So the fine needle aspiration requires a 22 gauge needle. The books would say 22 to 25, but 22 or the black needle is a good one to work with. The syringe would be a 10 ml. Again, 3 to 20 is recommended, but 10 ml is a good one. And the number of slides would vary from 2 to 4 or 5. So how you do that? I've just got the procedure here. So you have first of all, you have to restrain the mass between your thumb and your index finger. And then you pass the needle in to the mass. And then you start to, on your needle, just bring some negative pressure. Don't pull hard. Just 1 ml would be fine. So on this barrel, you just pull 1 ml. You stop there. And then you redirect the needle to another side. Again, you pull. When I say pull, you pull the plunger up to 1 ml, let go. And you do it to maybe 2 or 3 directions. And then you let go the negative pressure completely. And then you take the needle out. And then what you do next is you take the needle away from the syringe barrel, fill some air into the barrel of the needle, connect the needle, and squirt the stuff onto a glass slide, as you can see down here. So that's the material you have picked up. You don't expect to find anything inside your hub. You don't expect to see. Everything will be picked up in the needle. If you've got blood here, then you've got too much of blood contamination. So once you have put the sample over here, what you do next is you place another slide over this one. So that's the slide A, which you have collected. Put this other slide over that, and then you gently move that across the slide so that you smear it off like that. And therefore you have slide D, which is you're going to examine. But of course, you can also use slide B because that would also have some cells. So with one prick, you have made 2 slides. And what you got down here is an example of a slide which is prepared and it's stained up. And on the slide, on the frosted edge, you can write the name of the animal, the number, and the location. And then, of course, talking about stains, we can use the Diff-Quick stain, which we use commonly here. It's a bit expensive in Sri Lanka, I know that, but Teamsa is a good stain to use. And of course, Leishman, which you all use commonly, should be another example of a stain to use. So then the next step would be looking at under the microscope. And here I would just make a few comments. You would like to, when you buy a microscope, make sure you have antifungal coating on it. When you clean the lens, you can use absolute alcohol. And the most common lenses we will use are the 4x to 40 times. The oil immersion lens is a very expensive lens. If you want to give it up, that's fine for cytology, but for hematology, you might find that useful. Slide examination, you will do it in the 4 times or the 10 times. And one of the things we do often is we place a cover slip. Now you can see these 2 slides here. This one has no cover slip and this one has a cover slip. You can see a marked difference between the two. And we rarely use our oil immersion lens, or we rarely use oil in our examination of cytology. So the diagnostic process here, you can talk of it inflammatory and non-inflammatory. And then if you have neutrophils in your slides, it could be an abscess, a bacteria or bacterial infection, or could be a foreign body. If you've got a mix of cells, you might have macrophages, lymphocytes, and eosinophils apart from the neutrophils. It could be, again, a foreign body, fungal infection, or parasite. And then, of course, it could be a non-inflammatory mass. It could be a cyst, for example, an epidermal cyst, a hematoma, or a seroma, or a hygroma. And this is an example of a epidermal cyst cytology. And then, of course, a non-inflammatory mass, a non-painful mass in particular, could be a neoplastic mass, and depending upon the shapes of the cells, you can say a round cell, epithelial cell, or spindle cell. So I might discuss a little bit of this neoplasia. Here's an example of inflammation before I go on to neoplasia. So that's all the inflammatory cells. So you've got a macrophage here, you've got a lymphocyte here, and these are all neutrophils, and you've got the bacteria within the cells as well. So that's a very lucky finding. And this is a pycnotic nucleus. So if you've got all your smear is full of these neutrophils, it's inflammatory, full stop. Then, of course, you're talking about tumors. We have the round cell tumors. So you have the tumors can be based upon rounds, epithelial and mesenchymal. So when you say round, the cells are round. And in this group is the TVT, which you all see very commonly in Sri Lanka. The other round cell tumors are the histocytomas, the mast cell tumor. This is the most common tumor. Then you have lymphoma and plasmacytoma. If the cells are clumping like what you see here, that's most likely epithelial. So the stratified squamous epithelial, the tumors from the skin adnexa, and also the epithelial lining from glands and ducts. If the cells have got this spindle-like character, this kind of spindle feature, then it could be a mesenchymal tumor. A spindle cell soft tissue tumor is the most likely one. Then once you have diagnosed whether it's the round cell tumor, the advantage is you can go on to say what the name of the tumor is. If it's a epithelial tumor or a spindle cell tumor, you look for features of malignancy, and this is of a book which I've cited in my references, and which you can have a look later on. And you look for features of malignancy, which can be cell characteristics or it can be nuclear characteristics. And then I'll just move quickly on to histopathology. Very briefly, I just want to go, histopathology is the gold standard for diagnosing of tumors. So we have the different types of these biopsies. So we have the incisional biopsy, where you only take a small sample of tissue. So that's the mass, which is that's the dermis, epidermis here, dermis, and the subcutaneous. Here's your mass, and you take a small sample of the tumor. So that's called an incisional biopsy. And this one here is the excisional biopsy, where you take the entire tumor out in your biopsy process. Then the other less commonly used biopsies are the needle biopsies, where you put a needle in. This needle here would take a piece of tissue, which is about 1 millimeter, about 2 millimeters in diameter, and about 10 millimeters in length. And then, of course, we have the fourth type, which is the punch biopsy, which is a little instrument which is used with a diameter of varying from 4 to 8 to take a punch of the skin in particular, and you end up with a piece of tissue like that. The epidermis there, the dermis, and the subcutaneous there. So these are the 4 types of commonly used biopsies. And then there's a selection of biopsies. You can do it in multiple ways. So here is an example where I'm doing an excisional biopsy. So here's an example of the skin, a skin biopsy being taken. You've taken the entire thing out. Here's the mass, and you've taken the entire mass out. So that's an excisional biopsy. And here we have an incisional biopsy, where you only taken a small piece of tissue, because in this location, you need to plan the surgery, because that's a little difficult area to bring the skin together. So you need to plan the surgery. So you take an incisional biopsy. And then, of course, then thereafter, you will plan the surgery, depending upon what sort of mass you got. And now this one here, this is the graph to show you. The more tissue we have, we pathologists like to have more tissue. So an excisional biopsy is more likely to give you a diagnosis as compared to an endoscopic biopsy or a needle biopsy where you have very little tissue. And this one here is about fixation. I just want to tell you that we all know this. We fix the tissue in 10% formalin. You got to put it in formalin as soon as possible because you don't want the tissue to desiccate. That's the most important thing. When it's fresh, you can chuck things in. So there's examples of submissions to my lab here. You can chuck things in, but that's not very good because the tissue doesn't fix. You need to have the ratio of 1:10. So we have buckets here. We put the thing into a big bucket to allow it to fix properly. And I'm just going to go through fixation of a mast cell tumor. So that's an excised mast cell tumor. Here is the tumor being excised, and you can see lots of margins being taken out. And then we put it into formalin. So we put it on a whiteboard here to fix it properly so that it's left flat. And here is put into the formalin. And you can see the tissue floating because there's a lot of subcutaneous fat in it. So you've got to put some paper on top of that to make sure that the sample is immersed within the formalin. And that's the fixed tissue. So I'm going to use this fixed tissue to talk about tumor margins. So this is tumor margins. So here we have the tumor here, and here is the margins being taken out. So you take a section right across here. And then what we do is we take a section on the side. So we just look at the side margins and we look at the deep margin of the mass here. So I'm going to take the AB section to show you the deep and the side margins. So this is my histology of that mass. So you find that here is the side margins and here is the other side margin. And here is the mass with the tumor mass, which I've drawn in the dotted line here. So the tumor mass is here. And as you can see, the side margin is clear on this side and the side margin is clear on the other side too. And here is the deep margin. So the deep margin also is clear. So this is the good news for the clinician or the surgeon. We have a complete surgical excision of the tumor mass. Now, this one here is an incomplete surgical excision. And here is the tumor margin. This is an example of anal sac adenocarcinoma. And that's the surgical margin. And you can see the surgical margin is incomplete because you've got the tumor moving down here. So that's not good news for the surgeon or the clinician. Right, I just want to quickly run through the difference between cytology or the positives between cytology and histopathology. Cytology is excellent for diagnosing mast cell tumors. That's one tumor you can diagnose easily. It's good for lymph nodes. They prefer lymph node cytology as compared to histopathology. You can look at infectious agents for vaginal smears, obviously, for looking at animals' estrus or in other phases of the estrous cycle. That's a good one to look at, the vaginal smears. And also you can use ultrasonography to look at organs inside the body, apart from the skin. The positives for histopathology, of course, it's the gold standard. Then, of course, you can use other methods like histochemistry, immunohistochemistry. And one big advantage is you have architecture. And then, of course, you can go on to grading of these tumors. You can get a better feel whether the mass is benign or malignant. And you can also discuss about tumor margins. So with that, I just want to finish off with giving you some references on cytology. I've got a whole list here, which you can look up. And this is the website from Cornell University in the US, which is on the web all the time. It's a good one to look at cytology and also to look at clinical pathology. And then I've just got one reference on biopsies, which you can look through. Thank you very much for listening to my presentation.
Thank you very much, Dr. Horadagoda, for opening our eyes on bumps and lumps in our body and bring up and blooming our minds on the histopathology. So it's a fascinating topic. Thank you very much, sir. And good afternoon, sir. How are you? Can you hear us? Okay, so the floor is open for any questions to raise from our plenary speaker. If you have any questions, it's a time for you to answer. Good afternoon, sir.
Yeah, good afternoon.
How are you?
I'm all right, thanks. Yeah, glad to see. Glad to see everything.
So am I correct? So when you are so obsessed with the pathology and somebody puts a picture of rice plate, so as a pathologist, you are looking for rice bodies. Is that correct?
Rice bodies. What do you mean by rice bodies?
No, it's just a joke. So the audience are ready to ask some questions from users. So until they are prepared,
Yes.
there's a question from my side. We have seen that you have told about this needle size for aspiration from the lumps, like a 22, 25 gauge. But in case of ultrasound guided sample collection, can we go for such a small sizes? So we will select a more tiny, or is that beyond that size? So
The thing is, if you go to a very finer size like 25, you're going to damage the cells a lot when you're aspirating and when you're squirting the cells out. And also, on the other hand, when you go for a needle with a wider bore, like an 18 gauge, you get a lot of blood contamination. So the 22 gauge is the most, is one of the better needles. It has a balance of its size, in terms of blood contamination and also damaging the cells as less as possible. So the preferred needle size, if you can, is 22. This is not only my experience, but there are other people who have used different types of needles, and they feel 22 is a good one. This is why I mentioned 22.
Right. Okay. Thank you.
Yeah, you're welcome.
Yeah. Any questions from the audience? Online participant, you can ask, raise questions.
Yeah. Good morning, sir. I'm Randika. So yeah, it's very, good. This morning is very happy to hear one of our old teachers' voice. Actually, in the morning.
Good morning.
And,
Good morning.
yes, sir. And a small question I have. Actually, I mean, when you look at the smears of this, in the clinical level in our hospitals, like when you have a glance. Can you define us some features exactly to say that, get an opinion about whether this tumor is going to be a metastatic one or the normal localized one? So I mean, just some hints at a glance how we can differentiate. Just to you can explain us a little bit. Yeah, thank you very much.
Yeah, that's fine. Yeah, no worries. So as I said before, you look for the cells and you look for the shape of the cells, right? If they are rounded, then you call them round cell tumors, right? If the cells are all clumping, it's most likely going to be epithelial, okay? And if they are spindeloid, when you say spindeloid, the nucleus is in the middle, and you get two spindles, you get two cytoplasmic processes going on each direction, if you look at the slide I showed you. So that's a spindle cell tumor. Now, if you got a round cell tumor, it's easy because you can actually give it a name. You can say whether it's a mast cell tumor or whether it's a TVT, the TVT, of course, has its location. But if it's a mast cell tumor or a histocytoma or a lymphoma or a plasmacytoma, so that you can work it out looking at the cells. Now, if the mass is epithelial or if it's a spindle cell tumor, then you must look for features of malignancy. So I showed you a little chart there. I could not go into detail because of time constraints. But if you look at the mass, if you look at that list there, and if you got three features of that list, then you got a malignant mass, full stop. Is that clear? So you got to look for the three features of malignancy. For example, if you find that the cells are of varying size, which is called anisocytosis, right? That's one feature. If you get nuclei of varying size, that is anisokaryosis. If you got multiple nucleoli, if you got nucleoli of different sizes, so you need to look at it very carefully. So if I just could expand that question a little bit more. So you have a slide, you put a drop of oil and put a cover slip over that. And then you can look through the dry lenses. You pick up the area where the cells are, and then you start to move to 20 times and 40 times. And then you can observe the cells very closely. And then you can observe for cell size variation, nuclear variation, and maybe nucleoli variations in size. And if you got angular nuclear, and that chart has got about 15 features, which I don't want to go through now, but you can look at those. So in our practice, if you have 3 features and more, full stop, it's a malignant mass. Does that answer your question?
Yes, thank you very much. And further extension of the question, like, so, I mean, if you get the blood picture of the patient, is there any hint we can get from blood picture of the patients having cancers, like tumors?
Very unlikely. Very often you don't find. The only reason why you get blood is that if it's a single mass, often you don't see anything in the blood unless it has some other problem, right? But if it's multiple masses, then the animal could be losing weight for some reason. So you might gain, for example, you might find that if I was going to talk of blood picture, you might find the creatinine levels going down because the body weight is going down. You might find the proteins going down because, again, the protein absorption may be affected. But other than those, and of course, the anemia is a very common thing. Anemia of chronic disease is a common thing with some of these masses. So you get an anemia, but then what happens is the red cell, the red cell count, the hemoglobin, and the packed cell volume or the hematocrit is only slightly lower than the normal. For example, the packed cell volume in a dog is between 37 and 55, right? That's the normal value in most places. So you might find about a packed cell volume of about 30, just slightly below, but you won't find any features of regeneration. So it will be a non-regenerative anemia. So it's called what is called an anemia of chronic disease. That's what you might see in the blood picture. But that is not specific to a tumor by any means. It's only an indication of what's going on in the animal's body. But other than that, there are no specific markers as such, which you might see with tumors, at least in the animals at the moment. Now, for example, in the humans, of course, if they have prostate, then you have PSA going up. So there are markers in humans. But in the case of dogs, at the moment, not that I know of, there are no specific markers of tumors. That's something people are researching and trying to look for. Does that answer that question?
All right, thank you, sir. Any other questions? Yeah. Okay, thank you very much, Dr. Horodagoda, for joining with us today and spending your valuable time. And I would like to appreciate your inspirational thoughts and the inputs to this conference. Thank you very much, sir.
My pleasure. All the best to you all too. Bye then.
Thank you very much. Thank you very much. Stay safe.
Bye then.
That concludes the plenary speech on the clinical session. That was on lumps and bumps in the small animal practice, pathologist perspective. Well, now we have the plenary speech on the session of animal production. It's an honor for me to invite Dr. Chanak Rebel, Senior Lecturer, Department of Farm Animal Production and Health, Faculty of Veterinary Medicine and Animal Science, University of Peradeniya, to introduce the plenary speaker.
Thank you, Chandrindu. President, Sri Lanka Veterinary Association, Director General, Department of Animal Production and Health, invited guests, colleagues, good morning to you all joining us from Sri Lanka, and good evening to Dr. Matthew Wheeler, our plenary speaker, joining us from the USA. It is with great pleasure that I introduce Professor Matthew B. Wheeler, our plenary speaker for the animal production session of the 73rd annual scientific sessions of the Sri Lanka Veterinary Association. Our speaker today earned his bachelor's and master's degrees in animal sciences from the University of California, Davis, and his PhD in physiology and biophysics from the Colorado State University. He has also earned 2 fellowships, an NIH fellowship from the College of Medicine, University of Virginia, and another NIH NRSA fellowship from the University of Wisconsin. He joined faculty in the Department of Animal Sciences, University of Illinois at Urbana-Champaign in 1989, and has risen through the ranks to professor. Professor Wheeler's responsibilities at the UIUC, that is University of Illinois, include teaching and research in biotechnology, reproductive and developmental biology in the departments of animal sciences, bioengineering, and veterinary clinical medicine. He also has appointments in the Carl Voss Institute of Genomic Biology, the Beckman Institute for Advanced Science and Technology, and the Micro Nanotechnology Laboratory at the University of Illinois. In addition, he is a visiting professor in the Department of Biomedical Engineering at the University of Wisconsin-Madison. He has conducted more than 40 years of research on developmental biology, stem cells, cloning, transgenic livestock, genomics, and regenerative biology. Dr. Wheeler has developed and characterized genetically modified swine with increased milk production and weaning weights. Some of his research has direct applications on humans. An example is his research in pigs that led to development of 3D airway splints for infants with tracheobronchomalacia. He has published over 200 peer-reviewed articles, chapters, and technical articles. Dr. Wheeler also holds 44 US and international patents. During his tenure at UIUC, he has received more than $25 million worth of grants, gifts, and contracts. His research has been funded by the USDA, United States Department of Agriculture, Department of Defense, National Science Foundation, NSF, USAID, US Agency for International Development, the Gates Foundation, and NIH, the National Institute of Health. He has served as a past president of the International Embryo Transfer Society, the IETS. He also serves as a commissioner on the Commission for Dental Accreditation that approves accreditation of dental schools, dental programs, and maxillofacial surgery programs in the USA. He has been honored with the D.E. Becker and H.H. Mitchell Awards for Excellence in Research, undergraduate and graduate teaching, and as a university distinguished scholar. Dr. Wheeler has recently received the College of Aces Funk Award for Excellence, the International Embryo Technology Society's Distinguished Service Award, the Carl Foundation Hospital Friends of Research Award, and the UIUC Distinguished Faculty Leadership Award. He has also been named an honorary lifetime member of both the Brazilian Embryo Transfer Society and the International Embryo Technology Society. Dr. Wheeler has been the primary advisor for over 100 undergraduate research students, 26 masters, 9 PhD, and 18 postdoctoral students, out of whom the best looking postdoc happened to be from Sri Lanka. Professor Wheeler, on behalf of the Sri Lanka Veterinary Association, I thank you for accepting this invitation despite your busy schedule. And I hereby invite you to deliver the plenary speech for the animal production session of the 73rd Annual Scientific Sessions, titled Reproductive Biotechnologies, the Fast Lane Towards Self-Sufficiency in Dairy Products. Considering the potential technical challenges, we have obtained a recording of Professor Wheeler's speech. However, after playing the recording, Dr. Wheeler will join us for a live Q&A session. He is already online. So I appeal to the audience to kindly be ready with your questions at the end of the recording. Thank you. You may please play the recording. Thank you.
Good day. I'm Dr. Matt Wheeler, professor in the Department of Animal Sciences and Veterinary Clinical Medicine at the University of Illinois in Urbana-Champaign. I'd like to thank the organizers of the Sri Lankan Veterinary Association Annual Conference for 2021 for inviting me to present my talk, Reproductive Biotechnologies, Fast Lane Towards Self-Sufficiency in Dairy Products. The problem is, in the year 2050, we're going to have 9.7 billion people to feed. Only a few years later, in 2100, we'll have 11.2 billion people to feed. Global food production must increase by 100% by 2050 to meet our growing needs for food. One possible solution is increasing the arable land mass, but as you can see from this graph, since 1990, the per capita arable land mass has actually decreased. Another possibility is to raise more livestock. Do we raise more cows or do we turn to innovation? For example, with innovation, every year each cow has to give just 4.75 ounces more milk, approximately 140 milliliters per day, which is about a half a glass of milk, and we'll have enough milk to meet the world demand. So increasing land area and increasing livestock numbers are really not options to solve this problem. In 2050, the world population will require 100% more food. And of that 100% more food, 70% must come from efficiency improving technology. As an example, this 100% more food represents all the food that mankind has consumed for the last 500 years. That means we're going to have to produce that much food each and every year. FAO has done a number of studies to look at what are the greatest opportunities to increase small landholder productivity. And animal genetics and animal health are the two that rise to the top, with animal genetics providing the largest opportunity across all geographies for improvement, including Africa and South Asia. Assisted reproductive technologies, or ARTs, are one possibility to help achieve this increased efficiency. Many of you are familiar with artificial insemination. It's been used for the last approximately 80 years to improve our livestock by using genetically superior sires. Two other tools that have come on board in recent years, multiple ovulation and embryo transfer, or MOIT, has been used since the early 1970s in cattle, and ovum pickup and in vitro embryo production of embryos, or OPU IVP, has been used since the late 80s and early 90s. Two other tools, cloning and genetic engineering, may be tools for the arsenal that come into play as we need to increase the efficiency of our animal production. Multiple ovulation and embryo transfer, or MOIT, is where you produce embryos in the cow in vivo. The cows, donor cows, are superovulated. They're artificially inseminated at heat. The embryos are cultured inside the cow. These embryos are recovered by uterine flushing or lavage. At the same time this is going on, suitably prepared recipients are synchronized. Embryo transfer is undertaken at day 7 after insemination of the donor cow, and then hopefully a pregnancy is established in parturition. I understand the university is currently doing MOIT. However, OVP and IVF is the next step that will greatly increase embryo production per donor. This is an example of what MOIT can achieve. This is a cow, Windymont Mad Kathy. She's a Holstein cow that had 10 calves born after the transfer of 16 embryos in 1978. And this is almost 40 years before cryopreservation of embryos was perfected. Superovulation and flush starting at age 5, Kathy went on to produce more than 100 embryo transfer calves in the next 5 years, while continuing to carry 3 calves of her own, thus maximizing the use of this donor by having embryo transfer calves as well as her own calves. Ovum pickup and IVP is the next logical step in this continuum of technologies. In vitro embryo production, or embryos that are produced in the laboratory. Donor cows are aspirated to collect oocytes. Semen from either sex semen or conventional semen from elite sires are used for the in vitro fertilization in the lab. These embryos are then cultured and frozen, and then the embryo transfer is very similar to suitably prepared recipients, as you see in MOIT. One big advantage of this is that fertilization is not affected by ambient temperature. In hot climates and during heat stress, pregnancy rates decrease with artificial insemination. If you use frozen embryos from IVF, the fertilization temperature is controlled and higher pregnancy rates are achievable. In a recent review by Peter Hansen from the University of Florida, pregnancy rates from AI ranged from 13 to 22%, and with embryo transfer, 29 to 42% during hot months. Just a quick review of ovum pickup. The cow is transrectally palpated. A handle is inserted that carries the needle guide as well as the ultrasound probe in it. The ovary is manipulated toward the end of the ultrasound probe, where the needle guide is able to aspirate the ovarian follicles. You can see it better here. Here's the handle. Here's the ultrasound probe and the needle. The ovarian follicles can be visualized then using a vacuum pump that can be collected in a tube, and immature as well as mature oocytes and granulosa cells with follicular fluid can be recovered. In this figure, you see three ultrasound images of bovine ovaries. Each one of these dark circles is an ovarian follicle containing an oocyte. These can be aspirated using this follicular guided ultrasound aspiration, and oocytes can then be recovered and matured in vitro. As you can see from these two panels, as many as 100 oocytes can be aspirated from a single donor. If you look at the panel on the left, which is Bos indicus, and the panel on the right, which is Bos taurus, they get about the same mean number of embryos or of oocytes, but the curve is broader for Bos indicus, and typically in our hands, we recover between 30 and 40 oocytes per donor for a single OPU session. If you look at the International Immunotechnology Society statistics, you can see since 2000, the number of bovine embryos produced both in vitro and in vivo has increased to about 1.4 million in 2019. You can see that the number of in vitro produced embryos has steadily increased over that time to about 1 million embryos in 2019, while the in vivo produced embryos in the cow has remained relatively constant and maybe even decreased a little bit to about 400,000 per year. If you look at these data by region, you can see that North America and South America has really taken advantage of this technology, producing about 1 million embryos per year, while Asia really has not yet taken advantage of this technology, and it's really an area of potential growth and improvement of genetics in these countries. Some of the advantages of these assisted reproductive technologies are increasing the number of animals, number of embryos per donor. If you use conventional breeding or artificial insemination, if you look at a cow's average 7-year lifespan, she can produce 7 calves. If you use multiple ovulation embryo transfer or MOET, you can produce approximately 100 calves during that 7-year lifespan. And if you use ovum pickup and in vitro embryo production, you can produce almost 700 calves during that 7-year lifespan. One of the other advantages is shorter periods between generations. Pregnancies can be obtained from heifers as young as 5 months old, and they can actually produce pregnancies before they reach puberty. You can also improve uses of donors to get more calves and more embryos per donor. And it also allows you to improve uses of semen. You could produce approximately 600 oocytes with 1 dose of sex semen, and this potentially would produce between 100 and 200 embryos. All these combined lead to faster genetic gain. As you all know, 70% of the world's cattle are in the tropics. Typically, the cattle in these areas are Bos taurus breeds, which are much less efficient at producing meat and milk than European cattle breeds, but they're much better adapted to hot and humid environments. We've taken advantage of some of the work that's been done by our colleagues in Brazil, crossbreeding dairy Bos taurus and Bos indicus dairy breeds. And here is an example where high quality Holstein donor cows were used and bred to high quality milking gyr bulls. This cross makes what they call in Brazil Girolando cattle, where there's a continuum of genetics from the gyr, a pure gyr, which is the lowest milk production but highest heat and disease resistance, through the quarter gyr, half blood gyr, 5/8 Holstein and 7/8 Holstein, down to the Holstein cow, pure Holstein, which is the highest milk production but the lowest disease resistance. So there's a continuum of genetics here that can be adapted to the specific climate that you're interested in. We've taken advantage of that, the highest hybrid vigor in the half-blood Holstein gyr cows, as well as the 5/8 Holstein 3/8 gyr cows for our studies. Just as an example of what this technology can do, this is a half-blood Girolando cow, and she was the record holder for the 2016 dairy tournament in Brazil, and she produced 84 liters of milk per day, being milked twice a day. Just as a note, that 2021 Girolando record cow half-blood cow produced 139 liters per day. Both of these animals were produced by in vitro fertilization. We've been doing this at the University of Illinois for approximately 12 years now, where we've been seeking to improve tropical adapted dairy breeds. And we've been doing this through a program, the University of Illinois Coalition for Genetic Improvement of Livestock. Just an example of some of our early work. These are some Holstein Gier F1 embryos that were produced by in vitro fertilization. These oocytes that produced these embryos were collected at the University Dairy in Urbana, Illinois, in the USA. They were then flown to Panama City, Panama, to the laboratory where they were fertilized, cultured for 7 days, and then transferred. And these are the first 3 calves that were produced by that work. Just to give you some idea of impact this technology can have, even with a very modest increase in milk production, some of our work in the Dominican Republic and Panama, in the DR, average milk production is about 3 liters a day, which results in a daily income of about $1 and a monthly income of about $30. If we can increase that production from 3 liters to 9 liters, which is an increase of 6 liters per day, you can actually triple the daily income and triple the monthly income, which is results in about $60 increase in monthly income for these subsistence farmers, which is a significant amount of money. This is a table showing some of our early work milking some of these animals in the Dominican Republic and Panama. I just want to note that these animals were 100% pasture fed at temperatures greater than 32 degrees Celsius and at 95% humidity. And you can see of these 40 animals, the average production for the indigenous cattle was 2.8 liters, and these cattle was 13.8 liters, which results in about a 5-fold increase in production per animal. These are some of the donors that we've been using in our project at Chesapeake Farm in South Carolina, which is an area of the U.S. that's hot and humid. It's swampy and marshy, so it's wet most of the year. These animals were used as donors to produce our 3/4 Gier females. Our facilities there are pretty modest. We recently had this roof put over because it rains 3 to 6 inches per day fairly frequently. It's a very simple working cattle chute with a squeeze, where this is our veterinarian who's aspirating a donor here. And this is the back of the ultrasound machine on a small table. You can see it's very modest facilities, but it works very well for this work. So it can be done out in the field quite efficiently. This is our chute side lab. It's a prefab storage building that we fitted with electricity and water. Plenty of room for 2 scientists, Dr. Milner and Dr. Rabesa, to recover the oocytes that our veterinarian has recovered from the donor cow. They can be washed, packaged, and shipped to our lab in Urbana for fertilization. The size of this lab is about 10 square meters. This is an example of some F1 calves we produced in 2018, 2019. These are some 3/4 Gier calves that we produced in the fall of 2019. Just to give you some snapshot results from our work at Chesapeake Farm, in 2021 and 2022, we used approximately 40 donors. We've had 438 confirmed pregnancies. I've got 50 exposed recipients to preg check, but I expect about 18 pregnancies from these animals. If you calculate this, we've had 120 calves to date, 76 due by the end of the year, and another 260 by the middle of April. And we expect approximately 450 calves from the 2021 breeding season. In our previous years, we basically ramped up each year, doubling our production. You can see in 2020, which is the COVID year, we didn't do quite as well as I would have liked, but so far we produced about 370 calves from our project with IVF at Chesapeake Farm. As an example of some of the animals produced, this is our first lactation milk production. These animals were at a dairy farm in Bowman, South Carolina. Again, they're 100% pasture fed. The temperature was greater than 32 degrees Celsius and 95% humidity. And you can see the production range from 16.3 liters to 21.2 liters, which represents a 5.8 to 7.5 fold increase in milk production per animal. How can this technology help Sri Lanka? my lab research has been strongly influenced over the years by my international collaborators, including Dr. Chanaka Rebel from Sri Lanka, who spent 2012 and 2013 in the lab with me, as well as scientists from around the world, Libya, Italy, and Brazil. Dr. Rebel shared these statistics with me from some of your dairy production. And as you know, you produce or you consume about 3.5 million liters per day. You produce locally 1.3 million liters per day, which leaves a balance of about 2.1 liters per day that you need to import. If you think about strategies towards self-sufficiency to producing this 2.1 million liters locally, there's a number of strategies that you can consider, but if you could produce 70,000 cows that produce 30 liters a day, like these Gerlandos, that would get you to self-sufficiency, or 100,000 cows at 20 liters per day, or even 200,000 cows at 10 liters per day would get you to self-sufficiency. If we think about the middle strategy and adding 10,000 milking cows per year for 10 years with a 20-liter production, you can achieve that over 10 years by adding this many animals per year that produce 20 liters. But the breeding strategy is critical. This is really where MOET and ovum pickup and IVP can help you make this happen. How can the University of Illinois help Sri Lanka? Certainly technology transfer in the OPU and IVF technology, work with our grazing and forage research teams, cattle nutrition for heifer development, some of our work in precision farm management, digital agriculture, including electronic heat detection and data capture, which sometimes is difficult in Bos indicus, artificial intelligence to evaluate milk production and genetic selection, and cell phone-based cattle management software development, which is what we're currently working on. A number of years ago, Norman Borlaug said, "Peace cannot be found on an empty stomach." I thank you for your attention today. I'd be pleased to answer any questions by Zoom. Thank you very much.
Thank you very much, Dr. Veera. Are you with us online?
I'm here.
Okay, great. Great to hear your voice, Dr. Veera. Thank you so much. So let me remind the audience that it's currently about 11:30 p.m. for Dr. Veera. And in spite of that, you can see from the dark background, right? So in spite of that, he has agreed to, be present today live with us. So I think your speech was extremely relevant to the Sri Lankan scenario, because yesterday during the speeches from the guest of honor and chief guest, they highlighted how Sri Lanka needs to become self-sufficient, at least 80% self-sufficient by 2025, and also the poverty aspects in Sri Lanka, how COVID has impacted and all that. So Dr. Veera, before I move on to questions, I want to clarify a few points. Did you say some of these Girolandos produce as much as 130 liters of milk per day?
Yes. The half-blood Girolandos, those animals were fed supplemental feed. But yes, they made the record holder of 2021 produced 139 liters.
Wow. So I think you mentioned that because of hybrid vigor, the crossbreds produce more milk than either of the purebreds. Is that right?
Yes.
Yes, great. And you said the animals produced by the University of Illinois, they produced as much as 20 liters with 100% pasture at 32 degrees Celsius with the Sri Lankan climate and 95% humidity. Did I get that right?
Yes, you did. That's correct.
Okay. Wow. So that is fascinating. And I think that has a direct impact. And I think you also said you produced 450 calves with just 40 donors, right?
Correct. Yeah. And,
correct.
And actually my team just returned from the farm earlier this evening. And one of the donors down there yesterday produced 85 oocytes. And so
those eggs we shipped back to the lab, and we received them this morning, and they're currently being fertilized. And my technician will go in at 4 a.m. And transfer those embryos into culture.
Okay, that's absolutely brilliant, and I'm so excited because I certainly think, you know, we can put this technology to use in Sri Lanka, because right now, as you pointed out, we are, you know, 40% self-sufficient of our dairy products, and we want to become self-sufficient at least 80%, as highlighted by the Director General of the Department of Animal Production and Health yesterday. So with that, may I open the Q&A session to the audience? I have already got some questions beforehand. So if there are any questions at the audience, that would be lovely. Madam, yes. Can somebody get a mic to Dr. Kothilawala, please? So, Dr. Wheeler, this is the Director General, Dr. Mrs. Kothilawala, Hemali Kothilawala, Director General of the Department of Animal Production and Health. Yes, madam, go ahead.
Hello. Hello.
Good morning.
Yes, good evening for you. Yes, very interesting presentation and very appropriate for Sri Lankan situation. As Dr. Abel said, yes, we are in the process of increasing our milk production up to 8% self-sufficiency by 2025. So the technology will be very useful for Sri Lanka. I have a question. You said the technology, IVF, is more suitable for Bos indicus than Bos taurus. Am I correct?
It works a little bit more efficiently in Bos indicus because for some reason, Bos indicus cows produce a lot more oocytes per aspiration. So you have the potential to make more embryos. And so as you see, some cows can make 40, 50, in the recent case, 85 oocytes, but typically they make somewhere between 25 and 35. And so so in the last 2 days of aspirations, we produced about 800 oocytes from those 40 donors.
Okay, thank you. But you said the technology has not adapted yet, not yet adapted by the Asian people, Asian countries. Do you have any reasons for that? Is it the cost or the cost effectiveness?
No, I really don't, you know, and I actually called the statistics person. You know, a simple answer could be that embryo production has just not been reported, and that it is, you know, currently happening, but we just have no actual numbers. You know, one of the things when we started this work, and I spent a lot of time in Central and South America in the field, and we tried to mimic our studies after field conditions. And so you really need, you know, most of our equipment we could put in a vehicle or in a you know, small SUV or van, and so it's very portable to the site. And I really don't have any reason. Certainly another option other than ovum pickup is to use, you know, slaughterhouse material, abattoir material of good quality cattle, and we certainly have done that over the years. But no, I really don't have a reason why it's not been utilized in Africa and Asia.
Madam, may I add something to that? So I think Dr. Wheeler was spot on when he said these are not reported, because even at the University of Peradeniya, you know, if Dhammika was here, he would give exact numbers. We produced about 20 in vivo embryos last year, right? So, and I'm sure those numbers are not reflected in the IETS records. Right? So I'm sure it's a matter of values not being reported, whereas in the Western countries there is a mechanism to collect the data and to report that data, but we don't have such a mechanism. So I'm sure things go on under the table, under the radar, but it doesn't get reported. That is one of the reasons. Thank you so much, Dr. Wheeler.
I think there's some interest. I just had a scientist arrive from Egypt, from the veterinary school in Alexandria to train for 2 months. And then another scientist is coming in the spring from the Philippines. So I think the technology transfer piece is happening. And I hope, in the next few years, that number greatly increases.
Okay, wonderful. We have another question. This is from Dr. Susanta Mallavarachi, Director of Agro Hales. Sir, please go ahead, direct your answer to Professor Wheeler.
Yeah, Professor Wheeler, very good evening to you. And actually, it is a very interesting and eye-opening session for us because Sri Lanka is in need of improving milk production. Professor, my question is basically, though we have a short sufficiency of milk in Sri Lanka, but most of the people are now deviating their attention to type A and type A1 and A2 milk. So the beta casein A and beta casein A1 and A2 is a concern for some people. So from your point of view, how do you see that? Is it a marketing gimmick or a real science in that particular concept?
So I agree with you completely. So our breeding program, and I'm the architect of the genetics program. And so, unfortunately, some of the better quality Holsteins are A1, A2, or even A1, A1. So I actually had one of my scientists, we developed an A2 test. And so I screen all the donors and all the sires. And we just had a group tested for both A2 and for alpha lactalbumin genotype. And my recollection is of those 20 animals, 18 of them were A2, and 2 of them were A1, A2. So I actually screened the donors to try not to use any A1 donors, but sometimes we're forced to use A1, A2 donors. But I always try to mate them to pure A2 sires so we can produce at least 3/4 A2 offspring. And the ones that are A1, A2, I typically use as recipients and retire them from the donor category.
Thank you.
Okay, thank you, Dr. Wheeler. Do we have any other questions from the audience? If not, actually, I do have one question, Dr. Wheeler. So one of the issues when we try to adopt this technology would be, even in the US, the standard rates for success rates for artificial insemination are somewhere around 50 to 55%, but in Sri Lanka we are around 30%. So it would be a valid point if somebody raises, okay, we can't even get artificial insemination perfected. So how can we perfect, technologically advanced technology such as MOET, right? So what is your opinion? Do you think we can or we cannot do it, given the relatively complex nature of the technology involved?
Well, certainly, the biggest issue with artificial insemination and all these technologies is estrus detection. And if you're using Bos indicus cattle, the way they evolve typically is most of them come in heat at night, right? Which is really difficult. And all the current technologies to aids, either the patches or KMARs or chalk that people use, are not terribly accurate. So we've actually been working with a group that has produced an electronic heat detection aid, which counts the mounts and when the cow initially comes into heat, and then counts the mounts through the night. And initially it was an LED readout that you had to count, but that's not so easy in the dark. And so recently I've convinced the company that makes these to actually put a transmitter in. And so now when my cows come into heat in South Carolina, I actually get a text message on my cell phone in Urbana that they're coming to estrus.
Nice.
So the technology exists to improve that. And so I think that's one issue. And certainly if you use MOAT and IVF, you're going to synchronize the recipients, and that is, some extra cost there, but you also pay much better attention to heat detection, and you keep the animals in smaller groups that you can manage. So I think certainly it's achievable. I mean, we've been able to achieve really good success with my colleagues in the Dominican Republic and Panama on these large ranches that are 1,000 hectares with cattle, and bringing them in, for a short period of time, the 3 or 4 days when we detect estrus. So yeah, I certainly think it's achievable in Sri Lanka.
Okay, wonderful. Thank you so much, Dr. Veal. I do not wish to keep you up any further. It's already, I'm sure it's close to midnight, your time. Do we have any other one last questions from the audience? Okay, if not, we can wrap up the session, question and answer session. Professor Wheeler, thank you so much. I really appreciate you on behalf of the Sri Lanka Veterinary Association. We really appreciate you accepting our invitation. And, having a person of your caliber is a great honor to us. Thank you so much, sir. Have a good night. And with that, I end. Yes, Dr.
It's been my pleasure.
Thank you so much. Have a good night, Dr. Wheeler. And so with that, I wrap up the Q&A session and hand over the proceedings to Dr. Chandrindu.
Thank you very much, sir, for having such an interactive session. Well, of course, as the last plenary speech, we have the session on wildlife and aquaculture. To introduce a plenary speaker, I shall most cordially invite Dr. Ganga Vijay Singha, Veterinary Surgeon, Animal Health Division, Department of Animal Production and Health. Madam, the screen is yours.
Good morning, everyone. Thank you, Dr. Chandrinu. It's a great pleasure for me to introduce Dr. Taraka Prasad, today's plenary speaker of the Wildlife and Aquaculture session of the 73rd Annual Scientific Session of the Sri Lanka Veterinary Association. Dr. Taraka Prasad is the Director, Wildlife Health of the Department of Wildlife Conservation in Sri Lanka, and he graduated in 1993 from the Faculty of Veterinary Medicine and Animal Science, University of Peradeniya, and obtained his master's in 2004 in Biodiversity Conservation Management from the University of Peradeniya. And after his postgraduate degrees, he had undergone many training programs related to wildlife health and management. So few of them are capsular course in Diploma in Wildlife Management in India in 1997, and capture and translocation training in Tanzania in 2005. So Dr. Tarak Prasad has 26 years of experience as a wildlife veterinarian and the Director of Wildlife Health of the Department of Wildlife Conservation in Sri Lanka. And he's involved with a wide range of activities, including health management of captive wildlife and captive management of rescued wild animals, and conflict management and translocation activities. And he's also involved with involved in mitigating wildlife trafficking, and he works with international police to mitigate tusker smuggling and genetic analysis. And he's also holds positions in international organizations, and he's a focal point of wildlife health in the World Animal Health Organization, OIE. And he's the scientific council of CMS, Bonn Convention from 2000 to 2005. And he's also the focal point for CMS and involved with the preparation of national reports in Sri Lanka. So I cordially invite Dr. Tarak Prasad. I think he's joining with us live. And floor is over to you, Doctor.
Thank you, Ganga. I think you may listen. Good morning, ladies and gentlemen. It's my pleasure to address this prestigious gathering in second day of 73rd annual scientific session of Sri Lankan Veterinary Association. Today, I represent all the wildlife veterinarians in Sri Lanka, which include both sectors of zoo and wildlife department. As a wildlife veterinarian, our routine activities are treatment of sick or injured wild animals, clinically management of sick or injured wild animals under captivity until their recovery, population control of problematic wild animals, translocation of problematic wild animals, rehabilitation of orphaned wild infants, disease surveillance, and providing services for in situ and ex situ conservation with considering the principles of animal welfare and ethics. Wildlife health has much importance because it plays a major role on a One Health program, and also it has economical importance to the country as a main source of income generation by ecotourism activities and ensure the safeguard of the nations from human-wildlife conflict with other related issues. Since this field has more diverse, there will be a trend to expansion of further new areas of veterinary field to young generation of scientists with a novel management technique. Global disease prevention, management, and control effort must be recognized the independent relationship between animal and human health. Approaches health and approaches known as One Health. This ensures health care researchers and practitioners in both areas work hand in hand to prevent disease outbreak across species and address the root of cause of their spread. This has led to a successful management of many deadly zoonotic disease in its being used to eliminate others in the future. Wildlife conservation is practice of protecting floral species and faunal species and with their prevailing habitats called the ecosystem. As a part of world's ecosystem, wildlife provide balance and stability of nature's process. When it makes changes, can cause alteration of food chains, which result in imbalances of population of some animal species in the ecosystem naturally. Also shows passive involvement of ecosystem imbalances. Wildlife conservation also provides protection and management of water sources in highland and rest of other catchment, including groundwater table of both rivers and inland water tanks. Clean water is a key factor of living organisms, including humans. Wildlife is more important than a recreation value. Importance of wildlife can be categorized as ecological, economical, and investigatory importance, as well as the conservation, biological diversity, etc. The health risks are increasing with the trade of globalization, global warming, and changes with the human behavior, all which provide multiple opportunities for pathogens to colonize with the new territories and evolve into new forms of pathogens. As such, current pandemic of COVID-19 outbreak, thus far, over 15 million have been affected and over 500,000 deaths across 215 countries and territories have been reported after city of Wuhan in China. When considering world health, we knew that 60% of the pathogens that cause human disease come from animals, either domestic or wildlife, and 70% of emerging human pathogens are animal in origin. Also, 80% of pathogens that are concerned for bioterrorism in animal origin. We are working to achieve more sustainable future for our animal species. We are monitoring ecological health issues from various standpoints, including the emergence, re-emergence, and resurgence of infectious diseases. Increasing biological effects of toxic chemicals, drug residual effects on environment, habitat alterations, habitat fragmentation, defragmentation, depletion or exploitation, loss of biodiversity, alteration of ecosystem services, change of global climate, and atmospheric changes. Conservation medicine required professionals from diverse disciplines to work together in addressing the complex aspect of the intersections of health and environment. Today, we are in decline. The ecological health has been reported for all scales from global to local. Whether it's anthropogenic or natural in origin, it will affect to the living species, especially critical endangered animal species, and ultimately it will affect all the terrestrial, marine, freshwater animals and their environment. As a veterinarian, we must understand our mandate to maintain the ecological health of prevention to rate of the fast extinction of wild animals. Thank you for this giving the golden opportunity to talk, and thanks for the organizers and participants. I wish all the very best in second day of the Sri Lankan Veterinary Association scientific sessions. Thank you.
Thank you, Dr. Taraka, for this very interesting and eye-opening presentation. And now the floor is open for Q&A session. And I would like to ask a question from you first. You have vast experience in wildlife health and management in the Department of Wildlife Conservation. Throughout your career, what is the most challenging thing you have encountered as a wildlife veterinarian?
It's a very difficult question for answer that time, because we know that now the people are talking wildlife conservation, even not professionals, they are talking their beliefs. So we need to correct them in correct way. It's a very difficult task for these corrections. So the area is, the targets is become worst day by day. So mainly because of the not understanding the science.
Thank you, Dr. Taraka. Are there any questions from the audience or the virtual participants? Virtual participants can raise their questions by raising the hand, or they can also use the Q&A box to post their questions.
Yeah, Dr. Taraka, I'm Dr. Erandika, and yeah, it's very interesting, the wildlife and aquaculture speech you elaborated today in the morning. Thank you very much for that. And my question is actually, this is a very sensitive one, in the social medias and other, the papers and in all the digital medias and all, always highlighting the acts of wildlife, the way we are doing and handling the animals in wildlife as the wildlife handlers and including the veterinarians in the field. And the big question coming from the social media is that do we consider any palliative care of the animals or the animal welfare of this wildlife when we are restraining them and when we are trying to attempt the treatments under wild conditions? Do we have training for the veterinarians or other handlers who attend in these activities? What's your view on that? What's your opinion on that, Dr. Tarak, actually?
Thank you, Erandika, for the questions. Actually, you know that some government procedures, we have transfer schemes. Once we train in our stations, they have been transferred another third year, fourth year. So we have to keep on training them to handling methods and correct way of handling without getting damages or suicide. so it's a very difficult task. So when we engage in the operation, we can't use time for train them. Actually, it should be a professional attempt, and every mistake can represent a mistake of veterinarian, but not the mistake of worker. It's believed it's our mandate to keep the update the staff members, those who handle the animals. So it's a very, very challenging task, and we try to minimize this effect with negotiating the administration. Erandika, did you get my?
Yeah, thank you very much, Doctor.
Dr. Taraka, this is Erandi here. Can you hear me?
Yes, Erandi. Yes, Erandi.
Yeah, thank you for your speech. And, if we consider the past few months as vets, we had to face some unpleasant experiences related to these turtle strandings. So in your opinion, what should be our way forward as veterinarians in this area? Like we may come across similar situations in future, and we need to be geared to face these situations more confidently, and there are things that we should develop. So what should be our way forward?
Yes, Erandi, we all should know that it's a legal procedure intact with the process. So we only the category, those who attend the courts. Others are not attend the course, even courts, even the scientists from the different agencies, scientists from the chief scientist of the nominated members, scientific members. So we knew what is the court procedure, how it's began, how it's a process. So once we reporting anything, we have to say confidently the process, whole process. So here we receive even 3 to 5 days old carcasses, which we send to the tissue pathology. It says inconclusive because all tissues are decomposed. So there are some categories make a blame. There are some people make a blame that this is not professional. So we make them understand, and still we are waiting for one foreigner to visit and re-examine the case. Even he comes, he don't have permission to work and proceeding with the courts without our involvement.
Yeah, thank you, Dr. Taraka. Yeah, I really understand the legal constraints, but we all are happy to get together and work towards a better diagnosis in future for marine animals. Thank you very much.
Dr. Taraka, I am Susanta Malwar here.
Yes, Susanta. Can you hear me?
Dr. Taraka, good morning to you all.
Good morning, Arundhati.
Yeah, nice to hear you, Doctor, as a plenary speaker. Do you think that we need to go for any policy changes regarding the wildlife veterinarian sector?
We we have requested some issues of making changes.
Yes, can you please just introduce to the audience? This would be
Yeah, we have requested some changes of staff, making them available permanent for the veterinary staff. So they will be considered.
In any other aspect of wildlife welfare aspect?
Yes, the thing is, it will take time. I mean, maybe several years.
Yes, doctor.
To expected changes. I can't understand. I can't say exact course where we stuck.
Okay, doctor.
There are issues.
Thank you, doctor.
Today I would like to case report that is an occurrence of extramedullary plasmacytoma on a foot pad of a dog. The plasma cell tumors in dogs, actually the plasma cell tumors are well known in cats and dogs but uncommon in other species. Let's briefly go through what are plasma cell tumors. They originate from terminal differentiated B lymphocytes that have undergone malignant transformation. These plasma cell tumors incorporate a wide range of clinical syndromes, including multiple myeloma, solitary osseous plasmacytoma, and extramedullary plasmacytoma. A multiple myeloma is that plasma cell tumors occur in multiple bones, and solitary osseous plasmacytoma, that is when plasma cell tumors occur in single bone. And extramedullary plasmacytoma, that is occurrence of plasmacytomas in any other tissues except bones. The most common sites are trunk, limbs, head, especially ears, and also inside the internal organs, and that is in stomach, intestine, etc. So, I would like to pay your attention for a research done by Bayer et al. In 2008 on cutaneous plasmacytomas in dogs. In this table, you can clearly see most common sites for this type of tumor occurrence are digits, lips, and ears. So, when consider the age, middle age to old age animals were more susceptible for cutaneous plasmacytomas. And when consider the male-female ratio, the male animals were highly represented. So you can see this is the cutaneous plasmacytoma. You can see this is the digit in the lips and this is the ear. So just see what are plasma cells. Actually, plasma cells are the cells, they are differentiated from B lymphocytes and they are capable of producing antibodies, so immunoglobulin. So they are round cells with eccentric nuclei, and the cytoplasm is highly basophilic. And the special thing when considered plasma cell are these perinuclear halo. This perinuclear halo appearance occurs due to the Golgi apparatus, which contributes in secreting immunoglobulin. And this black arrow shows you mode cell, that is plasma cell, which is highly packed with immunoglobulin. And this is the normal view of plasma cells. When these plasma cells undergo malignant transformation, plasma cell tumors occur. So just see the morphology of plasma cell tumors. The cell morphology can vary greatly. Could be highly pleomorphic, that is different sizes of cells and different sizes of nuclei can be seen in these type of tumors. Despite the high pleomorphism, most of the time these plasma cell tumors are non-aggressive because when tumors are having high pleomorphism, most of the times they are highly aggressive. But these plasma cell tumors, most of the time, non-aggressive. So let's see our case. 8 years old male Labrador Retriever dog was brought to the veterinary surgeon's office, Rhabdomyosarcoma, with the complaint of some mass on its right falling foot pad, and the animal was a bit reluctant to put weight on that foot. So the veterinary surgeon examined the animal and decided to send this animal to veterinary investigation center for the laboratory testing. So I observed the animal, the gross lesions. It was a moderately circumscribed mass, erythematous, allopathic, and ulcerative mass. So differential diagnosis for this type of lesion, this could be due to traumatic injury and could be granuloma and neoplasia, or this may be due to immediate dermatitis. So I, after examining the animal, I did fine needle aspiration, and the aspiration matter was stain using Leishman stain, and examined under 100 power light microscope. And this is the view I saw. There were highly atypical population of brown cells, and high anisocytosis and anisokaryosis was noticed. That is, Anisocytosis means different sizes of cells, and anisokaryosis is different sizes of nuclei in those cells. And they got eccentric nuclei. Because of this appearance, they are called sometimes as signet-ring-shaped cells. And the cytoplasm was basophilic and would be able to see meganuclei, binucleation, multinucleation in this cell population. But mitotic figures rare. The differential diagnosis for these type of tumor cells, this could be due to round cell tumor, could be melanoma, or this could be an atypical lymphoma. As there's no inflammatory reactions, I decided this could be a tumor. So I just want to show you, this is a meganucleation, and this is binucleation, and this is a multinucleation, because you can see there are 3 nuclei in this cell. So after examining and doing finite aspiration, I referred this case to the Faculty of Veterinary Medicine for the teaching hospital for further investigation activities. And there, they have examined the animal and did further laboratory testings. Under these laboratory testings, the full blood count, there was no any abnormalities they have detected. When examined, observed blood smear, mildly hypochromic RBCs and a mild increase in WBCs were noticed. My WBC count was 22,500 per microliter, and in serum chemistry, we have observed normal total protein, albumin, and globulin levels. So, after getting these laboratory findings, we have decided to excise that mass. So, after they used 4% lignocaine as local anesthesia and completely surgically excised that tumor mass. And augmenting 20 milligram per kg VT for 5 days was used as post-surgical prophylactic antibiotics. And the owner was asked to restrict the movements of the animal until the surgical site completely healed. Elizabethan collar was put to prevent self-trauma, and no surgical complication from the owners. So, no recurrence or metastasis was reported in follow-ups. So, I just want to pay your attention to this slide. This is the histopathology of that tumor mass. Under high power, you can see highly atypical round cells all over there. And they have eccentric nuclei, and also this nuclei most of the time sickle cell shaped. You can see sickle cell shaped nuclei, most common. And when these plasma cells containing immunoglobulin, the cytoplasm become eosinophilic. So you can see the pink cytoplasm, dark pink cytoplasm of some plasma cells which contains immunoglobulin. These are mod cells. And this is a nucleus with multiple nucleoli. And this is a very common situation we can see in plasma cell cytoma. So this is the view. Results and discussion. All these features together with signalement, location of the lesions and cytology are highly consistent of extramedullary plasmacytoma. When the veterinary surgeon got this case, she examined the animal and directed to veterinary investigation center for testing, and there we did finite aspiration and referred to case for the veterinary teaching hospital for further testing and things. And at there they have diagnosed this and excised this at correct time. So as the diagnostic sequence was well maintained and proper tests were performed to obtain accurate diagnosis, it was able to treat the case successfully. These are our references. Thank you. Sorry, I couldn't hear anything. I think the mic is muted. I couldn't.
Yeah, if I raise my question again, when you come across this clinical presentations of these local tumors, you mentioned in your differential diagnosis that immune-mediated dermatitis conditions also as well. So at a glance, how do you differentiate this, whether this is a tumor or immune-mediated reactions in the body? Like, is there any clue in your abstract for that? Or in your
When we physically examination animal, there was no pain. The first thing is when examine no pain. If there's an inflammation, we could see especially the pain and things, and the external appearance. It was a big pink color one, and very demarcated mass. So because of those things, I differentiate this would be a neoplastic mass.
So you did the diagnosis of this neoplasm actually through impression smear, or you did some biopsies?
I first did fine needle aspiration at Veterinary Investigation Center. After that, I referred the case to teaching hospital. At there, they have done the excised and did all the histopathological examination. By that, get to the confirmation that this is a plasmacytoma.
Yeah. I have one final question. In your blood chemistry, you have mentioned that you detected albumin and globulin, levels in blood. What is the relationship with that test into this? What is the indication of doing that test for this cancer condition actually?
Because if this is a multiple tumor, the immunoglobulin level can be increased and the total protein level can be slightly increased. But at this time, it was normal protein level, the albumin globulin ratio. So because of that, we can say that it is a solitary tumor, not a malignant one, because the protein levels are not increased.
So you mean malignant tumors in the blood picture, you get high protein levels? Is it? Is it a demarcation? I mean, a significant finding? Understanding with that.
When if there's a
in a malignant patient, within the blood picture, the protein level is going high.
I'm considering that plasmacytomas. It's when consider multiple myeloma, it's also a type of plasmacytoma, and plasma cells that secrete in immunoglobulin and things. In multiple myeloma, such things, the globulin level can be increased.
So differentiate that this is from multiple myeloma and extramedullary plasmacytoma, and differentiate this is a solitary one. We examine these total protein levels.
I have one more question here. You said that this is surgery was done at the local anesthesia, is it?
Sorry, I couldn't hear.
Is this surgery done under local anesthesia?
Local anesthesia, yes.
What was the reason to choose local anesthesia? How did you get the margins there, the depth and the sideway margins in this particular tumor?
Yeah, because the tumor margins are very demarcated. So they examine the animal and get some X-rays to see whether there are some bone tumors in the bones. But when examining the four limb bones, the X-ray, there was no, the intact bone was there. There's no any sponge out holes or anything. So we decided this is some localized thing, and it was, as there's demarcated margins, decided to give local anesthesia and remove the tumor mass. It was easily removed.
What was the demarcation like marked? Like, is it 1 centimeter, 2 centimeters? Like, was there a particular margin that you have?
2 centimeter.
2 centimeter margin.
Yeah.
Okay. Thank you.
Thank you.
I have one question. It seems that you diagnose this disease based on the histopathological findings. So what is the confirmatory test that you have to do to confirm the diagnosis? Because according to your conclusion, it seems most likely diagnosis.
We can use immunohistochemistry by doing the MUM1 test. We can confirm this is the plasmacytoma.
So you cannot confirm this as a plasmacytoma tumor, no? Is that right?
When examine histopathology, actually, when we observe the margins, we were able to see clearly. We were able to see the plasma cells in this histopathological margin. So, based of those things, also we confirm that this is a plasmacytoma.
Okay. Let's go to the second presentation. Clinical pathological diversity of canine oral cavity tumors, a retrospective study by SACH Rodrigo, PGAS Pallekumbura, W. Jayavira, G. SPD S. Gunawardana, and PR MKK Vijayasundar.
My name is Chatri Rodrigo. I'm currently working as a temporary lecturer at the Department of Veterinary Pathology in Faculty of Veterinary Medicine and Animal Science, University of Peradeniya. So today, I'm going to deliver a presentation about one of the most important clinical aspects of the small animal practice. So before starting the presentation, I would like to bring your kind attention to a few pictures. If you clearly observe these patients, you can see that all of them are having some kind of a mass in their oral cavity. All of these masses you see here are oral tumors. So today, I'm going to present some interesting findings about these tumors which occurs in oral cavities of dogs. So the topic of my study is clinical pathological diversity of canine oral cavity tumors, a retrospective study. Oral cavity tumors represents around 5% of all neoplasia in dogs. It is a common clinical condition among the dogs in Sri Lanka. However, diversity of canine oral cavity tumors in Sri Lanka is largely unknown. Therefore, a thorough knowledge on oral cavity tumors of dogs is essential for veterinarians for effective early diagnosis and proper treatment approach of the condition. So the objective was to evaluate the demographic data and clinical pathological features of oral cavity tumors in dogs in Sri Lanka. So let's look at the materials and methods of this study. The data was collected from biopsy reports of 30 oral cavity tumors. These tumors were received by Histopathology laboratory of the Department of Veterinary Pathology over a 2-year period. We analyzed the age, breed, sex, clinical signs, location, gross and histopathology of oral cavity tumors. Not all masses which occur in oral cavity are cancerous. Some of the masses are inflammatory and hyperplastic conditions. So these masses which are inflammatory and hyperplastic were not included in this study. So let's look at the results of this study. When we analyzed the breeds of dogs, we observed crossbred as the most frequently reported breed. Among the pure breeds, German Shepherd were the most common pure breed, followed by Labrador, Great Dane, Ridgeback, and Rottweiler. So the age of these dogs were categorized under 3 categories. Around 50% of the dogs belong to 9 to 12 age category. These are the common clinical signs we observed in these dogs: facial swelling or asymmetry, hypersalivation, bloody oral discharge, and halitosis. So there were some other clinical signs as well: dysphagia, displacement or loss of teeth, weight loss, regional lymphadenopathy. When we talk about the location of these tumors, we observed 6 common locations of tumors within the oral cavity, such as gingiva, lips, palate, salivary glands, tongue, and buccal mucosa. So if you look at this table, you can clearly see most tumors had occurred in gingiva. The size of the tumors were classified according to the WHO guidelines on classifying the size of the tumor. So if the greatest diameter of a tumor exceeds 2 centimeters, it is a T1 tumor. If the greatest diameter is within 2 to 4 centimeters, it is a T2 tumor. And if the greatest diameter exceeds 4 centimeters, it is T3 tumor. So if you look at this table, you can clearly see most of the tumors were belonging to the T2 category. Of 30 tumors diagnosed, the majority of the oral tumors were classified as malignant tumors, whereas the rest were benign tumors. So among these malignant tumors, melanoma was the most common malignant tumor, followed by squamous cell carcinoma and fibrosarcoma. Of 14 benign tumors, there were 7 odontogenic tumors. Peripheral odontogenic fibroma was the most commonly encountering tumor in this category. Fibroma, amyloblastoma, amyloblastic fibroma were the other odontogenic tumors. So this table summarizes all the tumors that we observed in these dogs. And if you look at melanoma, you can see 4 of the melanomas occur in maxillary gingiva, and 3 of them had occurred on the lips, and 1 had occurred on buccal mucosa. So this table summarizes all the information that we gathered by carrying out this study. So male was the commonly affected sex. Crossbred was the highly affected breed, whereas the German Shepherd was highly affected pure breed. The mean age of oral cavity tumor diagnosis was 7.1 years. Facial swelling, asymmetry, hypersalivation, and bloody oral discharges were the most common clinical signs that these dogs were showing. Gingiva is the most common location of tumors, whereas highly reported size was the 2 to 4 centimeters. Irregular shape, bleeding, ulcerated surface, and broad attachment to the point of origin were the common gross lesion of these tumors. So the melanoma was the most common malignant tumor, whereas the peripheral odontogenic fibroma is the most common benign tumor. So before moving to the discussion of this study, I would like to quickly go through some of the gross and histopathological photographs of these tumors. So as I said before, melanoma is the most common malignant tumor. As you can see here in the gross picture, this tumor consistency is firm, but necrosis or secondary infection can cause softening. The majority grow as sessile masses, but some may be pedunculated. And if you look at the histopathological photographs of this tumor, you can clearly see they are very cellular tumors. And under the high magnification, you can see neoplastic melanocytes contain the melanin pigment granule. And when we talk about the squamous cell carcinoma, it is the second most common malignant tumor. So as most oral squamous cell carcinomas in domestic animals are advanced when first diagnosed, they most often present as ulcerated, raised masses that infiltrate surrounding tissues. Histopathologically, we can see keratin pearls, which is a peculiar feature of this tumor. Keratin pearls are the keratinized structure found in regions where abnormal squamous cells form concentric layers. When we talk about the fibrosarcoma, it is the third most common malignant tumor in the oral cavity. So fibrosarcomas are usually solitary, pale lesions that compared to the other oral malignancies. They are less likely to be ulcerated, typically infiltrative with destruction of surrounding tissue. And when you examine these fibrosarcomas under the microscope, you can clearly see poorly differentiated spindle-shaped cells separated by a collagenous matrix. Let's look at some of the benign tumors as well. Peripheral odontogenic fibroma is the most common odontogenic fibroma. These tumors are large pale pink masses which are usually non-ulcerated. Tumors usually develop in the rostral maxilla and recurrence after surgical excision is rare. So the majority of peripheral odontogenic fibroma is connective tissue that consists of delicate fibrillar collagen of varying density and evenly spaced stellate cells. Larger blood vessels can also be observed under the microscope. And when we talk about the ameloblastomas, they usually appear as poorly defined swelling behind the mandibular incisors. Under the microscope, we can see islands of odontogenic epithelium that are arranged in a follicular pattern with a prominent palisading of the bacillar cells. Overall, these findings emphasize the necessity of improving awareness on oral cavity tumors among veterinarians. Oral cavity tumors often remain unidentified as the oral cavity is not regularly checked by the owner. Therefore, the owners must be vigilant about the occurrence of above clinical signs and gross features so early identification can be done. Further studies must be conducted to carry out the effect of sex, age, and breed predisposition on occurrence of oral cavity tumors. Thank you.
Paper is open for discussion. There is one question from Dr. Sugat.
Thank you, Dr. Rodrigo. It's a nice presentation. You mentioned there were 4 types of oral tumors. Did you try with any treatment options? Because that is the very important one for as a veterinarian. If there is any information about the treatment options.
Yes, thank you for your kind compliments as well. So if we talk about the treatment options, that we actually cannot give a direct answer. That totally depends on the whether they are malignant or benign, and the location, and how advanced the tumor is. So most commonly these tumors, they respond well for, some of the tumors respond well for wide margin surgical excision. And there may be, I don't know whether they are being used in Sri Lanka, radiation therapy, chemotherapy, electrochemotherapy. There are some advanced treatment options as well. So most commonly what we do here is we just do the wide margin surgical excision, and most of the tumors do respond very well. So I think, and sometimes you'll have to go, when you do the surgical excision, you'll have to go for removal of the bones, such as partial mandibulectomy. Yeah, so those are some kind of treatment options that I suggest.
Thank you. No, I mean, can you go to the slide, please? Yeah, from the judge's panel to have a permission. Shall we go to the slide that? No? Okay. The tumor in the oral cavity, it's which we cannot remove by surgically. Can we try with doxorubicin or something?
Yes, I have heard there are some medical treatments as well, like carboplatin, pyroxicam. So I referred some of the papers, and they have mentioned these drugs can be used, but I have no deep knowledge on that, I should say.
Okay, thank you.
One more question is allowed.
Madam, I didn't get your question. I didn't clearly hear that.
Suranj, can I ask the question was of Dr. Suranj actually, what is the common cause for all of these tumors up to your opinion? Yeah.
Yes, when we talk about the causes, it's also I mean, it's very advanced. There may be genetic factors playing a huge role, and heredity, environmental factors may be playing a role, and we cannot give actually a direct reason for all these tumors, and male dogs show a greater risk than females, but the reason has not been identified yet. So I think overall I can say that genetic, heredity, environment, maybe diet, and being a male or female dog, I mean, male dogs show a greater risk. So I think those are the reasons, but a direct answer cannot be given as a reason.
Yeah, I have one last question, Dr. Chaturga. Actually, you know, I mean, when we are in the clinics, we get a lot of clinical presentations of these oral tumors, and we sometimes surgically remove them, and we get relapses, you know, I mean, in most of the time. So you have, in your study, did you go through any, you know, on what kind of tumor, you know, when a melanoma, or, I mean, this other category of tumors you have this categorized in your study? What type of tumors you get most of the time relapses when you do attempts surgical, you know, removal of such tumors? Did you study in that area, you know, in your study?
Yes.
When you get relapsed?
Yeah. As the title of this study says that we did this as a retrospective study. So we extracted data from the already existing files with us. So some of these data about their metastatic information and relapses were not there actually. So what we did was we gathered the already existing data. So we are planning to do this study in a good manner with not as a retrospective study actually. So I think I would like to put more stress on that aspect as well when I'm going to do it in the future.
Okay, thank you.
No, thank you. So let's
Thank you
move
very
on to
much.
the third presentation. An aberrant movement of a gunshot pellet in a dog, a case report. PGAS Pallekumbura, SACH Rodrigo, RMTM Ramanayaka, GSPD S Gunardana, and PRMKK Vijayasundara.
Hello everyone. I'll begin like this. I think you all are aware that companion animal death due to gunshot injuries has increased as a major public concern in our country. Recently, we heard large number of cases about gunshot deaths in dogs. Today, I will be discussing a similar case, and the topic is an aberrant movement of a gunshot pellet in a dog. I am Ajane Palkumbra, Faculty of Veterinary Medicine and Animal Science, University of Peradeniya. First, I'll begin by giving you a brief description about gunshot injuries. Gunshot injuries are considered as projectile or penetrating type of injury. Out of the traumatic injuries, in veterinary medicine, gunshot injuries represent small percentage. The form and the size of the wound usually depend on the projectile type, velocity at the impact, and the type of organ affected. The most vulnerable areas of a dog will be head and the trunk, and it will result in massive organ destruction and also hemorrhage. Because of that, immediate treatment is a must. Another important factor for veterinarians is the detection of the entry wound as well as the exit wound. Imagine if there is no exit wound, then we have to suspect whether this gunshot has trapped inside the body or inside an organ, or it could harm internal organs. Then we have to act accordingly. Okay, let's move to the case history. The canine Tumor crossbred 3-year-old dog has been shot by an air rifle at its immediate neighborhood. Then the owners brought the animal immediately to the veterinary hospital. Unfortunately, the dog has lost large amount of blood. Therefore, the dog died within 30 minutes before any medical intervention was done. Then the owner has requested the post-mortem examination upon legal aspects. Therefore, they sent the carcass to our laboratory. We performed a detailed post-mortem examination. Now I'll reveal interesting points that we observed that would help you to handle similar cases in future. Upon external examination, we detect pale mucous membranes. It is indicated in this figure as well. And another important factor is we observe bright blood stain on the fur coat, especially more confined to the cranial region of the animal. And we were able to detect an entrance wound. It was about 0.5 centimeter in diameter. It is very well focal and well demarcated hole. Interestingly, we couldn't find any exit wound. Therefore, we suspected the pellet should be entrapped or might lodged in somewhere in the body. Therefore, we explore more deeper and cut along the musculature around the entrance wound. In the musculature, we were able to detect a large number of bruises and also large amount of blood clots. Following that, we observed severe jugular vein, actually the right jugular vein. Then we suspected the massive external hemorrhage, which I mentioned in the history, could have occurred because of the rupture of the jugular vein. So bullet might have traveled to the jugular vein and caused rupture of the jugular vein. Then we open up the thoracic cavity. In the third intercostal muscle, we were able to detect a focal, well-demarcated piercing wound. And we thought the pellet have migrated to the musculature and has entered to the thoracic cavity via third intercostal muscle. Apart from the hemothorax, it is a mild hemothorax, we couldn't find any significant lesions in the heart and lung. Okay, it was surprising, but there was no detectable or significant lesions in the thoracic organs. Therefore, we suspect it had moved to the abdomen. Therefore, we examined the diaphragm very carefully. Again, we detected a piercing wound, a well-demarcated focal piercing wound on the membranous part of the diaphragm, and it was more towards the right side of the diaphragm. Then we open up the abdominal cavity, and again, we observed a liver rupture on the diaphragmatic surface of the right lateral lobe of the liver. You can see the liver rupture in this photograph as well. Okay. Then we examined the abdominal organs, but we couldn't detect any significant lesion or an hemorrhage. And upon careful examination, we found the metal pellet, which is trapped inside the mesenteries. So here you can see the metal pellet has trapped inside the mesenteries. This is an enlarged photo of this photograph. So you can see the metal pellet has trapped inside the mesentery. So this is the final blockage of the mesentery, of the metal pellet. So this is the metal pellet after removing from the mesenteries, and it was about 4.45 centimeter diameter. Okay. So the migratory pathway of the pellet, let's discuss it. Initially, the pellet entered to the body through the right thoracic region, and its trajectory penetrated the right jugular vein, causing the massive hemorrhage, which I mentioned in the history. Then it had penetrated the right biceps and the right pectoral muscle. After moving around the musculature, it entered the thoracic cavity via the third intercostal muscle, and without causing any damage to the thoracic organ, it perforated the diaphragm and entered into the abdomen. Then it moved along the liver, causing a liver rupture, and finally trapped in the mesenteries. So this is the migratory pathway, quite interesting. There were no much abnormalities in the internal organs. Even though there was no significant lesions in the internal organs, there was a massive hemorrhage from the severed right jugular vein. So the cause of death is hypovolemic shock because of loss of large volume of blood and resultant multi-organ failure. So the take-home message, as vets, We know it's a medical emergency. Important factor is to control the hemorrhage, and detection of the entrance wound and the exit wound is a very important step of the treatment process. If there is no exit wound, if there is an exit wound, in both of times, we have to use imaging facilities. If available, always try to use the imaging facilities to assess the severity of the damage inside the organs. Then we can proceed in a very efficient manner. And the surgical intervention for penetrating abdominal wound is a must. As owners, also, they must apply pressure to minimize the hemorrhage or simply the bleeding and seek the veterinary care immediately. I hope this case would provide you valuable ideas. If you happen to, I hope you should not able to handle this kind of a case, but if you happen to handle this kind of case, I hope this would give you a valuable insight. Thank you very much.
Thank you. And the paper is open for discussion. Can I ask the first question? Now, after the death, before the postmortem, have you all done any x-rays just to find out where the blood is?
No, the dog died just after arriving to the hospital. So they didn't have any time to do any medical intervention. So they haven't done any x-ray. So they directly send the carcass to the postmortem.
If you just did the x-ray for your interest, if they've got some idea because it's a dead dog, but it's an interesting case.
Yes, thank you.
Yeah, doctor, actually the Palakumara, actually my question is, what is the clinical significance of this, findings? We know as a, it's a common thing that we get gunshot injuries in a lot of dogs and, finding the cracks and, it's in a postmortem is good, but, in a clinical value, when you treat the dogs, and anyway, the bullet will go, somewhere in the body, it pierces in a lot of organs, we can't say that this organ is damaged and that organ is damaged and tracking the pathways. Exactly. Like it's a common thing, get a gunshot injury, it piercing and you can't detect, predict the way it runs, in each and every case is different. When you get a lot of postmortems, you will find a lot of pathways. What is the clinical impact of this, paper for the, as a clinician, what do you get out of this thing? Anyway, it's a clinical emergency, right?
Yes. I want to emphasize that if we do the X-ray, sometimes we might able to not detect any harmful effects in the internal organs. However, because of the severe jugular vein, there is a lot of external hemorrhage. That's why I needed to emphasize, even though there is no much internal damage, other than that, we have to check for the hemorrhage and everything, because hemorrhage is an important part when there is managing a case like this, because there would be internal and external hemorrhages as well. Sometimes because of the time gaps after after getting the shot, maybe owners did not detect the external hemorrhage. That's why I wanted to emphasize that fact in this case.
And you mentioned about this, the mucosa of the dog was very pale. That is in antemortem condition or at your postmortem condition?
Definitely, it should be an antemortem because of the hemorrhage.
And you did the x-rays, you did only one x-ray or a couple of x-rays?
No, they haven't done any x-rays because any medical interventions hadn't been done, because just after arriving, dog died. So they directly then send the carcass to our laboratory to do the postmortem.
No, you have in your slide in an x-ray picture of the dog.
No, actually I just kept the picture and I mentioned the link as well that I got the x-ray.
No, that this X-ray belongs to the same dog or some other dog?
No, some other dog.
Ah, okay. Thank you very much.
Yeah, one more question. Can I ask?
Yeah.
So this is so the postmortem was done at the request of the owners or any legal issues?
The owners requested the postmortem, and the police also came because they have filed a complaint in the police as well. So therefore, upon legal aspects, we had to perform the postmortem.
Thank you.
All right. Thank you, Dr. Parakumbra. So we will next move to the fourth presentation in this clinical session. The next presentation is on transmissible venereal tumor in 4-month-old puppy, a case report by IKL Ishara, HRE Ratna, and EMKA Tiragaratna. Screen is yours.
Hello, everyone. I'm going to present a case of transmissible venereal tumor in a 4-month-old puppy. These are the contents of my presentation. First, I would like to give an introduction on canine transmissible venereal tumor, TVT. This is the only type of contagious tumor in dogs, and the mode of transmission is by tumor cell transplantation during coitus, licking, and sniffing infected genitals. The most common presentation we see every day is TVT in external genital organs. And less commonly, we see cutaneous, nasal, ocular, oral, and tumor in anal mucosa as well. The prevalence is highest in sexually mature dogs, and the diagnosis is best obtained by cytology using impression smears or fine needle aspirates. If we talk about treatment of TVT, vincristine sulfate IV injection is the most effective treatment, but there are side effects such as myelosuppression, leukopenia, gastrointestinal effects, vomiting, and peripheral neuropathy. The other treatment options also available, such as excisional surgery, radiotherapy, and immunotherapy. So TVT in puppies is extremely rare, and a pup can acquire the disease from its mother during nursing or suckling. So this is an example of a study which was done in Ethiopia, and it shows the number of cases they have found according to the age of the dogs. So if you see the number of cases are highest between the age of 1 to 5 years, the reason being they are more sexually active in this age. And if you see the number of cases less than 1 year old is 0. So this case is of a puppy called Chia. It was a crossbred female intact puppy of 4 months old. And the complaint was a cutaneous mass growing immediately caudal to the right commissure of the oral cavity. So it kept increase in size. And the puppy was presented to a shelter. The clinical examination revealed a lobulated, firm, non-ulcerated cutaneous mass. The size was roughly 2 centimeter by 2.5 centimeter in size, and it was just caudal to the right oral commissure. There was no pain on palpation. Following differential diagnoses were made: excessive granulation tissue secondary to injury, insect bite reaction, and foreign body granuloma. So it was empirically treated with antibiotics, cephalexin, and meloxicam as an anti-inflammatory for 1 week. But there was no improvement, and the mass kept increase in size. So we decided to surgically remove the mass and obtain a histopathological diagnosis. So the surgery was done under general anesthesia. This image is taken immediately before the surgery. So these are the images from histopathology. The first one is this image taken under the power of 10, low power image. So it shows pseudo-encapsulated and lobulated mass. So by the arrows, we have marked the connective showing that the tumor was separated from rest of the tissue by this connective tissue and lobulation here. And if you see carefully, there are round neoplastic cells forming small packets here. And there were no epidermal hyperplasia or vita ridges formation. And the tumor was located deep in the dermis. This is an image under the power of 40. It shows features of cells, eccentric nuclei, prominent single nucleoli, lightly basophilic cytoplasm with cytoplasmic vacuoles. So actually, we could not obtain more clear images under the power of 100 because of the oil emulsion. We couldn't take clear photos. So there were no cytoplasmic granules, no binucleated or multinucleated cells. This is again an image taken under the power of 40. And if you see, it's marked by the arrows, multifocal lymphoid aggregates. They were also seen. So these features are most consistent with round cell tumor, which is TVT. And the other differentials included such as histiocytoma, lymphoma, muscle tumor, and plasma cell tumor. So if it's a histiocytoma, there should be vita ridges formation, binucleated or multinucleated cells. And if it was a lymphoma, the cells should be brown and there should be a centrally placed nuclei, and the cytoplasm should be dark basophilic. And also there should be cytoplasmic granules if it was a mast cell tumor. And plasma cell tumors are really uncommon in young dogs, and they should have perinuclear halo and dark basophilic cytoplasm like those characteristics. So the tumor was surgically excised with clean margins, and it was confirmed by histopathology. And the surgery wound recovered with no complications and healed quite well, if you see this image. And there was no tumor recurrence until present. Later, it was revealed that this puppy was fostered by a bitch with a vaginal TVT from the age of 10 days until weaning. So this is where the pup acquired the tumor from its foster mother. So before I conclude the presentation, I would like to discuss these points. So we know that neoplastic conditions are extremely rare in puppies, but it's important to include TVT as a differential diagnosis for such similar situations, especially in shelter conditions. You don't know the history of the puppy properly. So it's important for such cases to always include TVT as a differential diagnosis. And cytology is the best method to diagnose TVT. Unfortunately, we could not perform cytology for this case under the prevailing conditions at the sheltered or states. If we talk about the treatment for TVT in puppies, we could not find any adequate records on use of vincristine in such growing puppies. So if you consider the side effects of the drug, so it's doubtful whether it's suitable to use vincristine on young dogs or not. So further research is definitely needed to identify an effective and safe treatment approach for such cases, TVTs in really young puppies. I would like to thank my staff at workplace for supporting and helping me out in this case and for diagnosis. These are my references, and thank you.
All right, thank you, Ishara. It's a good presentation. I hope you are joining in online. This is open for now for the questions. Online audience, you can raise a question or you can drop it in the chat box. Ishara, so this is a bit tricky question from me, but I'm sure you can answer this very easily. Can you just explain how this close interaction with this sort of tumors get affected the animals? What is the mechanism behind that?
Yeah, so what happens is these tumors, they happen, the tumor cells transplant from one animal to another animal through mainly through a mucosal contact. So that's how the tumor transfer from one animal to another.
All right. And what are the other common sites you have seen among this young population? Other than this, you have seen this in the mouth, mucosal in the mouth. So other than that, what are the common places you have come across?
Yeah, so I have seen many cases of nasal TVTs and cutaneous ones. I think most common being the nasal one. Yes, those are the two I have encountered other than this case.
All right. Okay. Thank you. This is the last one from my side. So if you have seen, for example, if you've seen such an interaction with the bitch, with this pup, what are the things we have to as quick actions, like how fast we have to attend this sort of interactions or contact with this sort of tumors?
Yes.
What are the necessary actions you can get it out?
Yeah, so the ideal situation is we have to stop interacting with such puppies with an infected bitch. But unfortunately, the situation and to save the life of the puppies, we could not separate the mom from the puppies. So ideal situation, we definitely have to separate the puppy. If not, we have to take measures to at least to cover the vaginal TVT if it's possible. Yeah.
Any questions from audience?
Thank you, Ishara, for the. Can you hear me?
Yes, I can hear you.
Yeah. Now you have now this puppy was nursed by a TVT affected bitch,
yes,
right? In the shelter.
Yes. Yes.
So,
yes.
Didn't you treat the mother, foster mother?
Yes, madam. She was treated after the period. She finished the lactation. So we did not want to treat the mom as she has been nursing her puppies. So only after weaning, we did the treatments for the mom.
Okay. So when did you notice this TVT in the mother, foster mother?
It was actually on arrival. She was pregnant on arrival. And then she delivered the puppies with the cesarean section.
Right. Then how long did you wait till the treatment is initiated?
We waited until the puppies were like 8 weeks old, 6 to 8 weeks we waited. Yeah, we had to wait.
Okay, so her own puppies were also nursed by the same mother?
Yes, yes. So she had her own set of puppies and we had to introduce another set of rescued puppies, which were like 10 days old, really small, and they were difficult to hand feed. So we had to introduce the second set of puppies to this mom as well, unfortunately.
Okay, so the other puppies were not affected?
No, this is the only case. So out of, I think, madam, we had maybe 10 puppies, only one puppy got infected.
Okay, all right. Thank you.
Thank you, madam.
Yeah, thank you, Niransha, madam, for raising questions, and Ishara for good interaction with that answering questions. If there is no questions, we will give a big thanks for Dr. Ishara. Thank you very much. So we will move to the fifth presentation in these clinical sessions. This will, it's about the intestinal lipogranulomatosis lymphangitis in a German Shepherd dog. This is also a case report done by GADKK Gunatilaka, HDS Hevapatirana, S. Kabilan, MGTM Prasadini, TMSK Piyadasa, DDND Silva, and H. Ariratna. So the screen is yours, Dr. Gunatilaka.
Hello everyone. Today I am going to discuss about intestinal lipogranulomatosis lymphangitis in dogs. In my presentation, I'll focus on a case which was a German Shepherd dog presented to the VTH recently. First of all, let's see what is the intestinal lipogranulomatosis lymphangitis or ILL. It is a rare inflammatory disease of the intestinal lymphatic vessels and surrounding tissues within the intestinal wall, serosa, and mesentery. Typically, they are discrete 5 to 10 millimeter sized nodules among the serosal and mesenteric lymphatics. They are caused by chronic leakage of lipid-rich chyle and rupture of lymphatic vessels with subsequent foreign body type reactions. They can occur concurrently with lymphangiectasia and hypoproteinemia. Intestinal lymphangiectasia is a rare protein-losing gastroenteropathy characterized by dilatation of the intestinal lymphatics and loss of lymph fluid into the GI tract. This leads to development of hypoproteinemia, edema, lymphocytopenia, hypogammaglobulinemia, and immunologic anomalies. This occurs among several species, including dogs and humans. Generally, we can diagnose this condition by using different diagnostic aids. If the clinical signs and lesions are related to the rectal area, sometimes we can palpate those lesions by perectal palpation. When lesions present in small intestines or proximal part of the large intestines can visualize by radiographs and ultrasound images. Usually in ultrasound images can observe hypoechoic mucosal striations in intestines. But the evaluation of histopathology is the gold standard method. Here we use excisional biopsies. The gross appearance of the lipogranulomas are typically disseminated small masses on the serosa and surrounding lymphatic vessels. In histopathology sections, they contain epithelioid macrophages, multinucleated giant cells, and cholesterol. Let's move on to our case. It was a German Shepherd, 1-year-old female dog. At the first visit, the complaints and clinical signs were dyschezia or constipation associated with a defective reflex for defecation, tenesmus during defecation, and hematogenesia for 2 weeks. While general clinical examination, all vital parameters remain normal. During perectal palpation, the dog showed signs of pain and firm variably sized nodules were palpated. All the biohematological parameters within normal ranges. And also we took an X-ray to visualize the nodular lesions in the rectum, but it was not successful as there were no abnormality found. According to the all GCE and diagnostic results, we tentatively diagnosed the condition as inflammatory polyps and treated with prednisolone anti-inflammatory doses and clomiphene for facilitate the movement of fecal material. In the second visit, it is after 2 weeks, we were able to notice that the lesions remain as previous and the clinical signs also still there except hematochezia. So we all decided to surgically remove those nodules. There we took some excisional biopsies and we checked histopathology sections. These are the histopathological findings. In these two pictures, you can see granulomas. The circled areas are the approximate margins of the granulomas. In the center of the granulomas, you can see amorphous dark color materials. These materials can be dead materials, dead cells, or calcified areas. In the first picture, granuloma is spanning in the submucosa of the rectum. And the second picture, you can see pink color areas which comprise smooth muscle fibers that indicates the presence of granuloma in the muscularis mucosa of the rectum. These are the high power fields. Usually the granulomas consist of central amorphous fibrillar basophilic materials and they are surrounded by foamy macrophages and multinucleated giant cells. The first picture arrows shows multinucleated giant cells and the second picture the arrow shows individual macrophages. And other than that, you can see some of the inflammatory cells all around the slide. Most of them are neutrophils and lymphocytes. These two pictures are also low power fields. In the first picture, you can see distended submucosal lymphatics. And the second picture, the black color circled area is the lymphatic aggregate, and the other two red color circled areas are the granulomas. However, the prognosis of the patients depends on the early diagnosis and the distribution of the nodules. In our case, according to the extensive distribution of nodules observed during the surgery and inability to complete removal of them, the prognosis was poor. Animal died 3 weeks after the surgery, and the cause of leakage of chyle was in obscure. Then we'll move on to the discussion part. Gross and histopathological features of the present case were consistent with previous reports of ILL in dogs. However, this case differed from the previous reports on following aspects. According to the literature, hypoalbuminemia was reported in most of the previous cases, but in our case, the total protein and albumin levels are within normal limits. And also the nodules are not adequately visible in the radiographs we took. And the literature said that the median age of the dogs affected by intestinal lipogranulomatous lymphangitis is 6.9 years. It ranges 3 to 10 years. However, the dog in the present case was only 1 year old. The conclusion is the present case suggests considering intestinal lipogranulomatous lymphangitis as a possible differential diagnosis for dogs with intestinal mass lesions. This is the end of my presentation. Thank you.
Thank you very much, Dr. Gunathilaka. So I hope you are joining with us online. So the audience is open for the questions. Any questions from the online participants or the panel of judges?
Yeah, Dr. Gunathilaka, thank you very much for your presentation. And yeah, when you have this type of, clinical presentations in your vicinity as the vet, and I mean, usually it is, in this lymphadenitis like lesions, it generally occurs in all over the intestine sometimes. So when you do the surgeries in intestinal things, most of the times the prognosis is very poor, due to leakage of, afterwards the surgery. And so rather than doing surgery, do you have an opinion to have some chemotherapy, procedures that we can follow? And you have any literature review done on this, in this kind of aspect? Because this is very, very common in human field of, medicines, like they are doing a lot of chemotherapy procedures in humans. We are getting these lymphadenitis patients, rather than going for surgical attempts. You have any idea about that, doctor?
Actually, we didn't go for that. We'll try with anti-inflammatory process of prednisolone, but it didn't successful. So we go for the surgery. I'm actually not familiar about that chemotherapy part.
Questions before the surgery, did you get the biopsy and do some histopathological investigations before deciding to have a surgery?
Actually, according to the location, we couldn't get the biopsy samples and FNA samples, but we took some impression smears but there was no significant findings.
Okay, what's the reason for hematochezia at the very beginning, Dr. Gunatilaka? Because it initially was there, but later on with the treatment, it was disappeared. What could be the reason for hematochezia? Is that a common with ILL?
Yes, initially, according to the literature, most of the cases, most of the animals had diarrhea, but in this case, the cases presented to us, there was constipation. The chronic irritation may be caused to the hematochezia, but after the treatments with prednisolone, maybe it may help to reduce the inflammation and irritation. So that would be the case for the cause for the reduce the hematochezia.
All right, Krishni. So there is a question from a chat box. So I will get it from Dr. Anupama. The red highlighted nodules were normal lymphatic aggregates in the mucosa, or were they in the granulomatous area?
Sorry,
so I will repeat the question again, Krishni. So the red highlighted nodules were normal lymphatic aggregates in the mucosa, or were they in the granulomatous area?
The pink color circled area is the lymphatic aggregate, and the lower well demarcated areas are the granulomas, but all over the section there were inflammatory cells like aggregates.
Okay. All right. So any other special breeds predisposed for this sort of tumor type? Any breed specifications for this sort of condition?
Actually, I think further studies are needed to confirm that.
All right. Okay. So no problem with that. So if there is no question, so we will.
Yeah, I mean, one last question, and you use endoscopic, procedures to detect these kind of, lesions in the faculty.
Sometimes we use endoscopy, but not frequently.
Oh, okay.
Any other questions? All right. Thank you, Dr. Gunatilaka, for joining with us today. Thank you very much. So we will move to the sixth presentation in a clinical session today. This is going to present by EMU Disanayaka, but about the management of fractures in a ruminant in a field setting using external coaptations. Dr. Disanayaka, the screen is yours.
Today, I am going to share one of my field experience of management of fractures in ruminants in field setting using external coaptation. As you know, limb fractures are common in farm animals, are most commonly found in young stock. Most common fractures are metacarpus and metatarsus, approximately 50% of the fractures. Tibia, approximately 12% of the fractures. Radius and ulna, approximately 7%. Humerus, less than 5%. Femur, uncommon. Fractures are classified by severity such as incomplete, complete, comminuted, and segmental. Incomplete fractures are fractures through only one cortex. Complete fractures, fractures through both cortices. Comminuted, we can see multiple fragments. In segmental fractures, we can see 2 or more separated fractures. External coaptation is a versatile method for rigid immobilization of long bone fractures in ruminants. It includes the use of cast, splints, bandages, or slings to help stabilize fractures or luxations. Benefits of the proper external coaptations are minimal damage to soft tissues and blood supply at the fracture site. Cheaper and easy to do. Does not need specialized equipment. The decision to treat a fracture in a ruminant is depend on cost of the treatment, location and type of fracture, economic and genetic value of the animal. Here in this external coaptation can be used in different clinical scenarios because the cost is lower and can be handled in a field setting. So my objectives were applying splint and POP cast together as a versatile method to rigid immobilization of long bone fractures of ruminants. Find an inexpensive, successful method for long bone fractures in ruminants. Two cows and 2 goats were involved in the study. Case number 1, bovine Jersey female, 2 years old, and approximate body weight was 350 kilograms, closed, completely fractured, right side femur just above the patella. In case number 2, bovine Jersey Friesian crossbreed animal, female, 4 years old, 400 kilogram body weight, closed, complete fracture of both tibia, fibula in left limb. Case number 3, caprine Jamnapari female, 2 years old, 35 kilogram body weight, closed, complete fracture of both tibia, fibula in left limb. Case number 4, caprine Jamnapari female, 1 year old, 25 kilogram body weight, closed, complete fracture of both ulnar radius in left limb. What I did was, wooden splint was used to provide external coaptation for temporary stabilization of the fracture. Wooden planks were covered with cotton wool, then kept the fracture bones in a satisfactory alignment. 4 wooden planks were placed in 90 degrees in parallel, dorsal, medial, and lateral aspect of the limb. Padded bandage was placed in position the splints. Plaster of Paris were applied over it. This method was applied in all the cases. Here you can see the splints. Wooden planks should extend to a level immediately distal to the sole of the hoof. Planks were covered with cotton wool. Wooden planks placed in 90 degrees in parallel and tied planks together using plasters, so we can use pieces of cloth. Here you can see clearly how I kept these wooden planks and tied up. Padded bandage was placed to position the splints. Here. This is a photograph of applying POP cast in case number 1. Here in case number 3 after applying POP cast. Prognosis of treated animals. All treated animals were able to place their fixed limbs slightly on ground first 2 days after fixation. POP cast and splint removed after 21 days in all 4 cases. Gradually showed satisfactory alignment of their limbs and able to bear weight without limping after 2 weeks. Fully recovered after 5 weeks from the injury. These are the photographs of recovered animals after removing POP cast, case number 1. In case number 2, here in case number 3, here in case number 4. Discussion. Application of splint and POP cast together can be considered as a cheap, safe, and successful treatment method for repairing and managing long bone fractures in ruminants under the local farming condition. Thank you.
All right, thank you, Dr. Disanaika, for nice presentations. It's really a challenging situation. I hope you are joining with us today online. The presentation is open, abstract is open for any questions from the audience.
Yeah, doctor, actually, it's had a very good clinical impact in the field of, in our veterinary field. Actually, when you are in the handling cases, as a field veterinarian, very good. And your attempt, actually, my question is that you put that cast in the goat case just below the hoof level. I mean, the goat is not able to walk, for few weeks after that. Is that am I correct? Or I mean, you kept him recumbent throughout the period of where the cast is placed? Can you hear us?
Animal was able to handle that with that cast. Anyhow, I didn't put that animal in recumbency. Anyhow, that animal was able to stand and lie down when it wants.
And you have applied this cast on a cow in a very nearly 400 kg animal, big one. And
yes.
So this period was actually within 21 days, it healed. Is it correct? I mean, because usually for a dog, also small animal, it takes, nearly 4 weeks sometimes, because it has very big bones, the cow and the large animals. You had this case, 2 cases, more than 350 kilos, 400 kilos. That period is correct, right? Within 21 days, you remove the cast and okay.
Yes, I performed all these cases during last year, during lockdown period, first and second wave COVID period. So I didn't have any other option to do. I didn't have any drugs or any anesthesia or anything. I just do with the minimum facilities. Anyhow, I just did this as a temporary fixation, but anyhow, it worked.
Actually, I don't ask a question from you. So thank you very much for your effort for this under limited resources in the field. Your initiation is encouraging, and give you fullest. I mean, actually, it is very important because under field conditions, for as a veterinarians, you don't have any resources to do such a large scale surgeries or a correction of fractures. I think you have done an excellent job and fully recovered animals. Excellent work. Thank you very much.
Okay.
And one last question, doctor. You applied this, what do you call this, POP bandages, or just you obtained POP from hardware and use it? Is it?
Yes, I bought. I advised to the farmers to bought that powder form POP, plaster of Paris, from hardwares and mixed with water, lukewarm water, and apply.
Yeah, I'm also agreeing with the Professor Suji and Dr. Ramdika. I think it's a great effort and we have to appreciate that one, Dr. Disanaik. As a senior veterinary surgeon, so what are the guidance, what are the advices you are going to give for a young veterinarians coming into this field? Just a tip of ideas, please.
I like to suggest that
Dr. Disanaik?
we don't
Did you get my question?
Yeah, we don't need to give up any cases. We must try our best to do for the animals and the poor farmers.
All right. Yeah, one more last question. Yeah, Dr. Disanaik, please.
So far, I mean, the first time I saw somebody even attempting to do a case like this. Most of the cases have failed. Thank you very much for presenting this. Thank you.
Thank you.
All right. Thank you, Dr. Disanaik, for the nice presentation. So with that, we will move to the next presentation. It's coming from K.A.R.K. Pereira, Escabilan, and H.R. Ratna. It's about the multi-lobular tumor of bone in a dog. It's also a case report. Dr. Pereira, so screen is yours.
Hello, everyone. I'm here to present a case report on multi-lobular tumor of bone in a dog. First and foremost, let us talk about something: canine primary sarcomas of the axial skeleton. Osteosarcoma is the most common tumor of the axial skeleton, which has a prevalence of 85 to 90%. Meanwhile, hemangiosarcoma and chondrosarcoma has a prevalence of 10 and 5% respectively. Multi-lobular tumor of bone, which we'll be speaking today, has less than 1% of prevalence. Multi-lobular tumor of bone is a slow-growing malignant tumor, which commonly affects the skull and facial bone of dogs. It also affects the ribs and pelvis as well. Nowadays, the location of the tumor is accepted to be in the suture line of bones where two bones are joined. It is also called by different names such as chondromaradones, cartilage analog of fibromatosis, calcifying aponeurotic fibroma, multilobular chondroma or osteoma, multilobular osteochondrosarcoma, and lately it is known as multilobular tumor of the bone. These tumors primarily affect adult females, while large and giant breed dogs are predisposed, and the mean age of the dogs are about 7 years. The picture shown on the right side is a gross appearance of a dog which is affected with multilobular tumor of bone. Now let us focus on the radiographic appearance of the tumor. A mixture of radiodense and radiolucent areas giving a popcorn ball appearance is a characteristic feature of multilobular tumor of bone. When we consider the histopathological appearance, multiple lobules composed of proliferating osteoblast can be seen. The picture shown here, we can find multiple lobules marked with white circle. Meanwhile, at the center of lobules, you can find mineralized chondroid or osseous matrix. In between the lobules, thin fibrous stroma is seen, which is marked with red broken line. The ideal treatment method is surgical excision with wide margins, but usually it is considered as a difficult option due to the location. So most of the patients are treated with chemotherapy with either cisplatin, doxorubicin, adriamycin, cyclophosphamide, or methotrexate. Now let us move on to the case report of Chandi, Chandi is a 7-year-old male Rhodesian Ridgeback weighing 36 kilograms. When we look into the complaint and history, there was a progressive and deforming painless growth over the frontal to parietal area of the cranium observed since a week. There was a reduced appetite and water intake and has been treated for vomiting and incoordination by a regional vet. Under the general clinical examination, the dog was quiet, alert, and responsive, and all vital parameters were normal. The skin over the mass was tinged but not ulcerated, and neurological examination showed no specific neurological abnormalities. According to the general clinical examination, we made the diagnosis, differential diagnosis list with head trauma, bone deformation, secondary to nutritional causes, bone or soft tissue neoplasia. To rule in and rule out the differential diagnosis, we did a fine needle aspiration cytology, took a radiograph, a full blood and blood smear, a biochemical panel. The fine needle aspiration was moderate to highly cellular and moderately hemodiluted. It revealed an atypical population of mesenchymal cells admixed with pink matrix material suggestive of osteoid produced by neoplastic cells. The mesenchymal cells had large, mostly eccentric nuclei with prominent single or multiple nucleoli. The cytoplasmic borders of the cells were indistinct and the cytoplasm was variably basophilic. The radiograph showed a mass lesion with mixed radio-opaque and radiolucent areas, consistent with the popcorn ball appearance, which is often used to describe MTBs. A uniform soft tissue swelling is also evident. The adjacent bones did not show osteolysis. The lungs are a common site of metastasis. This is the thoracic radiograph of the patient with no markings of metastasis in lungs, which is evident of no pulmonary metastasis. However, micrometastasis may exist since the onset of the disease not always visible on a pulmonary thoracic radiograph. According to the findings, we were able to list our differential diagnosis with MTB, osteosarcoma, and chondrosarcoma. The location of the lesion, radiographic finding, and cytology was consistent with the diagnosis of MTB. Under the request of the owner, chemotherapy was initiated. Doxorubicin was selected considering the less severe side effects compared to those of cisplastin. The treatment protocol included doxorubicin 30 mg per meter squared, 5 doses in 2 weeks apart. In addition, antibiotics, antiemetics, analgesics, and anti-ulcer drugs were given as prophylactic. The dog showed mild improvement after the first 2 doses of doxorubicin. However, chemotherapy had to be stopped later due to babesiosis disease condition, and the dog died after 3 months of diagnosis due to complications of babesiosis. The location of the gross lesion, radiographic finding, and cytopathology were highly suggestive of MTB. However, histopathology is the best method for confirmative diagnosis, which was unable to perform in this case. The biological behavior of MTB is different to osteosarcoma. Therefore, it is necessary to include MTB as a differential diagnosis for bone lesions in cranium. Thank you.
Thank you, Dr. Kabilan. He has represent Dr. Pereira. He's the first author of this case report. We believe that Dr. Kabilan joined with us in online. The audience is open for the questions.
I have a question. Now, this owner did not want to do the surgery, right? To debulk this.
Yes. Yes, so the owner was not willing to do a surgery, so because the dog was pretty old, and so she suggested to perform chemotherapy, not the surgery.
So he agreed to chemotherapy straight away without the surgery.
Yes.
Do you think like if you did the surgery and debulking and then started chemotherapy, there would have been a chance to this animal? I mean, is there better prognosis?
So, upon surgery is the ideal solution for this condition. So, complete dissection of the tumor, debulking of the tumor is the ideal correction of the condition. So, but due to the location, the risk with the location and the age of the dog was more suggestive for chemotherapy. And when we explain the risks the dog can face to the owner suggested not to do the surgery and go for a chemotherapy.
Okay, thank you.
All right. So how long you have continued?
So we continued for like 3 weeks. We did the chemotherapy for 3 weeks, and the dog showed mild improvement. But unfortunately, the dog was affected with babesiosis condition and later with IMHA, and passed away due to complications of babesiosis.
And Kabilan, how do you check the improvement after treatment of the chemo?
So basically the dog was from Nigambu, I think, as I remember. So we had telephone conversations, and we frequently called them and asked the condition, and we contact the doctor who was following up the case as well.
Okay. So any questions?
Yeah, my question actually, Dr. Kapil, you did the biopsy FNA, no? Final aspiration.
Yes.
And in your X-ray, it was very diffuse, like traumatic, like, cancer there in the bone piercing into the, skull and into the deep into the brain area also as well. I saw in the X-ray. And
Yes.
what is the gauge of the needle you use to the aspiration? It's a very hard structure, in our experience, it's very difficult to get a bone, by FNA.
Yes,
The needle gets bent sometimes, yeah.
It's a 22 gauge needle. Yeah.
What's the gauge? Yeah.
22.
Okay. So it pierced the bone, right?
Yes, it pierced.
Okay.
And what is the?
Yeah. And what was the cost of the treatment you applied? This is doxorubicin you gave, right? It's IV, or how did you apply? How did you give doxorubicin for the animal?
It was IV, yes.
What was the cost of the treatment like? Yeah.
It was actually we were not were not the ones who gave the treatment, so we referred the case to the local vet. So they discussed with the local vet, the owners discussed with the local vet, and somehow brought the medicines, and the local vet is the one who gave the IV injection.
You didn't have any idea about the cost of the treatment, right? Where did you get the doxorubicin, from the pharmacy or?
Yeah, from the pharmacy.
All right. One more question. So, yeah. Dr. Sugat, yeah. All right. One last question, Dr. Kabilan. What is the usual life expectation of these sort of conditions having in dog?
Actually, we have the literature. There is one literature which was done in Sri Lanka as well, and some of the literatures show that doxorubicin worked very well, and the dog lived for like 6 to 8 months, and we cannot expect a huge expectancy, but this treatment can improve the life expectancy to an extent.
All right. So if there's no question, we can wind it up this presentation. Thank you, Dr. Kabilan, for joining with us. So I will hand over the microphone, Dr. Diane.
So let's move on to the next one. Mandibular fracture correction using dynamic compression plates in a dog by S. Kabilan, RMNS Nuwanshika, GADKK Gunathilaka, HDS Hevapathirana, TMSK Piyadasa, HMS Vijayakon, and DGN De Silva.
Fractures of mandible and maxilla are very common in cats and dogs. With fractures of the mandible alone making up to Hello everyone, I'm here to present a case report on mandibular fracture correction using dynamic compression plates in a dog. Let us go through a rapid introduction on mandibular fractures. Fractures of mandible and maxilla are very common in cats and dogs, with fractures of the mandible alone making up to 1.5 to 6% of fractures in canine. Mandibular and maxillary fractures in dogs may result in severe functional deficiencies and gross disfigurement. There may be several reasons for the occurrence of mandibular fractures, and out of these, traumatic incidents stand out as the main cause. A systemic evaluation followed by stabilization and pain management are crucial as soon as possible when the case is presented. Obtaining a complete and accurate diagnosis is also crucial to choose the correct fixation method. Diagnosis can be done by a proper clinical examination or by either taking radiographs. The main goal of treatment is to prevent damage to soft tissues and dental structures. There are several surgical and non-surgical methods of fixation, such as plate and screw methods, mandibular intramedullary pinning, circulatory application, and muzzle application, or any combination of either the above methods. Now let us move on to the case report of Dory. Dory is a female 1.5-year-old Rhodesian Ridgeback weighing 32 kilograms. Dory was presented to the veterinary teaching hospital after a road traffic accident. The owners observed difficulty in apprehension when given food. The general clinical examination showed there was apparent right-sided mandibular fracture, and the examination also proved there was no any fractures detected on palpation. The full blood count was unremarkable, and the radiological examination showed there was compound transverse fracture just behind the right-sided mandibular canine mandibular tooth. The radiograph on the left shows how the fracture is located just behind the canine mandibular right-sided tooth. The radiograph on the right side shows the dorsoventral view of the cranium with the location of the fracture. After the diagnosis, the dog was taken to the surgical unit. Chlorpromazine was given as sedative under the dose of 2 milligram per kilogram, and propofol was given as the anesthetic agent under the dose of 4 milligram per kg. The animal was placed on left lateral recumbency, and cotton swabs were placed deep inside the oral cavity in order to prevent substances getting into the trachea. First and foremost, an incision was made just ventral to the gingival surface over the alveolar mucosa to form a pocket-like space. The picture on your left side shows the space which was formed using the incision in order to place the plate. A 2.7 millimeter dynamic compression plate with 4 holes combining with 2.7 millimeter self-tapping cortical screws was selected to span the fractured gap. A special plate bending plier was used to contour the plate into 3-dimensionally. The plate was placed on the vestibular surface, the jaw, and 2 screws on each side were inserted at either side of the fracture. After the placement of the plate, the routine closure was done using absorbable suture material. These radiographs were taken just after the surgery. The radiograph on your left is a lateral view of the fracture reduction, and the radiograph on your right is an oblique view of the fracture reduction. The animal was given antibiotics just after the surgery, and meloxicam was given to reduce the pain caused by the fracture reduction. The patient recovered in 3 weeks of interval with returning to normal appetite and water intake. During the 3-week interval, the owner was advised to give soft diet and also was advised to prevent chewing hard materials. The implant was left in place till present, and no inflammation or damage to the dental tissue was observed up to date. Plate and screws perform well in complicated bilateral and unilateral mandibular fractures and provided excellent stability. Although plates are expensive, they can provide painless and rigid fixation with quick functional recovery. In this study, we demonstrated that dynamic compression plates provided such a balance as indicated by the short period needed to return to normal function. This study also confirms that the plate is well tolerated by the body and does not give rise to any clinically detectable inflammation or foreign body reaction. So finally, the maintenance of stability in fractures of the mandible and maxilla are much better when using dynamic compression plate compared to the conventional method which was used in Sri Lanka, which is the intraosseous wire fixation. Although the method is expensive, plates can provide painless and rigid fixation with quick functional recovery. Thank you.
Paper is open for discussions. Dr. Sugar?
Dr. Kabilan, it's a very good presentation and a new technology to the veterinary field. Just I want to know, normally for the oral cavity, we apply cuttable, malleable plates so we can bend it according to the shape of the jaw. And other thing is, did you get the X-ray to rule out any damage to the tooth roots? Because that is very, very important. If we damage to the tooth root, it will cause very, that we have to do nerve healing or something now.
So at that moment, we were not able to take any tooth X-rays. We only just took an skull X-ray.
I have a question. Now you have used a dynamic compression plate here. Now on each side you have used 2 screws. Now, is there a minimum screw number that you need to use with the DCP on either side of the fractures? Because I'm asking this, like in long bones, there is something like that. Minimum number of screws. On oral cavities, there are some, like, in each side, minimum number of screws required.
So we earlier we planned to balance the plate. So like balance number of screws at either side. So first we initially planned to insert 1 screw at either side of the fracture, but later we decided to add 2 screws at either side because it gave more stability than applying just 1 screw at either side.
One question, Kabilan, how do you select the plate size 2.7 for this patient? What is the method and classification of that?
Yeah, because the main reason was the availability was a main factor, and so we had 2.7 millimeter of plates, and the next thing is the location. So the oral cavity is more prone to get like damages when we use the bigger size of plates. So so that's why we plan to insert a 2.7 millimeter and not much larger plates.
Normally, for the oral cavity, they recommend 2 millimeter plates. That's why I asked that question.
I think Dr. Sugat is right there, because it's not a weight-bearing bone, the mandible. I think you could have gone for smaller size, but it's a interesting paper. And the other thing I wanted to highlight is that your meloxicam dose is wrong. 2.1 milligram per kg is the oral dose. Even the previous presentation, you have given 0.2 milligram per kg, because that can cause ulceration in the long term.
I have one question. So regarding this implant, so in humans, generally we can keep this implant for a lifetime. Is there any complications or adverse reactions to keep this implant for a long time in animals?
Yes, definitely there will be there are complications, but so we frequently followed up the case, and we asked for any gingivitis conditions or any other complications. But many publications they have removed the implant after like 8 to 10 months, and some of the dogs, they have left the implants for lifetime. And in this case, still the dog is having the implant, and there is so far no complications seen.
Yeah, Dr. Kapil, actually, it's a very good one. With the available resources, you have done your best, I suppose. The animal was recovered, and, you showed us a photograph also after the surgery, and he's, I think, happily eating his foods, able to, have the normal life. And my small question of what made you to have this chlorpromazine and propofol combination in this surgery? Is a particular indication for that rather than going for normal, basic, what do you call, anesthetics?
Yes, because there's now no specific indication. Propofol was very safe and less with less side effects, and that was the reason, and there was no specific reason for using chlorpromazine.
Thank you, Dr. Kabina. Let's move to the next presentation. Combination of surgical correction and platelet-rich plasma therapy for Achilles tendon rupture, 2 successful clinical cases. HDS Hevapatirana, GADKK Gunatilaka, S. Kabilan, KARK Pereira, MGTM Prachadini, TMSK Piyadasa, HMS Vijokon, and DDND Silva. Oh, I'm so sorry. I made a mistake. The next presentation should be uncommon presentations of common disease. 2 cases of transmissible venereal tumor. KARK Pereira, IPCS Kitsiri, C. Abekon, and HR Ratna. I'm sorry about that.
Hello, everyone. Today, I'm going to share with you uncommon presentations of a common disease. 2 cases of transmissible venereal tumor, a very common case for veterinarians in Sri Lanka. Well, when you say TVT or transmissible venereal tumor, it has many synonyms. For example, sticker tumor, venereal granuloma, transmissible lymphosarcoma, and even infectious sarcoma. Now, TVT is a commonly occurring benign reticuloendothelial tumor of dogs. It affects mainly the external genitalia, but there are occasions where internal genitalia are also affected. This condition is commonly observed in the tropical countries and also in subtropical countries, but we do not see any predisposition towards any breed, age, or sex. Now, what causes this condition, this disease? What is the etiology? We see a tumor cell transplantation from affected hosts to healthy animals, especially during coitus. That is the major cause. That is what leads to this tumor. Now, during coitus, there could be extensive abrasion and bleeding of penile mucosae and even vaginal mucosae. This makes it very easy for the transplantation of the tumor. Well, grossly, this appears as a small nodular lesion that bleeds easily. They are usually found in the shaft of penis in males and along the vestibule of vagina in females, as shown. The neoplasm begins as a nodule and when enlarged, breaks through the overlying mucosa. The prominent cytological feature of TVT is the presence of cytoplasmic vacuolation. In addition, mitotic figures with chromatin clumping and 1 or 2 prominent nucleoli are also evident. Now, as you all know, vincristine sulfate is the most effective drug, and majority of the cases of TVT respond to vincristine very effectively. Well, canine TVTs can reach extragenital sites as well, such as the nasal mucosa, oral mucosa, ocular mucosa, and cutaneous lesions. Well, it is suggested that this transmission may occur by licking, sniffing, and biting affected areas. Well, macroscopically, it presents as a simple or even multiple nodules with cauliflower-like appearance, friable and intense reddish color. Most of the time, extragenital cases of canine TVTs emerge along with the lesions in genital organs, but rarely exclusive extragenital canine TVTs are also found without the involvement of genital TVT lesions. This presentation is about incidence of 2 cases of extragenital TVT in 2 dogs. But the first case is Shadow. A 1.5-year-old male golden retriever was presented to the better teaching hospital with the main complaint of multifocal nodular lesions in skin and eyes, together with a breathing difficulty. When we investigate on this case, especially on the history, we found that a surgical removal of a mass in the right submandibular area had occurred 2 months prior to the presentation. Well, thereafter, small multifocal nodules appeared in the skin, eyes, gums, nostrils about 2 weeks after the surgery. Their onward snoring, sneezing, and epistaxis has persisted. Well, in the physical examination or the general clinical examination, we found it to have a mild to moderate tachypnea, together with nodular lesions in the conjunctiva, nasal plenum, philtrum, gums, upper palate, upper eyelids, ventral abdomen, and medial thighs. When we performed the fork test, we found that only the left nostril was patent. Interestingly, we found no lesions associated with genital organs. Now you can see here, there are lesions right above the upper eyelid, here in the gums, in the medial thigh area. This is shadow with so many lesions extragenitally. So we wanted to go for further diagnostics. We did an FBC with a blood smear. We took impression smears from cutaneous lesions and nasal swabs, and also did skin scrapings. We came up with a list of differentials. We had demodicosis, bacterial pyoderma, allergic dermatitis, fungal dermatitis, immune-mediated skin disease, and TVT. The TVT came very low in the list because the clinical presentation and the appearance of these nodules were very consistent with bacterial pyoderma clinically, just by visual observation. But the FNA told a different story. Well, when we consider the upper respiratory issues that shadow had, especially snoring, sneezing, and epistaxis, we could come up with the differentials of allergic rhinitis and nasal polyps. Well, we did laboratory diagnostics, and in hematology, we found not much of deviations, but cytology, especially the impressions from the cutaneous lesions and nasal swabs, suggested that these lesions were very consistent with TVT, and the skin scrapings were negative for demodicosis. Well, our diagnosis came as an extragenital transmissible venereal tumor. Well, this is interesting. Late in the process, we discovered actually the clients came up with this history that in the same household, there had been another dog with vaginal bleeding for a period about 1 month. So we suspect that dog, that particular dog who shared the same household, might have had genital TVT, but this one, Shadow, had extragenital lesions. Well, the treatment was very direct. It was vincristine sulfate, and also we started cloxacillin as an antibiotic. The disease outcome was very good. All cutaneous nodules disappeared with 2 doses, but mild snoring was observed. But unfortunately, clients did not bring the patient for the 3rd dose because I assume the patient got better and the clients felt it was not required. Well, the second case is Timmy, a 5-year-old male crossbred who was also present with the complaint of breathing difficulty, but also with unilateral facial swelling around the nasal area. In the history, we found that the facial swelling and breathing difficulty had been observed since several months. The skin over the facial swelling had a scar tissue. We suspected it to have, whether it was a dog bite, and also it had snoring, sneezing, and epistaxis. In the general clinical examination, we found Timmy to have hypothermia, but there was also unilateral facial swelling around the nasal area with blood-tinged purulent discharge and 2 puncture wounds. Once again, no genital lesions. We did an FBC, we checked the blood smears, and also we took samples from the nasal swelling. We did FNA. The list of differentials we had, we thought it to be a xerotic suppurative sinusitis, allergic sinusitis, fungal rhinitis, nasal polyps, and once again, TVT as a neoplasia. In hematology, we found it to have a mild to moderate leukocytosis with anemia and the smear being positive for Babesia gibsoni. Cytology once again proved to be consistent with TVT. Well, the case was once again, in a way, direct. it was having extragenital TVT with babesiosis. We did not directly treat for TVT because he was suffering from anemia. Therefore, we treated with doxycycline, pyridine, imidocarb, omeprazole, and hematinics in treating Babesia gibsoni. And we wanted to have a follow-up after 10 days to recheck the blood parameters. But then again, the clients also wanted to be referred to regional vet because it was convenient for him. Well, when we consider these two cases, it's very interesting because we find that none of these cases had lesions in the genitals. None of these cases had TVT lesions in the genitals, which means that coitus was not the cause of transmission in both of these conditions. Then what was the cause? How did it transmit? Well, in the first case, we can say the other dog who was in the same household might have given the disease to this particular dog who was shadowed by contact, but it happened to be not genitally, but extragenitally placed. In the second case also, it could have been due to sniffing an infected dog or through a dog bite of an infected dog. Now, the importance of TVT in the DD list is that when a patient is brought with cutaneous nodal lesions and dog is presented with epistaxis or purulent nasal discharges, it's important that we include this in the DD list, even though there are no genital lesions. Secondly, cytology is an inexpensive and effective method to confirm the diagnosis of extragenital TVT. Hope you enjoyed my presentation. Thank you very much for listening. Thank you.
Thank you. The paper is open for discussion.
Yeah, actually, Dr. Chandra, it's a good attempt. You did this, paper, and the presentation is very nice. And my question is, usually in our clinical experiences, we get a lot of cases in, it's quite common we get these TVTs on the face, when you get a sneezing with a dog and you get some epistaxis, we have secondary doubts whether he has TVT, it's a very common finding. And the things, always we sometimes get, impression smears from those lesions, and we get sometimes attempts for crystalline sulfate we are giving for. It's a common practice in the field. Why did you use this? The topic in your presentation as an uncommon presentation, a common disease, like what made you to have that topic? Yeah.
I think our main approach was to make it more scientifically valid here. Because I know most of us have encountered these sort of cases, especially when it's epistaxis. It is possible that we have, it's important that we have TVT as one of our DDs. But first thing was to make it scientifically evident in Sri Lanka, and also to make sure that even though it has epistaxis, there were also the first case, it did not have it had subcutaneous lesions in eyes and in the thighs. It was more or less generalized throughout the body. So I think that was a bit of a rare finding. And also the importance of cytology, because we take it granted when it comes to cytology that we always feel it should be something we should do histopathology, but it's not the story. The other thing is, now it's good that this was TVT, but what if it was not TVT? Because sometimes most of the clinics that we find, they just give TVT, they just give vincristine whenever you see epistaxis. But they would do it, they would just try giving antibiotics orally, and the second would be giving vincristine. So this highlights the importance of scientific approach to cases of TVT.
Yeah, your answer was very good, actually. You tackled my question very nicely, because anyway, the feel that it's a common thing in the, on the skin of the faces of the dogs, when they go and sniff, lesions, because it is contagious. Quite commonly they get, TVT on the face. You can't name anywhere, maybe eyes or the lips or maybe on tip of ears. Sometimes we have seen a lot of cases. It's very quite common. But you applied the way scientifically, it's very good you're answering. Yeah, anyway, it's good. Yeah. But we don't see any uncommon, thing here, Chances are it's a very common thing, yeah.
Yes, Dr. Noan.
Dr. Chandilu, when we come across the TVT case like the epistaxis, do you think we can isolate the cancer cells by oozing blood? If you
most of the time we could, because usually exfoliation is observed during because it's round to cell tumor, and you do because I think most of the cases, but I've seen, and most of the cases that we've seen in our hospital, teaching hospital, we were able to the sample collection. We just had to place a slide right against the nostrils, and that was enough. But if you think it's not going to work, maybe you can use a nasal swab. Maybe go a little bit deep inside and then take a sample. That would be more representative.
Do you have any idea about what is the common site of internal nasal TVT site? I mean, it's a superficial, or should we go for the more deep?
Well, yes, I think naturally what happens is whatever cell has to, it's inhaled mostly, and it has to go somewhere and get stuck. So I don't think it could pass beyond the concave, the nasal concave. It should be quite below the nasal concave.
Thank you.
Thank you. Can move on. Okay, let's move on to the next presentation. Combination of surgical correction and platelet-rich plasma therapy for Achilles tendon rupture. 2 successful clinical cases. HDS Hevapatirana, GADKK Gunatilaka, S. Kabilan, KARK Pereira, MGTM Prasadini, TMSK Piyadasa, HMS Vijayakonan, DDN De Silva.
Hello, everyone. This presentation is on 2 successful clinical cases, outlines combination of surgical correction and platelet-rich plasma therapy for Achilles tendon rupture in dogs. Before moving to the case presentation, let me give an introduction. Achilles tendon is made out of 5 tendons, mainly gastrocnemius and superficial digital flexor tendon. And 3 other minor tendons are involved. Function of this tendon is extension of hock joint. So the gastrocnemius tendon is attached to the calcaneal, while superficial digital flexor partially attached to the calcaneus and passes over it and attached to the toe. All other 3 minor tendons are attached to the calcaneus. Achilles tendon rupture could be partial or complete. In partial rupture, it involves only gastrocnemius tendon. In complete rupture, it involves the whole tendon with all 5 tendons. In both conditions, hock joint is dropped. In partial rupture, it curled the toe, as you've seen in the image. In complete rupture, it comes to plantigrade position. Diagnosis of this condition is mainly based on physical examination findings. Radiographs, ultrasound scanning, MRI scanning could also be used. When it's come to treatments in minor condition, non-surgical treatments with splint application. In severe conditions, surgery is recommended. Most of these kind of cases, prognosis is uncertain and depend on the patient, and complications for the recovery or the complications for poor prognosis are low vascularization of the tendon structures, adhesion with surrounding tissues and restrict mobility, tension and active loads on the tendon, active and passive tendon movements. With the development of regeneration medicine to overcome these complications, they have used combination of PRP with surgical or non-surgical treatment. PRP therapy or platelet-rich plasma is an autologous product that made out of patient's own plasma. And it has been used in many clinical conditions and there are successful outcomes. When the whole blood is concentrated into the PRP, activated platelets contain these growth factors, platelet-derived growth factors, vascular endothelial growth factors, tumor growth factors, etc. So all these growth factors are involved in enhancing tissue healing. These tissue healing process is enhanced by these growth factors. Therefore, there are many successful literature that where platelet-rich plasma has been used in many clinical conditions in veterinary medicine as well. When it comes to the case presentation, this presentation is on 2 cases. First one is Willie, 7 years old male, grade A, presented to the VTH with the complaint of non-weight-bearing lameness and infected wound above the hock joint. Shadow, 5 years old female Belgian Shepherd, presented with the complaint of non-weight-bearing lameness, and he also had a wound, but not that much complicated as Willie. So mainly we came into the diagnosis with the physical examination. The radiograph also revealed how the tendon structures are tear in both patients. Surgical procedure was performed in both patients under the general anesthesia and lateral recumbency. Terminal loop suture ternography was used with non-absorbable sutures, and the suture size that we used is 3. The recommended size is from 3 to 0 in USB scale. This is because using of larger suture materials could be cause for delaying healing. And tendon heads are identified and approached and sutured. So with the combination of the surgical procedure, we go for the PRP treatment as well. And 2 different types of treatments were used in 2 patients. In the patient 1, we were using PRP solution and it was infiltrated to the surgical site. Post-surgically at 2 days interval for 2 weeks. For patient 2, we placed a PRP and fibrin clot at the gap of the defect before the close of skin incision during the surgery. In post-operative management, it is a critical part of healing of Achilles tendon rupture cases. So during post-operative management, the immobilization is essential in early stages. These images are from Willie's surgery. The infected wound was controlled before the surgery by hospitalizing the patient, and at the surgery, we exposed the 2 tendon structures, remaining tendon structures, and attached 2 ends with non-absorbable suture materials. And PRP solution was made by centrifugation of collected blood. Blood was collecting to ACD containing conical tube. 8 to 10 ml of blood is collecting, and this was subjected to centrifugation in 500 G for 10 minutes. And this is how it looks like after first spin. Then the plasma was separated and subjected to the second centrifugation. Then the pellet was there in the bottom, and it was resuspended in the remaining 1/3 of plasma. So this is how it looks like. The preparation looks like before the administration. In Shadow's case, 2 tendon structures were identified and it was sutured in terminal ternography method. This is the fibrin clot, the fibrin PRP clot that prepared from patient's own blood during the surgery by centrifugation in 500 G without adding anticoagulants. And this is how it's placed between the defects during the surgery. Both cases were followed up to 1 month. In Willie's, suture healing were completely occurred after 1 month of time. And also in Shadow, the anatomic, the functional restoration was occurred. Significant anatomical restoration was observed. Complete wound healing was observed in both cases. Take-home message of these 2 cases is the recovery period was much less, and it was effective and successful with the combination of surgical intervention and PRP treatment. It is recommended to use combination of surgical correction with PRP therapy for tendon injury as well. And also it is cost effective and easy to perform in Sri Lankan condition as well. So it is justifiable, and we embark the use of this treatment method in Sri Lankan condition as well. And also several important aspects needed to be addressed with critical review. And also more clinical studies should be performed to identify the true effectiveness of the PRP in tendon healing as well. Thank you.
Thank you. The paper is open for discussion. Can I ask the question first?
Okay.
Sorry.
It's quite interesting, Dr. Patran, actually. I mean, so you use this PRP clot and infiltration of PRP, both methods. I mean, in one surgical attempt, right? Or in both, in one dog you use PRP clot only, and the other dog, yeah, what's the procedure you follow, doctor? Please explain us.
Yeah. In two cases we used the two separate way. In one case we infiltrate the solution, and in the other case we use the PRP clot.
So you compared the healing process after that? I mean, the duration of the healing and animal recovery? I mean,
No, our intention is to get the outcome, not to compare the effect of the PRP, the duration, but what we want to do is the combination of the PRP with the surgical therapy is effective than using individually, using the surgery, not without using PRP. So in these both cases, we see the very similar time of healing process. It was effective than not using PRP.
My other question is, I mean, this study actually, if you're having a very clinical significance, like, for the clinical usage, I mean, this is we have done on two cases with this method, suturing and the tendon and applying this PRP. And have you done any study without applying PRP? Another case to compare with the healing process really help for this, to have the clinical implication of this application?
Yeah, this is the first time that we used PRP for the correction of this kind of method at the veterinary teaching hospital. So according to the history that we have, according to the records that we have, the healing time is more or less in these two cases. And also its literature suggests that there are very good literature that related to these kind of cases, that they are very clearly emphasizing that healing time is reducing with the use of PRP.
Because usually in our clinical experience, anyway, the dog is, when he's moving after the surgery, most of the cases, it breaks, and dogs come present to the clinic again,
Yes.
Immobilization is the best. I mean, the most post-operative care play a very important role. Even in human, they put POPs, when you repair this Achilles tendon, the repairs, because you have to keep sometimes many months in human cases. For the dogs, it's very difficult to keep them, So, I mean, if this is really helpful, yeah, it's would be a very, very, very productive, experience and finding. Yeah, that was my, to know that. Yeah.
What is the immobilization method you used in this case?
In these both cases, we were used application of this co-band application, and we didn't use any splint all, I think, because the wound was there, and it was very hard to keep a splint in that kind of situation. So we were wrapped, after giving the treatments, we were wrapped with the co-band tightly and kept the dog immobilized, kept the joint immobilized in that way.
Just the co-band onto the skin, is it?
Yeah, yes, externally application of co-band.
Without any support layers?
No, we didn't. I mean, the cotton swab were used, not any external coaptation like splints. We used
not even the Robert Jones bandage.
The swab with the
yeah, because this immobilization is the key factor here. Yes, I'm sure the PRP is helping to enhance healing, but because the tendon healing takes so long, not like a soft tissue muscle healing, the immobilization has very important together with the surgery and the other supportive therapy. Thank you. Any more questions? Thank you. We will move on to the next one. Cardiac rhabdomyosarcoma in a doe, a case report. In a doe. GM Vidura, YK Jayawardena, BMDN Kularatna, WPP SI Pereira, PGAS Pallikumura, RRMKK Vijay Sundara, PGA Pushpakumara and GDRK Pereira.
Hello everyone, I am Vidura Gajanayaka. Welcome to my presentation on cardiac rhabdomyosarcoma in doe. As we know, tumors are accumulation of cells that are dividing uncontrollably and severe no-purpose actually. But if they are malignant, they can spread to another place and cause problems. If they are benign, they can present at the wrong place and also cause problems. Before moving to today's topic, I would like to briefly explain about cardiac tumors. Basically, cardiac tumors can be divided into two groups, primary cardiac tumors and secondary cardiac tumors. Primary cardiac tumors originating within the heart itself, and secondary tumors spread from primary tumor in different part of the body. Myxoma, rhabdomyoma, fibroma, hemangioma are some of benign type primary cardiac tumors. Rhabdomyosarcoma and primary lipoma are malignant type primary cardiac tumors. So here I have mentioned some of common cardiac tumors that can be seen in domestic animals. But cardiac diseases are very rare condition in domestic animals. Today we are focusing into rhabdomyosarcomas. So as you know, rhabdomyo stands for the striated muscles and sarcomas implies malignant type tumors. So rhabdomyosarcoma means malignant type tumors in striated muscles. Rhabdomyosarcomas can arise from almost any type of striated muscle in any location, resulting highly variable clinical manifestation. Cardiac rhabdomyosarcomas are very rare condition in animals, even in humans. Let's move to our topic. This is the case that was presented into farm animal teaching hospital. Animal was 1.5-year-old Saanen female goat. The complaint was reduced appetite and distension of abdomen over 4 days. In the presentation, animal was depressed and lethargic. During the general clinical examination, animal's temperature was 98.8 and heart rate was 60 beats per minute, and it also arrhythmic. Respiratory rate was 70 beats per minute, 7% dehydration, fair mucous membrane, bilaterally enlarged abdomen, and reluctant to stand. Based on the general clinical examination and the history, those were our problem list: hypothermia, dyspnea, tachypnea, cardiac arrhythmia, pale mucous membrane, 7% dehydration, reluctant to stand, hyporexia over 4 days, bilaterally enlarged abdomen. We came across 5 differential diagnoses based on our problems. severe bloat, pneumoperitonitis, gastrointestinal obstruction, hydrometria, and cardiac diseases. Animal was admitted for the further diagnosis and treatment. Unluckily, animal died shortly after. However, we could able to identify very interesting lesions during the necropsy. At the necropsy, carcass was severely pale, as you can see here, and there were approximately 5 liters of clear ascitic fluid in the abdomen. You can see here this yellow color fluid. And these two pictures are liver. You can see the blunt edges in the liver and also the fibrinous materials on the surface. Fibrinous materials are clearly seen in this picture. And this is the cut surface of the liver. At the cut surface of the liver, you can see dark irregular areas of the hepatic tissue interspaced with pale color areas. It looks like nutmeg in here. Lungs were heavy and filled with frothy fluid, and also we could able to feel crepitation at the caudal border of the lungs. And here I have shown a distal trachea. You can see the frothy fluid in the distal trachea, and also there were multifocal petechial hemorrhages in the distal trachea. This is the heart, and there were approximately 50 milliliters of the clear pericardial fluid and the pinpoint hemorrhages on the pericardium. This is the cut surface of the heart. We can observe whitish vegetative growth with a cauliflower-like appearance in the base of the tricuspid valve. It's only on the right side, not in the left side. And we send this vegetative growth sample to the histopathology. Histopathological findings are suggestive of primary cardiac rhabdomyosarcoma. Here I have shown lower magnification of the histopath slide. You can see the attachment of the tumor to the tricuspid valve. This is a tricuspid valve, and it is a tumor, and here is the attachment. This is a higher magnification of the slide. Presence of the large bizarre tumor cells and deeply eosinophilic cytoplasma are evidential for pleomorphic subtype of cardiac rhabdomyosarcoma. As you can see here, large tadpole-shaped rhabdomyoblast along with the eccentric nucleus, and also multinucleated giant cells. You can see the tadpole-shaped rhabdomyoblast in this slide. Basically, tumors of heart are often asymptomatic for a long time until their growth impair the blood flow through the cardiac chambers and adjacent blood vessels. At that stage, they can mimic symptoms and signs of heart disease, such as stenosis or insufficiency of valves, obstruction of venous outflow, or a heart failure. Cardiac manifestation depend on the size, location, and the histopathological characteristic of the tumor. Intramural tumors may cause heart rhythm, conduction disturbance, and impairments of ventricular function and pericardial exudation. Intracavitary right atrial and ventricular, most frequently due to sarcomas, pudding pairs, filling and empty. Those necropsy findings due to these cardiac tumors, those pulmonary, hepatic, those lesions due to heart lesion, heart failure. Changes of the heart, changes of the liver reflects chronic passive hyperemia of liver due to heart failure. And also sciatic and hydropericardium, also the generalized edema due to the cardiac failure. Trots in the distal trachea and the pulmonary congestion, also the sequelae of the heart failure. So this animal could be died due to congestive heart failure due to the cardiac tumor. Take-home messages: don't exclude cardiac tumor in your differential diagnosis list when you present the goal with such a clinical presentation. As an indeed rare and fatal condition, early detection would be supportive to get management decisions, avoiding economical loss to the farmer in both farming practices. Thank you very much.
All right, thank you very much. So the paper is open for the discussion. Then Dr. Randika has some questions. Yeah.
Yeah, doctor, actually, yeah, it's a very good finding. I mean, is this the first time in Sri Lanka this reported? You have any literature review for this kind of this cardiac this tumor? I mean, this rhabdomyosarcoma.
Dr. Vidura, are you with us through online?
Hello, can you hear me?
Yeah.
Okay. So yes, according to literature, we couldn't find any cardiac rhabdomyoma cases in Sri Lanka in goats. Actually.
Yeah, I mean, and my other question is, you have some lung lesions and liver lesions as well together.
Yeah.
I mean,
Yes.
you get like that scanty, this what you call the fibrous appearance on the cardiac and even lungs. Did you do any bacterial investigations, any culture test, or and to rule out mycoplasma also? A lot of mycoplasma cases have similar. Yeah.
Yes, sir. We sent the vegetable growth sample for the microbiology as well, but we couldn't see any growths.
You didn't have any culture growths of other bacteria and mycoplasma. Did you do for mycoplasma? Because it's a little bit long procedure to identify that.
I'm not actually, we didn't check for the mycoplasma.
You did only ruling only this pathological slides for this to find out this tumor, right?
No, we sent the sample for the microbiology actually, but we not proceed for the mycoplasma.
Okay.
Any more questions from the table?
I mean, what made you to think this is? I mean, looking at the slides, this is exactly cardiac rhabdomyosarcoma, right? Have you ever seen any slides? I mean, what made you to have this literature? To think this is the very significant finding?
Actually, to confirm the cardiac rhabdomyosarcoma, we have to send sample for the immunohistochemistry, but we didn't perform the immunohistochemistry for this sample. But most of histological characteristics are supportive, suggestive for the pleomorphic subtype of cardiac rhabdomyosarcoma. Those histological, based on the histological characteristic, we suggest that that is a cardiac rhabdomyosarcoma.
You suggest it, right? Not confirm.
Yes, not confirm. We have to send the sample for the immunohistochemistry for the confirmation. If it is positive for myogenin and myo-D proteins, we can confirm it is a cardiac rhabdomyosarcoma by immunohistochemistry.
Yeah, if you can confirm that, then you can report it as the first case in the country. Like, yes. I mean, it's the significance, end of the research. Yes. Otherwise, you can say anything. I mean, just a name of the distinct condition. No, yeah, yes. That's my opinion. Yeah.
We plan to send the sample for the immunohistochemistry as well.
Okay, thank you, Vidura, for joining with
Okay,
us
thank you very
today. Okay, all right. So we will move to the next presentation. It's about the multiple trichoepithelioma in crossbred dog. It's also a case study, which was done by WMNS Vijay Surya, Eskabilan, HMS Vijay Kon, KK Vijay Sundara, PGAS Palkumbura, and H. Ariratna. Dr. Vijay Surya, the screen is yours.
Hello everyone. Today I am going to present a case report, multiple trichoepitheliomas in a crossbreed dog. Skin tumors are the most common tumors we encounter in veterinary medicine. Cutaneous neoplasms can be classified based on their origin. Epithelial tumors are the most common type. As a percentage, it is 40 to 60% of cutaneous neoplasms. Mesenchymal tumors, they occupy 35% of cutaneous neoplasms. In addition to those two, there are melanocytic origin tumors and lymphohistiocytic origin tumors. Among neoplasms which are having epithelial origin, hair follicular neoplasms account for 10 to 12%. Almost all the hair follicular neoplasms are benign and aggressive in nature. Therefore, accurate histological evaluation is required. This is the normal structure of a hair follicle. It is divided dorsoventrally into three parts: infundibulum, isthmus, and the inferior segment. Infundibulum extends from the epidermis to the sebaceous duct. Isthmus extends from the sebaceous duct to the insertion point of erectopili muscles. Inferior segment extends from the insertion point of erectopili muscles to the bulb. Tumors can arise from all the above anatomical structures, and we classify them according to their structural differences. Trichoepitheliomas derived from all the three segments of the hair follicle. Trichoblastomas derived from the hair bulb. Tricholemomas, they can be derived from the isthmus or inferior segment of external root sheath. In addition to that, there are tumors that are not very commonly found in dogs. For example, trichofolliculomas and pilomatricomas. In this presentation, our biggest concern is on trichoepitheliomas. Trichoepitheliomas are common in dogs but uncommon in cats and rarely reported in other species. Mostly they occur between 5 to 11 years old age, but animals between 1 to 15 years old age also may develop these tumors. Especially spayed female dogs are at risk. Predilection sites for trichoepitheliomas are back, thorax, neck, and the tail. Trichoepitheliomas located mostly in the dermis, but may occasionally extend into the subcutaneous tissue. Mostly they have a distinct margin, but sometimes may invasive into deeper tissues. They are solitary neoplasms. Multiple neoplasms are rarely reported. Epidermal ulceration, alopecia of the skin over the mass, and secondary infections are associated with this condition. Definitive diagnosis of trichoepithelioma is based on histology. Histological appearance may vary, depends on the degree of differentiation into the three segments of the hair follicle. They consist of islands of epithelial cells. These islands are surrounded by a stroma. This stroma can be collagenous or mucinous. At the center of epithelial cell islands, keratin accumulation can be seen. Sometimes these neoplasms may show a cystic variant. They have one large cyst or several small cysts. They are filled with keratin debris. In addition, we may find gauze cells and cholesterol clefts at the cyst lumen. Now let's move to our clinical case, which was presented to the veterinary teaching hospital. The animal is a canine crossbreed, female neutered, 6 years old animal. The complaint was 3 cutaneous masses present on the ventral neck region, distal left forelimb, and left lateral thoracic wall. These masses had a sequential development over 3 months. During the general clinical examination, animal was bright, alert, and responsive. Mucous membrane color was pink. Animal had a mild splenomegaly and mild abdominal pain. Animal was obese and no other abnormality was found in other body systems. Based on the general clinical examination findings, we came to some differential diagnoses, including abscess, foreign body granuloma, and neoplasms. For further diagnosis, 5 needle aspirates were taken and done cytological examination. There were tightly cohesive clusters of uniform cuboidal epithelial cells. Those cells had a large central nuclei and a small rim of dark basophilic cytoplasm. Between epithelial cell clusters, there was a pink amorphous matrix material. Based on the cytological examination results, it was diagnosed as an epithelial cell tumor. Based on that diagnosis, complete surgical excision was recommended. Surgery was done under general anesthesia. Surgical site was aseptically prepared pre-surgically and completely removed the masses with white margins. These are some pictures taken during the surgery. After the surgery, samples were taken for histopathology. This is one of the histological sections. You can identify islands of epithelial cells. This is the collagenous stroma. Here you can identify keratin accumulations at the center of epithelial cell island. This figure shows you some small to moderate amount of keratin accumulations within the lumen. This is the lining epithelium, consists of cuboidal cells. According to the histopathology, this was diagnosed as a trichoepithelioma. At the first visit, all the masses were inflamed. Therefore, the inflammation was controlled before the surgery. Signs of metastasis was evaluated by examination of lymph node aspirates. No metastasis signs were detected. Because of the benign nature and the absence of metastasis, it was diagnosed as 3 separate masses. Post-surgical management of the animal was done using antibiotics and analgesics. During follow-ups, no tumor recurrence was reported, and the animal was clinically normal. In conclusion, trichoepitheliomas are one of the common hair follicular tumors, but multiple trichoepitheliomas is a rare presentation. When an animal is presented with multiple neoplasms, examination of each individual neoplasm is important. This may identify whether they are separate neoplasms or the metastasis of same neoplasm. This knowledge is important when it comes to treatment plan. So this presentation emphasized the importance of cytology and histology in situations diagnosing multiple neoplasms. That's the end of my presentation. Thank you.
Okay, thank you, Dr. Vijay Surya. So we hope you will join with us in the online as an online viewer. The audience is open for the questions.
Yeah, Dr. Vijay, I have a question that how did you rule out the metastasis tumor small nodules in the skin? Whether it has gone to the other parts of the body. How did you rule out that condition actually? Just having a look at the cytology, is it?
Yes, we got fine needle aspirates from the lymph nodes, all the lymph nodes, and we did not observe any metastasis signs like the level of anisokaryosis and anisocytosis are it is less, and the tumor. And also in the lymph node aspirates, we couldn't find any tumor cells. That's how we came to that conclusion.
All right, Dr. Vijay Surya, thank you very much for joining with us today. So we will move to the next presentation. It's about the recurrent of subcutaneous spindle cell tumor with the histological features consistent with peripheral nerve sheath tumor in 5-month-old mixed breed dog. This also the case reports coming from TMSK Piyadasa, S. Kabilan, NB Ramesh, HDS Heva Papirana, RMNS Nuanshika, GADKK Gunatilaka, AT Liyanage, and H. Ariyaratne. Dr. Piyadasa, the screen is yours.
Hello everyone, I'm Nirujan. I will be presenting a case of a recurrent subcutaneous spindle cell tumor with histological features consistent with a peripheral nerve sheath tumor in a 5-month-old mixed breed dog. Peripheral nerve sheath tumors, or PNSTs, are a group of mesenchymal group neoplasms in dogs, and they are given name on the origin of some cells. Schwannoma is a term given for the tumor that originates from Schwann cells, while neurofibroma or neurofibrosarcoma is the term given for the tumor that consists Schwann cells and perineural fibroblasts. This is common in old or middle-aged dogs, but rare in young dogs. Youngest dog that is reported with a PNST is a 4-year-old dog. And in this case presentation, we will be talking about a 5-year-old dog, which is also a rare case. PNST in dogs are malignant tumors, and malignant tumors of this kind can be characterized by high mitotic rate, high cellularity, and anaplasia. These malignant tumors are poorly circumscribed, and they rarely metastasize to lungs or regional lymph nodes. Clinical signs may vary according to the location of the tumors, and surgical excision with white margins is curative. Local recurrence could occur in case of incomplete surgical margins. There are two distinct historegions that you can see in a PNST. They are Antony A pattern and Antony B pattern. Antony A pattern consists densely packed spindle cells which are arranged in interlacing bundles and fascicles with occasional storiform or palisading or concentric growth, and the nuclei of these spindle cells are elongate to fusiform. Antony B pattern consists less cellular, diffuse, loosely textured meshwork of more pleomorphic, round or fusiform or polygonal cells, and they have greater nucleopleomorphic or karyomegaly and multiple nucleoli. And the Antony A region consists a significant histological feature which is named verrucate body. Verrucate body consists of stacked arrangements of two rows of elongated palisading nuclei that alternates with acellular zones which consist the process of Schwann cell. So if you see here, this region here has the nucleus packed, stacked and parallel. And this region here is the region which consists the process of Schwann cell. Looking in that figure, this area here consists the nucleus and the other one here is the nucleus, packed, stacked, arranged. And this region here, which I am drawing in a circular region, consists the process of the Schwann cells. And in my case report, the patient was 5-month-old, female mixed breed dog. And during the general clinical examination, the mass was firm and the dimensions of it was 3 centimeter into 2 centimeter in size. And it wasn't painful in palpation. And the mass lied in the sternal area within the subcutaneous tissue. Except for the mass, the dog was otherwise healthy. So making up the differential, I listed out foreign body granuloma, follicular cyst, excessive granulation tissue formation, nodular paniculitis, and cutaneous hamartoma. We did an FNA, and the FNA revealed a population of spindle cells with moderate cellular and nuclear atypia in the absence of concurrent inflammation. Following an FNA, a surgical appointment was made and the mass was excised. Later, at 7 months of age, there was recurrence of the mass, and again surgery was done, mass was excised, and this time histopathology was done to see the changes. And during the second excision of the mass, the dimension which was excised was 16.5 centimeter into 15 centimeter in size, and the mass was multilobulated, firm in consistency, and white to gray to white in color. The same regions, but I discussed in the previous slide, were found in the histopathological results. There was Antony A area with high densely packed cells, and Antony B area with less cellular area, and verrucate body, which are a significant feature of Antony A area, which consists stacked palisading nucleus in two rows, and alternating region that consists the process of Schwann cell. With histopathological features, we were mostly consistent with PNST, but there are some other tumors that mimic the histopathological features of PNST also. They are low-grade fibrosarcoma and peripheral vascular wall tumor. So to confirm the diagnosis, there are some immunohistochemistry markers which are used in human medicine and as well as veterinary medicine. So we used GFAP, which is glial fibrillary acidic protein from the human-based laboratory, and the test gave weakly positive. The reason could be we tested it from out human lab, and also very few PNSTs are positive for GFAP. Other than GFAP, there are SOX10 or laminin, which are used as additional markers to confirm the PNSTs from soft tissue sarcomas. Sadly, we don't have SOX10 or laminin that can be used in Sri Lanka. Later, after the surgical excision, there were no recurrence which was reported in 7 months follow-up. And after 7 months, the case was lost for follow-up we made. So I would like to conclude, the prognosis will depend on numerous factors, which are histopathological grade, surgical accessibility, and stage. Complete and even marginal excisions are usually curative for grade 1 tumors in dogs, but incompletely or marginally excised grade 2 and 3 tumors will likely recur. And these are the references I used to build up this presentation. Thank you very much.
All right, thank you, Dr. Nirujan, thank you for representing your group work. The audience is open for the questions. Dr. Randika has some question, I think.
Yeah, Dr. Pidas, actually, so you just removed some, lumps on the skin, and you did for, what do you call pathological, you have with some pathological findings. So what is the clinical significance of this, your research? Actually, wow, I mean, you can have this kind of tumors in dogs, but I mean, what is the clinical implication, and what is the significance actually of this finding?
Hello, sir. Can everyone hear me first?
Yes, yes.
Yeah. The clinical significance means in the case which was reported to veterinary teaching hospital, the patient was clinically fine and that mass was there, but in with the age, this mass grows and it could compress the other structures around there, or it can lead to some infections and cause the death of the patient.
Right. This is actually, subcutaneous, in the mass found on the sternal area, right? On the chest area. Yeah. But it's a localized lesion, right?
Yeah.
So do you believe that it can go into deeper layers and can cause the, fatal conditions in the dog, is it?
Yes, I believe in that, as these PNSTs could develop in deeper regions of the dog. So luckily in our case, the mass developed on the sternal area. But if the mass develops within the body, so there are high chances of compressing, and because as the patient had it visibly out, it was easy for us for the diagnosis. In the sense, if it's developing inside, it would be very hard to come for the diagnosis. So the mass could have been pressurized the other organs and lead to the death.
But there are no other organs in, in that area. I mean, just, it's a soft tissues and, subcutaneous organs are there. I don't think it can make, very big harm for the animal. On the other hand, when you do the surgery, you can have some remnants, in the the same area of the surgery. So it can cause again, usually you get relapses. Yeah, it's a common thing, right?
Yeah.
Thank you, Dr. Guruvardhana, for raising questions and put some input. Thank you, Dr. Nirujan, for joining with us today. So we will move to the next presentation. This is about the immune-mediated hemolytic anemia in dogs, and 1 year all retrospective survey at 1 year retrospective survey at the Veterinary Teaching Hospital, Peradeniya, by BMLN Bandaranayaka, KARK Pereira, ERKV Edirimanna, DRA Disanayaka, and H. Ariratna. So Dr. Bandaranayaka, the screen is yours.
Hello everyone, my presentation is on immune-mediated hemolytic anemia in dogs, a 1-year retrospective survey at the Veterinary Teaching Hospital, Peradeniya. First of all, I will briefly go through introduction. IMHA is development of inappropriate immune response against host antigens and causing intra or extravascular hemolysis resulting in anemia. It is a common cause of anemia in dogs. Mean age of onset is 6 years. Cocker Spaniel, miniature schnauzers, poodles, Old English sheepdogs, and collies were shown to be more susceptible to IMHA than the other dog breeds. However, variations in breed predisposition may vary according to the geographical overrepresentation of certain breeds. Mortality rate is high in dogs with IMHA, it's nearly 70%, therefore early diagnosis and treatment is crucial. There are 2 types of IMHA according to the causative agent of hemolysis. They are primary and secondary. Primary IMHA is the most commonest form, which accounts for 60 to 75%. In primary IMHA, antibodies are produced against RBC surface antigen in the absence of an underlying disease. In secondary IMHA, anti-RBC antibodies are produced consequent to another disease conditions like infectious diseases, mainly hemoparasitism, drugs, vaccination, and neoplastic disorders. Hemoparasitism. Common vector-borne hemoparasites in dogs shown to cause IMHA include Babesia, Ehrlichia, Anaplasma, Mycoplasma, and Diphtheria. Several Babesia species were shown to cause IMHA in dogs, while Babesia gibsoni is the mostly reported species to cause IMHA in dogs. When Babesia species infect RBC, antibodies are produced against the organism, could result in immune-mediated RBC destruction. Severity of IMHA depends on the involved Babesia species, age, breed, concurrent infections, immune and pathophysiological status of the dog. Ehrlichia is an intracellular rickettsia. Some dogs with chronic ehrlichiosis were shown to cause IMHA. Pathophysiology. Immune-mediated hemolysis is a type 2 hypersensitivity reaction. Anti-RBC antibodies attach directly or indirectly to various components of RBC membrane, causing extravascular or intravascular hemolysis and intravascular RBC agglutination. The degree of red blood cell lysis depends on the type and amount of the antibody that binds to the RBC membrane. Diagnosis. As there are no gold standard tests to diagnose IMHA, evidence from various analyses are combined with history and clinical examination findings can be used to confirm diagnosis. In FBC and blood smear of dogs with IMHA frequently show moderate to severe anemia and high MCFC values. Although not specific for IMHA, most relevant finding in blood smear is oocyte. Other finding is gauze cells. Saline dispersion test can be performed to differentiate rular formation from autoagglutination. For that, have to mix 1 drop of blood to 4 to 9 drops of saline. True agglutination is seen grossly as persistent speckles even after dilution with saline and microscopically as non-linear clumps of RBC as seen in the image. Coombs test detects antibodies of complements present on RBC surface. A positive Coombs test result would support a diagnosis of IMHA, while a negative test result suggests a non-immunological cause of hemolysis. In serum biochemistry and urinalysis, hyperbilirubinemia or hemoglobinuria can be seen. Objectives of the present study are to assess the signalment of dogs with IMHA, to address hematological findings in dogs with IMHA, and to identify the possible causes for IMHA. For that, did a 1-year retrospective descriptive analysis of canine IMHA cases presented to the veterinary teaching hospital from March 2021 to March 2021. Results. Total 63 cases were diagnosed as IMHA in that period, and from that group, more males were reported than females, it 63%. When considering the age group of animals, nearly half of the group is less than 5 years old and other half is more than 5 years old. Crossbreed dogs, Labradors, and Rottweilers are more frequently reported than the other breeds. Then move on to the presenting complaint and general clinical examination finding. All the dogs were either anorexic or hyperexic at the time of presentation. Few had vomiting, diarrhea, abdominal distension, incoordination, dyspnea, hematuria, and epistaxis like non-specific clinical signs. In general clinical examination, 65% of dogs had pale mucosa, 58% had bounding pulse, 44% had fever, and 36% had jaundice. When considering the hematological findings, anemia can be graded as mild, moderate, and severe. Most of the dogs had severe anemia, and 8 out of 63 had moderate anemia. Anemia is regenerative in 27 dogs. Concurrent anemia and thrombocytopenia was reported in 16 dogs. In blood smear, all the dogs had spherocytes and nearly half of the population had gall sacs. Important factor, hemoparasites were reported in 41 out of 63 cases. Most were affected by Babesia gibsoni, it's more than the half of the population. 6 were affected by microfilaria. Other findings obtained from the current survey are 14.3% dogs were previously treated for hemoparasites, 2 dogs were treated with antibiotics, and other dog was given erythropoietin. Discussion and conclusion. In this study, majority of dogs treated with IMHA are purebred males. Presenting complaint and general clinical examination findings are non-specific and not helpful to arrive at a definitive diagnosis. Therefore, it is essential to perform necessary laboratory investigations to arrive at a diagnosis. All the patients diagnosed with IMHA had spherocytes. Therefore, presence of spherocytes in anemic dogs should perform further diagnostics for IMHA. Further, 65% of dogs diagnosed with IMHA had concurrent hemoparasites. Therefore, it is possible to have an association between hemoparasitism and IMHA. Without the relevant previous clinical records, it's difficult to confirm that hemoparasitism is the triggering cause. Few dogs were previously treated for hemoparasitism, and it was uncertain that drugs used to treat the hemoparasitism may triggering IMHA or any other factor. Due to the presence of many confounding factors, it is difficult to determine whether IMHA in these dogs is either primary or secondary. Thank you. This is the end of my presentation.
All right, thank you, Dr. Nishade. I hope you are joining with us today through the online. So the paper is open for the questions from the audience.
Shall I ask one question?
Yeah, please.
Can you hear me?
Yes, sir.
So how did you diagnose IMHA in this case? Scenario.
Mainly, we consider a spirocytosis in the blood smear. More than 5 spirocytosis is the main factor we have considered. But in some cases, we received 3 to 5 spirocytosis.
So I disturb you. So how do you confirm? What is the confirmatory test to diagnose this IMHA?
As there are no gold standard tests, we choose many tests and select the patients. Spirocyte and Gauss saline agglutination test likewise.
Have you done a Coombs test?
No, sir. We don't have
agglutination test.
We don't have facilities tests.
So then, how do you confirm this as IMHA cases? Because you have to at least test with the reputed test. So just based on the morphological findings and other clinical findings, you cannot confirm the disease. Maybe you are giving wrong.
Yes, this is a retrospective study.
Even retrospective studies, so you cannot confirm it. You can suggest it as a IMHA disease because you haven't done the confirmatory test.
Yeah, I have another question. In your abstracts, doctor, you are saying that the drugs used to treat hemoparasitism cause IMHA as the dogs had been treated for hemoparasitism previously. So that, I mean, how do you confirm that whether the dog has been given these drugs, and for those drugs actually are consequence to that, giving that drugs, those drugs can cause IMHA. I mean, what is the base you are using to that statement?
Sorry, sir?
Idiopathic statement you are giving that. I mean, there's no scientific basis. Up to my belief, you say that maybe the drugs, like, I mean, anybody can say that, any layman can say that. No, yeah. What is the scientific basis of that statement you are reporting here?
So in the literature, there are some evidences, some drugs causing IMHA. So we didn't confirm that, but we suggest that it may also causing IMHA.
And what are the drugs I mean, in the literature can cause IMHA?
There are cephalosporins, penicillins, acetaminophen, levamisole-like drugs.
So this study says that these dogs have been given with those drugs?
No, sir. Other than these drugs, they use many various drugs.
Okay, thank you.
So do we have any questions from the table? So if not, so thank you very much, Nishadi Bandaranaike, for joining with us today. So we will move to the last presentations in the morning session of clinical session. This is about the cytological diagnosis of sinonasal carcinoma in a German Shepherd dog. This is also coming as a case report from WMNS Vijay Surya, WRJP Valpola, Atilianage, Edangola, DDND Silva, Janice Vijay Korn, and H. Arya Ratna. Dr. Vijay Surya, so you can start your presentation.
Hello everyone. Today I'm going to present a case report, cytological diagnosis of a sinonasal carcinoma. Sinonasal tumors arise from the lining epithelium of nasal cavity, paranasal sinuses, or serous or mucous glands in the upper respiratory tract. According to literature, 88% of these sinonasal tumors located in the nasal cavity, especially in the caudal region, while about 6% located in the sinuses. Most of these tumors are malignant and a small amount is benign. Approximation for the prevalence of sinonasal tumors are about 1% of all neoplasia. Sinonasal tumors can be classified as epithelial tumors, mesenchymal tumors, and tumor-like lesions. Epithelial tumors arise from the nasal epithelium. Normal nasal epithelium has a divergent differentiation based on the anatomical location within the nasal cavity. Thereby, the tumor type also differ. Examples for epithelial tumors are adenocarcinomas, transitional cell carcinomas, and squamous cell carcinomas. Mesenchymal tumors arise from the mesenchymal tissue, such as connective tissue. This includes bones, adipose tissue, muscles, fibrous tissue, and blood. Examples for mesenchymal tumors are fibrosarcoma, chondrosarcoma, osteosarcoma, leiomyosarcoma, rhabdomyoma, and hemangiosarcoma. Tumor-like lesions include olfactory neuroblastoma, neuroendocrine carcinomas, polyps, transmissible venereal tumors, and malignant melanomas. Of all sinonasal tumors, 2/3 are carcinomas and 1/3 is sarcoma. Most prominent feature of sinonasal tumors is the slowly and insidiously expanding space-occupying mass in the sinonasal region. This may invasive and cause destruction of adjacent structures. As a result, functional loss of associated structures may occur. Another prominent clinical sign is unilateral or bilateral nasal discharges. These discharges can be mucopurulent or blood-tinged. In association with above presentation, sneezing, dyspnea, ocular discharges can be seen. In advanced cases, animal may develop facial deformities and exophthalmos. There is a high possibility of invasion of the tumor through the cribriform plate into the cranial vault and brain. This may cause neurological signs including behavioral changes, seizures, circling, visual defects, and ataxia. Presumptive diagnosis can be made by skull radiography. It may reveal presence of soft tissue densities within the nasal cavity and bony disruption. Definitive diagnosis requires biopsy to perform cytology and histopathology. Computed tomography is recommended to support the diagnosis and evaluate the extent of the tumor. Now let's move to our clinical case, which was presented to Veterinary Teaching Hospital. This is Sandy, a canine German Shepherd, female, intact, 5 years old animal. Complaint was presence of a soft tissue swelling on the forehead. This was gradually developed over 3 months. During the general clinical examination, animal was bright, alert, and responsive. There was bilateral hyperemic conjunctiva and hyperemic oral mucous membranes. The soft tissue swelling on the forehead is approximately 3 by 3 centimeters in size. There was oxophthalmos in the right eye. Animal was having obstructive breathing pattern with inspiratory stridor. No abnormality was detected in other body systems. Based on the general clinical examination findings, we came to differential diagnosis. This includes bone fracture and callus formation, neoplasia including chondroma, chondrosarcoma, sinonasal tumors and lymphoma, fungal infections like chronic fungal rhinitis. During radiographical examination, soft tissue mass in the frontal sinus region was identified. And also there was incomplete frontal bone lysis. However, cytology or histology is essential to confirm the diagnosis. Here we used fine needle aspiration to yield identifiable neoplastic cells. Figure A shows you the view in low power. Here you can see cell poor areas with windrowing. Most of the sinonasal carcinomas associate with production of mucus. They appear as amorphous pink staining material. Presence of mucus causes arranging RBC in lines, which gives a windrowing appearance. In figure B, there is an atypical population of epithelial cells arranged in variably sized clusters in a hemodiluted background. This figure shows you clusters of epithelial cells. They are arranged, they are round to polygonal cells with large round central nuclei. Nucleoli is prominent in these cells. This black arrow shows you variably sized vacuoles present in the cytoplasm. Anisocytosis and anisokaryosis was observed moderate to high. The condition was diagnosed as a sinonasal carcinoma based on the cytological examination. Under available facilities at the Veterinary Teaching Hospital, surgical removal of mass contents were recommended. Surgery was done under general anesthesia. Contents were highly mucoid and semi-solid, therefore most of the contents were removed carefully. Bony structures were left intact. Drainage was applied in order to drain remaining contents. Definitive diagnosis should be made based on cytology and histological examination. But in this case, radial
the moment. Thank you, Dr. Vijay Surya. So the paper is open for the questions and inputs.
Doctor, you attempted any surgery on this dog, or the dog is survived? What happened after the,
Hello, can you hear me? Can you hear me? Can you hear me? Can you hear me? Hello, can you hear me? Yeah, we did a surgery just to remove the contents in the sinonasal region because in the surgery also we did not remove all the contents because the bone in the frontal bone also lysis. There was an incomplete lysis of the frontal bone. So we leave the bony structure and we remove contents as much as possible. The contents also like semi-solid and highly elastic contents, and we applied a drainage to drain the remaining structures.
Thank you.
Two. Two. Two.
U.S. soybean farmers are proud, resilient. Some even call us, yep, we admit it, stubborn. We keep our promises to our families, our community, and to the earth. Sustainability isn't just a label, it's our livelihood. Our grandfathers remember when drought and over-farming in the 1930s turned our land to dust. That was about 75 years ago when our country put into place some of the world's most stringent resource protection laws. Today, U.S. soybean farmers are partners in trust to protect the land. We approach our mission as if the world depends on us, because in many ways, it does. More soybeans are grown here than anywhere in the world. 80 million metric tons a year. Of sound science and continued research over the past 30 years, we have increased soybean yields by 55% on roughly the same amount of land. U.S. soybean farmers have reduced carbon emissions, energy use, greenhouse gas, and soil erosion. We're licensed to use pesticides, insured to protect workers' rights and safety, and our assurance programs are verified. We're meeting U.S. laws and international sustainability standards. And to validate our compliance, a team of 3,000 career conservation agents throughout the country and continual verification through surveys, interviews, field observations, and electronic data that we're operating our farms in compliance with stringent environmental laws. Our commitment is more than just a neighborly agreement. Independent peer-reviewed research verifies U.S. soy is sustainably produced with comprehensive data demonstrating that U.S. producers are compliant with the vast majority of our hectares already subject to annual audit by the USDA. And because we are driven by a commitment to continuous improvement, we're incorporating soil testing, plant tissue analysis, satellite positioning that precisely adjusts crop inputs, and much more. Why? To ensure that every link in soybean production is sustainable and to live up to our commitment as stewards of the land. If a U.S. soybean farm could tell its own story, it would be a legend, complete with dedication, resilience, compassion, and above all, successful, sustainable perseverance that lives to tell the story all over again. United States soy, verified sustainable. Learn more about our U.S. Soy Sustainability Pledge at ussec.org.
United States, there are about 2.2 million farms. We stand together and ready to continue to grow and produce the food that fuels the world.
U.S. soybean farmers are proud, resilient. Some even call us, yep, we admit it, stubborn. We keep our promises to our families, our community, and to the earth. Sustainability isn't just a label, it's our livelihood. Our grandfathers remember when drought and over-farming in the 1930s turned our land to dust. That was about 75 years ago when our country put into place some of the world's most stringent resource protection laws. Today, U.S. soybean farmers are partners in trust to protect the land. We approach our mission as if the world depends on us, because in many ways, it does. More soybeans are grown here than anywhere in the world. Roughly 80 million metric tons a year are raised on over 30 million hectares of land. As a result of sound science and continued research over the past 30 years, we have increased soybean yields by 55% on roughly the same amount of land. U.S. soybean farmers have reduced carbon emissions, energy use, greenhouse gas, and soil erosion. We're licensed to use pesticides, insured to protect workers' rights and safety, and our assurance programs are verified. We're meeting U.S. laws and international sustainability standards. And to validate our compliance, a team of 3,000 career conservation agents throughout the country and continual verification through surveys, interviews, field observations, and electronic data that we're operating our farms in compliance with stringent environmental laws. Our commitment is more than just a neighborly agreement. Independent peer-reviewed research verifies U.S. soy is sustainably produced, with comprehensive data demonstrating that U.S. producers are compliant with the vast majority of our hectares already subject to annual audit by the USDA. And because we are driven by a commitment to continuous improvement, we're incorporating soil testing, plant tissue analysis, satellite positioning that precisely adjusts crop inputs, and much more. Why? To ensure that every link in soybean production is sustainable and to live up to our commitment as stewards of the land. If a U.S. soybean farm could tell its own story, it would be a legend, complete with dedication, resilience, compassion, and above all, successful, sustainable perseverance that lives to tell the story all over again. United States Soy, verified sustainable.
Ladies and gentlemen, welcome back. So we're finally have come to the final phase of the clinical session, which would be once again co-chaired by Dr. Suranj Vijay as well as Dr. Dani Sirivardhana. So I should once again give the control to the two chairs of this session.
Let's start again. This is cutaneous asthenia in a Rottweiler. K.A.R.K. Pereira, T. Apinayan, K.N. Vijayavardhana, H.M.S. Vijay and D.D. N.T. Silva.
Hello everyone. This presentation is regarding a rare disease, cutaneous asthenia, which is a connective tissue disorder. First of all, I'd like to give you an overview of the disease. It is a multiple, heritable, congenital defect of dermal connective tissue. This disease is also described in various names like dermatosparaxis, collagen dysplasia disease, hyperelastosis cutis, and rubber puppy disease. It is similar to Ehlers-Danlos syndrome in human and also reported in cats, minks, cattle, and sheep. Clinically, it is characterized by hyperextensibility, which means the ability of the skin to stretch beyond the normal limits with loose attachment to subadjacent tissues, and also decrease tensile strength, which means minor trauma can result in lacerations, large gaping wounds, which is termed as fish mouth appearance. It has been reported in many breeds like boxers, dachshunds, beagles, English Spaniel, Saint Bernard, German Shepherd, but not reported in Rottweiler set. Now let's move on to the clinical case. The signalement of the patient was Shadow, a 9-month-old male Rottweiler weighing 17 kilograms. Animal was presented to the veterinary teaching hospital with a complaint of hyperextensibility of the skin and frequently getting injured, which caused small wounds with minimal bleeding. The lesions were prominent over joints, especially elbows and perineal regions. They have been treating for these conditions since the puppy was 3 months with many systemic antibiotics and topical applications and etc. But no improvements has observed, in fact, getting worse and recurrence of wounds irrespective of the treatment and management. In general clinical examination, no abnormalities were detected in vital parameters. Appetite and water intake were normal. Bilateral perineal swelling, and on right perineal region, a circumscribed wound with a necrotic foci and exudates was present. As presented in the complaint, skin on the dorsum, especially the neck area, lateral thoracic, and cranial to thighs, could be stretched far beyond the normal limits, indicating loose attachment of the skin. Differential diagnosis for this condition is very rare since the disease is highly distinctive with the presentation of lifelong history of hyperextensible, fragile skin with gaping wounds from minor trauma. Therefore, diagnosis is mainly based on clinical signs, extensibility index, and histopathological findings. As mentioned earlier, main clinical signs of this disease are hyperextensible fragile skin with gaping wounds. The extensibility index is used to quantitate the extensibility of the skin, and it is the ratio of the vertical height of the dorsolumbar skin when traction is applied compared to the body length from the occipital crest to the base of the tail. Normal values are 8% to 15%, while those of affected animals are 17% to 25%. Normal histology using hematoxylin and eosin staining is described with defects in collagen fiber, orientation, packing, and number. As shown in these images taken from histopathology, the collagen fibers are characterized by shortening, disarray, uneven size, and widening of the interfibrillar space. This is a magnification showing the disarray arrangement of the collagen bundles, collagen tissues, and this is showing the widening of the interfibrillar space. No significant abnormalities were detected in full blood count, blood smear, biochemical panel, and other than a moderate leukocytosis. Skin scrapings were negative for ectoparasites, and moderate bacterial infection was observed. Impression smears from the right perineal lesion was obtained, which revealed degenerating neutrophils, fat droplets, and intracellular bacteria in neutrophils. No specific treatment has been reported in dogs, although oral administration of vitamin C has been suggested since it is necessary for collagen synthesis. Moreover, surgical excision and closure to remove extra hyperelastic skin folds and antibiotics for wound healing can also be used. In this case, in the first visit, wound dressing was done with oxoferrin, and owner was advised to start antibiotics, vitamin C, and to provide soft beddings to the dog. But in the follow-up, after 5 days of the first visit, the skin lesions has got worsened than earlier. Bilateral perineal swelling has increased, resulting in hanging skin folds with ruptured, ulcerated, large open wounds. Therefore, to reduce the gap, surgical correction was suggested. In the surgery, skin folds that are hanging on either side of the perineal region were surgically removed, and both subcutaneous tissue and skin was sutured with simple interrupted suture pattern using Vicryl and nylon respectively. However, patient was present back after 3 days of the second visit, and complete suture adhesion was observed in the skin with worsened condition. Since the prognosis of this disease is poor, patient was euthanized upon the request of the owner. Discussion and conclusion. A case of cutaneous asthenia is documented in a Rottweiler in this study. The main methods used to diagnose this disease are clinical signs, skin extensibility index, and histological evaluation. Unfortunately, we couldn't able to check the extensibility index in this dog, which is a lap of in this report. The diagnosis in this mainly based on clinical signs with hyperextensible skin, poor wound healing, and histopathological findings.
Thank you. Paper is open for discussion. Can I ask the first question? regarding this surgery to reduce the skin extends the flaps, the author said like she used white field suture material, and then thereafter, after 3 days, he came with suture adhesion in such a big flap. Why were you using white field?
Actually, we have used some phonote. I remember as a phonote white field for the tissues, and then eventually the skin and subcutaneous were sutured by nylon, not the outer layer by white field.
Even inside, it can harbor more because the wound is so extensive.
Exactly.
So because it's braided material, it can harbor a lot of bacteria. That's my first question. And the second one, like for in these cases, have you studied any blood supply to the skin is affected in any way?
Why with the surgery?
No, in this hyperextensibility of this particular condition, blood supply is low, or is there anything there?
Not especially its effect on the blood supply, but particularly collagen fiber is the matter, because especially collagen type 1 and 2 get disoriented. And due to that condition, we perhaps that's why the wound healing is delayed.
Thank you. Dr. Sugat?
Yeah, it's a good presentation. I want to know whether we can use collagen fibers instead of that surgery. Just with there's a powder, collagen powder with antibiotic. Can we use that?
Collagen, again, can you just repeat? Sorry.
There's a commercial product, collagen fibers, right?
Exactly.
Normally it's come with the powder form with the antibiotic. Can we use that?
Perhaps we can use for a certain level, because it's a localized conditions for that particular place we can put it, but it's when it consider it's a not just local, that fine, it's a generalized condition all over the body, it's there, and it's also coming like inherited condition, so maybe the treatment will be temporary, but the thing is, I think we have to more consider when they are going to breed. We have to think more, and because this is a definitely poor prognosis patient, so we have to think seriously.
Any more questions? Okay, thank you, Dr. Suvanchi.
Thank you very much.
We will move to the next one. Soft tissue sarcoma in dogs, 2 case reports. BMLN Bandaranayaka, WRJP Walpola, AT Lienage, TMSK Piyadasa, C. Abekon, HMS Vijayakon, ERKV Edriman, and DDND Silva.
Hello everyone, my presentation is about soft tissue sarcoma in dogs, 2 unusual cases presented to the veterinary teaching hospital, Plenary. Before moving on to the clinical cases, let me present the background of soft tissue sarcoma. Soft tissue sarcomas are malignant tumors of mesenchymal origin. Those account for 15% of all skin tumors and 7% of all subcutaneous tumors. It may occur in any anatomical location such as muscle, adipose, neurovascular, facial, and fibrous tissues. There are many types of soft tissue sarcomas as fibrosarcoma, peripheral nerve sheath tumors, which is the most common type of cutaneous and subcutaneous soft tissue sarcomas, myxosarcoma, leiomyosarcoma, rhabdomyosarcoma, synovial cell sarcoma, lymphangiosarcoma, sarcoma, and undifferentiated sarcoma. Clinical features: there are no apparent breed predisposition, but prevalent among middle to old age, medium to large breed dogs. Sex-or-neuter status does not appear to have any influence on disease development or progression. Soft tissue sarcomas most commonly appear in limbs and trunk. Metastasis. Sarcomas are metastasis hematogenously in up to 20% of cases, mainly pulmonary metastasis, and also into regional lymph nodes. Soft tissue sarcomas are locally aggressive and can proliferate through and along fascial planes, making excision with clear margins difficult. There are several prognostic factors for canine soft tissue sarcomas have considered in literature. It includes histologic type, histological grading, degree of resection and completeness of surgical margins, mitotic index and proliferation markers. There are three categories according to the completeness of surgical margins. They are incomplete, complete, and closed margins, according to the distance between surgically created tissue edge and neoplastic cells. For histological grading, three criteria have to be investigated. They are tumor differentiation, mitotic index, and pattern of tumor necrosis. This is the way of histological grading of soft tissue sarcomas. Each criterion again divided as this and each one get a score. Finally, have to take the total score and according to that, histological grade can be obtained. This table illustrates how the histological grade and completeness of surgical margins affects the prognosis. Metastasis is rare in grade 1 and 2 tumors, and in grade 3 tumors have greatest probability to metastasis. When considering the recurrence after the surgery, it may vary according to the completeness of the surgical margins. If there are close margins, recurrence is infrequent in grade 1 and 2 tumors. Recurrence is more likely in grade 3 tumors. Recurrence is rare in both grade 1 and 2 tumors in complete margins. Recurrence is less likely in grade 3 tumors, even in complete surgical margins. There are many treatment options. Among them, surgery is the treatment of choice. Surgery alone can be curative for low or intermediate grade tumors. The risk of regrowth after surgery and metastasis also depends on the tumor grade. Chemotherapy helps delay the onset of metastasis. Other treatment options are radiation and electrochemotherapy. Then move on to the first case study. Tina, 6 years old, German Shepherd male dog, presented to the veterinary teaching hospital with a complaint of lump on right flank since 4 months. It looks clinically normal other than the firm to hard mass on the right flank. Previously treated with antibiotics and topical medications, but no improvement. Then fine needle aspiration from the mass was done and it contains fibroblasts in the collagenous matrix. These are the radiographs of Tina. It is having an ovoid mass with soft tissue opacity surrounding the last 4 lumbar vertebrae on the right side. When Tina was moved into the surgery, black arrow shows the lump. Dog was anesthetized and placed on left lateral recumbency and linear incision was made on the top of the mass along the length. Carefully dissected the attachments of the tumor while cauterizing the blood vessels. One side of the mass is attached to the transverse process of the lumbar vertebrae. This is the removed mass weighing 2.2 kilograms. Then the dead space was reduced by suturing the subcutaneous tissue and the samples are sent for histopathological examination. This neoplasm composed of spindle cells arranged in long interlacing streams and bundles in a collagenous matrix, and the black arrow shows the small aggregates of lymphocytes and plasma cells. Red arrow shows the elongated nucleus with finely speckled chromatin and indistinct cell borders. Mitotic index is low in this neoplasm. Prognosis of Tina was good and no recurrence after the surgery. Then the second case, Ollie. It is a German Shepherd, 6 years old male, presented with reduced appetite and gradually enlarging abdomen since 2 weeks. It was having a history of pig fever. Clinical examination revealed hypothermia, pale mucosae, dehydration, and hard abdomen. At the presentation, it was having anemia and thrombocytopenia. In ultrasound examination, it was having benign masses with different echogeneicities, moderately vascularized with clear margins. Gallbladder was distended with biliary sludge and splenomegaly was evident. Radiographs were taken in order to check the metastasis, and there was no metastasis. Due to the low blood counts, blood transfusion was done prior to the surgery. The mid-ventral incision was made. The mass is located inside the abdomen, surrounded by the mesenteries, and the one side of the mass located over the caudal vena cava. This is the removed mass. It weighs 7.1 kilograms. This is the histopathological images. Histopathological examination shows the neoplastic cells are spindle shaped, nuclear and cellular pleomorphism is minimal, and cytoplasm is amphiphilic with occasional vacuolations. Prognosis. Animal was normal after the surgery, but it was died after 4 days of discharging. Discussion. In case number 1, histological appearance along is suggestive of a low-grade sarcoma with a non-aggressive behavior, but this tumor grows rapidly within a short period of time, and its locally invasive nature, this can be categorized as a histologically low-grade, biologically high-grade fibrosarcoma. Such types of tumors reported to occur in maxilla and mandible regions in dogs. In case number 2, it is difficult to identify the origin of the neoplasm with the histology alone. According to the histological features, most likely differentiate include peripheral nerve sheath tumors, fibrosarcoma, leiomyosarcoma, and gastrointestinal stromal tumors. Both cases are grade 1 soft tissue sarcoma. This is the end of the presentation. Thank you.
Thank you. The paper is open for discussion. In the second case, have you done the lung X-rays for any metastatic lesions?
Yes, madam. Second case is that.
No, they haven't. No, that's the first one, I think. The one who died, the second case?
Yes, madam.
Have you done the chest X-rays?
Yes, madam, but we couldn't get the chest X-rays of the first case.
And yeah, my question is, I mean, in the second case, you removed a mass of around 7 kilos, right, from the dog.
Yes.
Yeah, how did you manage the hypovolemia in the dog after the surgery?
We maintain a slow drip.
That's all, right? Yeah.
Yes.
What do you think about the reason for the death, doctor?
It's having some complications like anemia, thrombocytopenia, like things, and yeah, I think these are reasons.
Thank you. The next presentation is high-grade sarcoma of the maxilla in 1-year-old Labrador Retriever, a case report. A.T. Liyanage, WMNS Vijaysurya, TMSK Piyadasa, WP Valpola, H. Aryaratna, HMS Vijayakon, and DDND Silva.
Hello everybody, I'm Harsha, and my presentation title is High-Grade Sarcoma of the Maxilla in a 1-year-old Labrador Retriever. This case was presented to the Veterinary Teaching Hospital, University of Peradeniya. And as this is a case of oral neoplasia in the dog, I would like to briefly discuss about oral neoplasms in dogs. Oral neoplasms are common in dogs, and these neoplasms account for approximately 6% of all tumors in dogs. The most common types include melanoma, squamous cell carcinoma, and fibrosarcoma. As this is a case of fibrosarcoma, I'm going to briefly discuss about fibrosarcomas in dogs. And oral fibrosarcomas account for 8 to 25% of all canine oral tumors, and middle-aged 7 to 9 years old large breed male dogs are mostly affected. Predilection sites include maxillary gingiva and hard palate, and occasional lymph node metastasis and distant metastasis is reported. Usually, these neoplasms are grossly flat, firm, ulcerated masses in the oral cavity. And bone involvement is a common thing. Best method of treatment is combination therapy with surgery and radiotherapy. Surgery or radiotherapy alone is shown to be less successful, and chemotherapy is shown to be not very effective treating fibrosarcomas in dogs. Prognosis is good if surgery and radiotherapy, a combination of radiotherapy and surgery is used, otherwise it is guarded. Usually the cause of death is the local disease. And this is our case, and it's a 1-year-old female Labrador retriever. The presenting complaint was difficulty in breathing, and during the general clinical exam, it was identified that there is a severely erythematous and ulcerative flat firm mass in the oral cavity. The size was approximately 7 centimeter into 2.5 centimeter. The mass was spanning the upper palate, mostly in the soft palate, and also it was occupying part of the caudal hard palate. And the differential diagnoses from the gross appearance were foreign body granuloma, giant cell granuloma, transmissible venereal tumor, and other neoplasms were considered less likely at this stage because of the very young age of the dog. Next thing about the diagnostics, we have obtained fine needle aspirations from the lesion. However, these fine needle aspirations were highly hemodiluted and therefore non-diagnostic. Skull radiographs were obtained, no bone lysis was seen, and all hematological and biochemical profiles of this dog were within the normal limits at the first visit. And mandibular lymph nodes were mildly enlarged, and there were no evidence of tumor metastasis in the thoracic radiographs. At this time, the treatments given included antibiotics and anti-inflammatory drugs, and the case was followed up after 1 week. However, no improvement was seen. The mass was increased in size, therefore it was decided to surgically excise the mass and to send a sample for histopathology. Surgical procedure was conducted under general anesthesia, and it was identified that mass was highly locally invasive and it was extending up to the nasal cavity. Therefore, it was extremely difficult to obtain wide surgical margins. And the histopathology of the mass, I have shown on high power field. The mass was composed of atypical mesenchymal cells arranged mostly in herringbone pattern, and occasionally they were arranged in short fascicles or sheets. The cellular and nuclear pleomorphism of the mesenchymal cells, it was high, and the mitotic rate was 3 per 10 high power fields. However, in some areas, it was quite high, like 4 to 5 were one high power field. And there were atypical mitosis also. The red arrows are pointing to some of the atypical mitosis seen in this tumor. And occasionally there were giant cells. And in addition to these areas, the neoplasm contains some areas with dense collagen bundles. There were no necrotic areas or hemorrhages or prominent inflammatory cell infiltrates within the tumor. But at the periphery of the tumor, there was severe diffuse hemorrhages and also suppurative inflammation denoted by extensive infiltration with neutrophils. And the differential diagnosis from this histopathology included fibrosarcoma, high-grade fibrosarcoma, malignant melanoma, osteosarcoma, and other soft tissue sarcomas. However, these histological features were mostly consistent with the high-grade fibrosarcoma, especially this herringbone pattern. IHC and other advanced histochemical methods are necessary for a confirmative diagnosis. And in the follow-up was done after 1 week of surgery. The patient was presented with tumor recurrence, most probably secondary to incomplete surgical margins, which was very difficult to maintain clean margins during the surgery. And surgical tumor resection again was not attempted because of the limited ability to complete tumor excision. At this time, it was quite large and severely ulcerated erythematous, and the patient's condition was quite deteriorated, and it has reduced appetite and moderately dehydrated, so there was no chance of going for another surgery. The owner was informed about chemotherapy as an alternative. However, at this time, it was difficult to implement chemotherapy. After this visit, we didn't hear about the dog, and it was lost for follow-up. Probably it might have died. And I would like to discuss few points before I conclude the presentation. This is an oral fibrosarcoma with a very aggressive behavior, aggressive biological behavior. It is quite uncommon to see such fibrosarcoma with very aggressive biological behavior in a very young dog. This dog was only 1 year old. And we could only do surgical excision because radiotherapy is not available in Sri Lanka. Maybe if radiotherapy was used in combination with surgical excision, the result might be different. And finally, we don't know what is the cause of having this kind of very aggressive tumor in a young dog. There could be many reasons. We need further studies to identify possible causes. Finally, I would like to thank all of you, and thank you very much.
Thank you. The paper is open for discussion. Can I ask the first question? Now, the first picture that you showed with the maxillary tumor, it looked quite extensive in the maxilla. Why did you attempt to surgically remove the sarcoma and obtain the samples instead of doing incisional biopsies to diagnose? Because you can't do any maxillectomy there because it was quite extensive.
First thing, we tried fine needle aspiration biopsy, which was not very useful. It was quite hemodiluted. And to take an incisional biopsy, you ask about incisional biopsy, right?
Yeah, multiple incisional biopsies from the maxilla would have helped for a definitive diagnosis.
It would have helped, but at this time, the owner was not, he didn't like for us to go for one biopsy selection for without going for surgery. Like it needs 2 times of sedation and anesthesia. So he didn't opt for that. That's why we didn't go for incisional biopsy and it was directed to surgery.
In oral cavity tumors, that's something important because when the tumor is extensive, obviously, you get a bigger sample so that you explain it to the client because you are macerating the whole wound in the mouth and you're putting to a lot of welfare problem in the animal. No? Once you diagnose, then you can discuss the prognosis and, thereafter do the necessary thing.
Actually, we have discussed that with the client, but then we have to say that what's the outcome also. Like if it is a tumor, then we have to tell him that we are going to do a surgery to remove it. Then when we have given those 2 options, he said, why not to go for the surgery at the first run? That's why. So we cannot go against his wish. Therefore, we couldn't do incisional biopsy beforehand. I know it's a very good thing to do, but with our circumstances and with our client's knowledge and other things, in our context, sometimes it is difficult to achieve.
Yeah, my basic question is actually, we get a lot of such tumors in dogs. So I mean, so we attempt to sometimes surgically remove if it is not extensive. And so you attempted the surgery and did a good job maybe, and the second time it relapses and the prognosis was poor. The dog maybe it's not the prognosis very poor. So what made you to have this case to present? Like, I mean, what is the significance in this finding? I mean, to make a case of this. I mean, to present here, like, I don't know.
Okay, there are 3 things why we reported this case. First thing is we are doing in our field, we are doing kind of evidence-based medicine. So at this point, this is a very young dog. Usually, it's not a very common thing for young dogs to have cancers. So at this point, this may be quite insignificant, but with let's say there's another tumor comes in next year or next month, and those things keep on accumulating, then that will trigger us to search for, okay, there should be some reason why the very young dogs, maybe Labradors, I don't know. So this kind of why this kind of presentation appears, there should be some reason. It could be they are exposed to some kind of environmental carcinogen, or there could be a genetic predisposition for this kind of sarcomas. That's how this scientific knowledge builds up. At this point, this is just a case report, but usually in pathology, we come to conclusions. We decide, okay, this tumor's behavior is going to be like this from many records reported by many clinicians and pathologists over a period of time. That's one thing, that's one reason for reporting. And the second thing, actually, we only have surgical excision, and chemotherapy is not very effective in this kind of tumors. So we wanted to raise this point that it is a very nice thing if we have radiotherapy to treat this kind of tumors. And the third thing about the client education, so client and veterinary education, because when you see this kind of mass in a very young dog, I think at least very vets who are at the starting level might think this is not a tumor, because we always not always. We usually say cancers are not very common in young animals. So this just tells people that okay, it's uncommon, but it is need to follow all these diagnostic procedures, because it may not be a inflammatory lesion, but a neoplastic lesion. Neoplastic lesions may occur in young dogs. So how to approach them? And this procedure is important for client education, communication with clients. So you need to give a process how to follow up the case. That is really important. That's what I feel, why it is clinically important and why we have reported this case.
Okay, thank you.
Thank you, Dr. Harsha. The next presentation is on intestinal phytobezoar in a goat, a case report. BMDM Kularatna, BIU Pereira, GM Vidura, YK Jayavardhana, HEL Diseram, PGA Pushpakumara, and GDRK Pereira.
Hello everyone. Today I will be presenting a case report on intestinal phytobezoar in a goat. The objectives of my presentation is to identify what is a phytobezoar, how to diagnose a phytobezoar, and the treatment for phytobezoar. Let's see what is a bezoar. Bezoar is a mass made up of undigested material, and this material accumulates in the digestive tract. Basically, bezoar are of 4 types. They are lactobezoar, pharmacobezoar, trichobezoar, and phytobezoar. Out of these 4 bezoars, trichobezoar and phytobezoar are commonly found in animals. Lactobezoar are formed by accumulation of milk, pharmacobezoar are formed by accumulation of medicine, trichobezoar are formed by accumulation of hair, and let's see how phytobezoar is made up of. So phytobezoar is made up of aggregated plant material with fiber origin, mainly undigested fiber like cellulose. So this phytobezoar condition is very rare among small ruminants, and it is common among horses. The primary predisposing factor is improper dietary management. When we consider about the anatomy of the digestive system of small ruminants, phytobezoar can occur in esophagus, forestomach, cecum, and the intestines. Now let's see a case which is presented to the veterinary teaching farm and finally diagnosed as the animal was having a phytobezoar. So the animal presented was a caprine, Saanen, female, and the animal was 3 years old. The presenting history and complaint was the animal was off feed for 8 days and the defecation was absent for a few days. The owner was not sure for how many days the animal was not defecating. And this animal was previously treated by the regional veterinarian, and the animal was given liquid paraffin, amoxicillin, and catazole, but no apparent improvement was observed. This animal was also dewormed 3 months ago using albendazole. And the owner was sure that there was no any change in the diet very recently. When we consider about the general clinical examination, all the vital parameters were within the normal range. That is, the heart rate was 82 beats per minute, respiratory rate 22 breaths per minute, body temperature was 103.2 degrees Fahrenheit, and the mucous membrane was pink in color, and the animal was mildly dehydrated. So for diagnosis, we palpated the left and right paralumbar fossa thoroughly. Thereby, we were able to identify an elongated hard mass on caudal-dorsal region of the abdomen. So this mass was readily palpable from the left paralumbar fossa than the right paralumbar fossa. So for further diagnosis, Radiography was performed on the left lateral abdomen, and as shown in the diagram, a radiodense elongated structure was found in the ascending colon. So considering the condition of the animal, as the treatment, surgery was performed. The surgery was done under general anesthesia, and as the sedative agent, psilocin was used, and as the anesthetic agent, ketamine was used. So as in this diagram, the animal was placed on right lateral recumbency, and the hair on the left paralumbar fossa was clipped. And the exact location was identified to put the incision. So as in this diagram, the incision was made and the laparotomy was performed. So after the laparotomy was performed, the hard mass was isolated, and to be found, this mass was isolated from the large intestine. Then a longitudinal incision was made parallel to the long axis of the intestine, just above the mass. And as you can see in the diagrams, to prevent contamination, the mass was covered with gauze. So in this diagram, you can see the exteriorized mass. And here the mass, we can see it is about 14 centimeters in length. So for us to come in to diagnose this as a phytobezoar, because this mass had the features of a typical phytobezoar. Usually a phytobezoar is around 1 to 15 centimeters in length, and the dry mass is around 0.5 to 270 grams, and it is usually yellowish brown in color, and it has a shining appearance and velvet texture too. Most of the time, these phytobezoars are elongated in shape, but it can also be ovoid, trapezoid in shape, cuboidal, and even sometimes be flattened. Most of the time in small animals, these phytobezoar occur in small numbers. But in large animals, this phytobezoar may occur as a single large mass. So when we see the cross-section of this mass, we can see the lamellae appearance of this mass. Therefore, we can be sure that this mass was made by accretion. After the mass was removed, we were able to identify the intestinal tissue which was covering the mass was necrosed. So this necrotic tissue was dissected. And finally, the remaining viable tissue of the intestine was anastomosed. And finally, the laparotomy incision was closed using suturing the peritoneum, muscle layers, and the skin. As post-surgical treatment, wound management was done using primarily Negasant and betadine. And cefuroxime was given as the antibiotic twice daily in IV route. And flunixine was given as the analgesic. And after the surgery, the animal was kept for gut resting for 72 hours. And after 72 hours, chopped grass was introduced. During this gut resting period, fluid therapy was done. So finally, the discussion and conclusion of this case is, this is a rare finding in goats under local management. Most of the time, this type of conditions are not diagnosed by veterinarian because this case may sometimes be asymptomatic depending on the location of the mass. For example, if this mass was present in the rumen or the abomasum, the animal may be asymptomatic. But sometimes this mass also may lead to rupture of abomasum too. So this phytobezoar could be life-threatening. The phytobezoar itself could be life-threatening, and sometimes post-surgical this could be life-threatening. So we must include phytobezoar in the list of differential diagnosis when an animal is present with absence of defecation. So in early stages, thorough physical examination of the abdomen from both left and right side, we can find a hard mass. In early stages, the best treatment is to do a surgery for the animal. But if you find out the prognosis of the animal is poor, the better option is to cull the animal. If you diagnose the animal is in a good condition, and if you perform the surgery, the success rate is around 20 to 30%. I would like to thank SLDA for giving this opportunity to present this presentation, and thank you.
Presentation is open for discussion.
Yeah, actually, doctor, it was a very good attempt. Surgically, you did for the goat, and what about the prognosis of the animal? Animal is still surviving, or he's still? I mean,
no. After, can you hear me?
yeah, it was a good attempt. You did surgically for the goat to remove this this besua from the intestines.
Yes,
and
animal actually.
What is the prognosis?
Yes, animal survived 5 days after the surgery, but the animal passed away after the 5th day.
What do you think about the cause of the death, like peritonitis?
Yes, after the death, with the postmortem, and we were able to find one of the suture was removed, and the peritonitis has occurred. So I think that was the cause for the death of the animal. But yeah.
Dr. Kularatna, it's a nice presentation. I'm just wondering why this sort of hard mass of fibers are collecting. It's because of the type of fiber, type of plant, or any sort of malfunctioning in the gut, or any age specific to get this sort of condition. Have you read about this?
Yes, but in this phytobesua case, the main thing is the diet. Consumption of like poor quality roughages, and sometimes flowering plants like Eriocephalus, and some, according to literature, some plants which are found in Africa, like African sheep bush, will give rise to this type of conditions.
Okay, thank you.
In this study that you have given intravenous fluid, normal saline and lactated drinkers, both. Is there a reason for that?
Sorry, madam. No, alternatively, we gave NS and RN.
What is the reason behind that?
Because the animal already was off food for 8 days, and the animal was not eating, and to like electrolyte, animal was imbalanced. Like to balance the electrolytes, we gave those fluids.
What is the difference between the LRS and the normal saline to have that?
LRS have bicarbonates, and NS does not have bicarbonates.
Sodium chloride is not there?
No, sodium chloride is there, but LRS mainly have a bicarbonate.
In your presentation, you mentioned the dose rate of ketamine as 0.11 per kilogram for goats. Like, I don't know, it's in the literature it says 11 milligram per kilogram, right? Maybe it's right.
Yes, yeah, 11 milligram per kilogram.
Okay.
And after the surgery, was any tetanus toxoid given to the goat?
No, madam. Prior to the surgery, prior to surgery means though they have given tetanus already, like 1 month before.
Okay. Right. Thank you. So let's move on to the next case. Effect of intra-articular injections of platelet-rich plasma for tetanus in a dog. Successful outcome of treatment. A case report. BR Nirujan S. Kabilan and KN Vijayvardhan.
Hello everyone, I'm Nirujan. I will be presenting a case on tetanus and the successful treatment outcome. Tetanus is an infectious disease which is produced by the bacterium Clostridium tetani. Clostridium tetani produces a toxin, a neurotoxin, which enters the neuromuscular system and eventually produces tonic muscular contractions and paralysis. This image here shows a dog which is affected with tetanus. When looking into epidemiology, all domestic animals are susceptible, where cats are more resistant than dogs, and there are no specific age group and sex predilection to tetanus occur. Open wounds are one of the main risk factors which leads to the occurrence of tetanus, and Clostridium tetani is present in environment and there are no specific seasonality. In my case presentation, my patient Nari, canine crossbred 3 years old male, was presented to veterinary teaching hospital, Peradeniya, with a presenting complaint, stiffness in forelimbs for 36 hours. When taking history, it was noted that the patient has lost appetite for 2 days and there were wounds from the barbed wire accident. Completing the general clinical examination, it was listed out that the patient was alert, recumbent, forelimbs were stiff, neck and tail hyperextended, ears were erect, facial muscles were contracted with retracted lips, locked jaw, protruding nictitating membranes, enophthalmos, laceration in both hind limbs, hypothermia, seizures, mild congestion in lungs, and arrhythmia. To diagnose this condition, as there are no practical clinical confirmatory tests, we came to diagnosis using clinical sign and history of recent wound. The wound which were observed in the hind limbs due to the barbed wire was one of the features which led us to the diagnosis. So, deciding the patient with the tetanus, the following treatment protocol was started. The animal was kept in a quiet, soundproof area with minimal stimulation. This is the patient who was kept in a soundproof, quiet, dark room to reduce the minimal stimulation. And you can see the patient is provided with comfortable cushion mattress and eyes are closed to reduce the environmental stimuli and covered in bed sheets. Later, to sedate the animal, we used IV midazolam and serum containing tetanus antitoxin transfusion was provided via IV slowly. To do this, we found a recently vaccinated dog with tetanus toxoid and we collected the blood from the patient from the tetanus toxoid vaccinated dog and we extracted serum and gave the extracted serum to the patient who was diagnosed with tetanus. Antibacterial treatment was initiated. In that, benzyl penicillin and metronidazole was used. Benzyl penicillin was used in 20,000 to 50,000 international units per kilogram and metronidazole was used in 10 milligrams per kg IV. Later, to physically rehabilitate the patient, physiotherapy and applying to harness twice daily for about 15 to 20 minutes was provided. So in this image, you can see the patient is supported with harness and intensive nursing care was provided using IV fluids and nasogastric tube feeding. IV fluids which were given were Ringer's lactated solutions and normal saline and glucose and dextrose. To prevent the decubital ulcers, patient was provided with comfortable cushion mattresses and patient was turned on his sides frequently. To ease and to provide comfort, patient's urine was removed and for this urinary catheter was placed and urinary bladder was emptied frequently. The nutrition and diet which was provided to the patient was high quality blended food, and this was done by placing a nasogastric tube and providing the fresh milk, chicken soup, and fruit juices in this case. So outcome of the patient falls in this list. So day 1, the patient was recumbent. Day 3, tried raising the head. Day 5, movement of the limbs. Day 7, sternal recumbence, defecating and urinating. Day 9, started to crawl and tried to stand without harness. Day 11, stood voluntarily. Day 13, walked and responded to the call of the owner. So these images shows here how the patient responded to the treatment. Day 7, Nari started to stay in sternal recumbency, and day 9, he started to raise his body and stand voluntarily without any support of harness. This image showed and responded for the call of the owner. And in my conclusion, I would like to include this following. As the prognosis of the tetanus is guarded, there is better improvement with mild and localized clinical signs. In the reported literatures, the survival rates were mentioned as 50 to 90%. And in mildly affected animals, the normal function usually returns within 3 weeks of the initial treatment. And to prevent tetanus in future, it is better and advisable to use a rational antibiotic therapy for the infected wounds or wounds that has occurred. And these are my references I used and I went through. Thank you very much.
Thank you. If there are any questions, you can ask now.
Yeah, Doctor, can you hear me? Yes.
Yeah, I can hear you, sir. Yes,
yeah,
sir.
I mean, in your presentation, you clearly mention in red letters, says there's no diagnostic method for tetanus other than the clinical signs and symptoms. But, I mean, there are methods, I suppose, to my knowledge, in, just to isolate the toxins and culture and then followed by mouse inoculation and then see for the signs but can you say no actually exactly but still the literature there are tests what made you to write that statement actually?
Yeah, I agree with you, sir. What I mentioned was there that once the tetanus is suspected, it takes more time to bring for a confirmatory diagnosis. So to culture the Clostridium, we need anaerobic environment. It takes more time to culture. And in our country, we don't have the toxins that are present in the patient's blood to extract and confirm. And in some of the literatures I came, they have also mentioned that tetanus is the treatment of tetanus is started based on the clinical signs and the presence of the recent wound. So that made me to make my presentation in that manner.
Yeah, you can declare that it is not available in Sri Lanka, but you can't say no, right? I mean, there's a method for that. No, I mean, even though it's not available in our country, maybe, but I don't know. It's MRI they're doing the test. Yeah, but it takes time. Anyway, it's a good attempt. You manage the dog. The management is superb, actually. I mean, giving and you put the nasogastric tube and you feed the animal and to get nourishment. That is excellent. Yes. And yeah, the way you handle the literature only there's some shortcomings were there.
Okay, Dr. Nirujan, there's a question from online audience. Were there any wounds?
Yeah, there were wounds on the hind limbs which were caused by the barbed wire fence. So at the time when the dog was presented, almost the wounds were covered. I mean, it was in healing process. So we didn't want to interrupt the healing process, and we started the treatment based on the wounds and the clinical signs the patient exhibited.
Okay, thank you. That question was from Dr. Pavitra Pereira.
You said you gave anti-tetanus toxoid animal serum, is it?
Yes, madam. Yeah.
After how long of the vaccine you collected that serum from that donor?
So we selected the patient within the 6 months of interval. So it was last, we checked for the history of our patients who were given tetanus toxoid, and we selected the patient who was given within the 6 months.
Usually,
So
how long does it stay in the serum in higher level after giving the tetanus vaccine?
I mean, the
toxoid.
The titer levels of the, that one. You have any reference for that? Yeah.
No, I can't correctly remember the duration, sir.
Yeah,
that's okay, but
anyway,
it's a good
yeah,
attempt. Yeah, very nice presentation.
The thing is, I mean, you can get nervous signs for different, I mean, for different conditions, maybe have similar signs of tetanus. So rather than confirming it is tetanus, you can't say this dog has definitely got tetanus, right? I mean, without confirming the diagnosis, but clinical science, yeah, it's okay. I mean, anyways, responded for the treatments, yeah.
Yes, sir.
Thank you. Let's move on to the next one. Effect of intra-articular injections of platelet-rich plasma for lameness in dogs with osteoarthritis of the coxofemoral joints. MGTM Prashadini, HDS Heva Patirana, DDN De Silva, and HMS Vijayakon.
Good day everyone. My presentation is about effect of intra-articular injections of platelet-rich plasma for lameness in dogs with osteoarthritis of the coxofemoral joint. Osteoarthritis is most commonly diagnosed joint disease among dogs. It is also referred as degenerative joint disease, which is a progressively worsening inflammation of the joint caused by the deterioration of cartilage, which is a source of chronic pain leading to functional disability with a high negative impact on patients' quality of life. Risk factors for developing osteoarthritis include larger breeds such as German Shepherd, Labrador Retrievers, and Golden Retrievers, higher body weight, common among all the animals, repetitive stress injuries like fractures and ligament tears, infections that affect the joints such as Lyme disease, improper nutrition, mechanical factors including malalignment and abnormal joint shape, and genetic predisposition. Due to its multifactorial nature, management of osteoarthritis is challenging. Management of canine osteoarthritis involves a combination of therapies including weight control and exercise. Here, exercise should be reduced during flare-ups arthritic pain to allow the inflammation to subside. In the long term, regular, moderate, controlled exercise may be beneficial. Analgesics like non-steroidal anti-inflammatory drugs need to be used with care as they can have side effects. Disease-modified osteoarthritic drugs, which may act to slow the cartilage degradation, glucosamine and chondroitin, essential fatty acid supplements like fish oil, local therapy through the use of intra-articular injection is a new treatment modality in osteoarthritis that reduces the systemic effects of drugs. For example, corticosteroid, hyaluronate, platelet-rich plasma are high in the list. Here in this study, we are discussing the platelet-rich plasma. Autologous platelet-rich plasma is a biological preparation made from patients' own plasma and a concentrated sample of platelets, growth factors, and other cell signaling proteins. These growth factors include platelet-derived growth factor, vascular endothelial growth factor, fibroblast growth factor, epithelial growth factor, and transforming growth factor. PRP is obtained by collecting a blood sample from the patient through venipuncture. And blood is then processed through centrifugation. After processing, the end product can be injected to an area of injury such as arthritic joint, ligament, tendon, and other soft tissue injuries. A PRP sample should provide a therapeutic dose of platelets between a 3 to 7-fold concentration. PRP sample should contain a significantly reduced concentration of RBCs as they can damage cartilage and synovium directly. Red blood cells also increase concentration of unwanted inflammatory mediators, and PRP samples should also have reduced number of neutrophils as they increase concentration of unwanted inflammatory mediators. When PRP injected to an area of injury, it is exposed to collagen, which is important in platelet activation. Activated platelet changes its shape, which leads to release of stored growth factors, and macrophage and other beneficial inflammatory cells are attracted to area of injury to clean up damaged and necrotic cells. Once the tissue has got rid of the damaged cells, new blood vessels formed and fibroblasts migrate and proliferate. Then remodeling of the tissue begins. Hyaluronic acid and other beneficial components of the extracellular matrix are produced, which aid in the moderation of inflammatory process. As a clinically proven therapy, PRP has the ability to treat numerous orthopedic and soft tissue conditions. Majority of patients benefit from improved articular function and decreased inflammation and regeneration of damaged tissues. Hypothesis of our study is canine autologous PRP can ameliorate the symptoms of osteoarthritis. Let's see how the PRP prepared. 8 ml of blood drawn from cephalic vein and immediately placed into a test tube containing 1 ml of acid citrate dextrose. Then the blood sample centrifuged at 500 G for 10 minutes and got two components as sign erythrocyte component in upper fraction and blood cell component in lower fraction. Then the entire sign erythrocyte component transferred into another centrifuge tube without anticoagulant and again centrifuged at 500 G for 10 minutes. Then this centrifugation resulted in two new components as platelet poor plasma and platelet pellet in lower fraction. 2/3 of platelet poor plasma was discarded, then platelet pellet resuspended in rest of the platelet poor volume to obtain platelet rich plasma. This slide briefs the methodology of our study. There were 3 patients included in the study with a complaint of limping of affected limb. Among these patients, there was 6 years old male Labrador, 4 years old female Labrador, 5.5 years old German Shepherd male animal. And these are the exclusion criteria. Joint involvement and severity assessed by physical examination and radiographs of affected limb, and all the 3 patients underwent routine clinical chemistry and hematology to evaluation to ensure overall health. 2 ml of autologous PRP was injected to affected joint after positioning the patient and aseptically prepared the affected joint. Follow-up PRP injections were arranged in day 14 and day 28, and the follow-up radiograph was taken 6 weeks after first PRP injection. This table summarizes the clinical details of 3 patients. We handled limb function in the dogs before and 6 weeks after first PRP injection was evaluated using veterinary orthopedic examination assessment score Scores were assigned based on visual examination of lameness at a walk, pain on passive manipulation of affected joint, limited range of motion with pain at less than full range of passive motion, and functional disabilities, including level of stiffness as measured by willingness to walk and run. Radiographic scores were determined for each patient based on this scoring scale, where 0 indicating normal joint and 4 indicating severe degenerative changes. Clinical outcomes measures were based on the same veterinary orthopedic examination score sheet. This table summarizes the finding of pre-treatment and 42 days after first intra-articular PRP injection. It is obvious that according to the results, all the 3 patients have improved orthopedic scores. Results of current study demonstrate that intra-articular PRP therapy resulted in improved orthopedic examination scores as assessed by veterinarians, and lameness, range of motion, pain on manipulation, overall combined scores are significantly improved over time. This study indicated follow-ups only for 42 days after first intra-articular PRP injection, but more long-term results will be available in future as we are following up for 2 years of time period. Overall, this study shows intra-articular administration of PRP therapy decreases patient discomfort and increases patient functional ability in dogs with osteoarthritis of the coxofemoral joints. Thank you.
Discussion is open for the presentation. Could you explain me the aseptic procedure that you used before the intra-articular injection?
As a routine surgery, we first treat the hair and then prepare the area. And create within some proteins, and actually we braid the areas with that. Then we use sterilized gloves, surgical gloves to inject the preparation. That's the treatment.
Right. And then what was your maximum length of monitoring after giving the PRP injection for the lameness for?
Actually, in that results we did for 42 days. We are currently also following up with those cases for up to 2 years period.
Why I'm asking that question is because when you're giving intra-articular injections,
yes,
if you're doing it quite frequently, that's going to be disastrous. I mean, depending on the frequency, like every 6 months would be nice. I mean, so it's an ongoing study still.
Yes, ma'am.
And also in the presentation, you mentioned that the steroids is being given intra-articular. Which literature have you, that is after a literature review that you got?
Actually, madam, we did the literature review. They have mentioned about the methylprednisolone. In case of humans, they also use methylprednisolone in
humans. Yes, but I'm asking animals, small animals.
We did refer the animal literatures as well.
Okay.
Yeah, my question is actually, it's a very good attempt. I mean, this has been there for long in other countries, sometimes in human it's very long. I mean, they're quite practicing, but they have found that, the human wise actually is not quite successful because we are not treating for the underlying cause of the arthritis. Like, I mean, if the continuous, recurrence, I mean, the cause is there, this may be some temporary, measurements to heal the, pain, like, forming of collagen there, this condened sulfates and everything. But I mean, in long term, you have to give it again, I suppose, I mean, anyway, it's a good attempt.
So, I mean, we are still monitoring with those patients up to 2 years period.
And you use these photographs, I mean, preparation of this, PRP, that is in the textbooks actually you have
we did the practical.
the actual photographs, no?
Yes,
those are, okay.
In clinical.
So is there any minimal required dosage that you have to give according to the weight? Or?
Actually, we referred the literature. They told that 1 to 2 milliliter of PRP is enough for one joint. So there's
for
no,
any weight of the animal, Labradors, German Shepherds, like, you know, even small breeds?
It's depend on the blood amount we drawn.
So what is the volume you have to draw from a, like, you know, 15
around 50
kg?
kilograms body weight? It is enough to draw 8 milliliters of blood, and we can get 2 milliliters of PRP ultimately.
Okay.
From the same dog we are getting, right?
Yes, sir.
Can you get from another dog?
Currently, we are practicing in autologous platelet-rich plasma therapy. We are hopefully.
You mean, if
to
you get
start
from
the-
another dog, we'll be having some reactions?
Maybe we have to check first blood smears to reactions. Cross reactions. Yes.
Okay.
Thank you very much.
Right. Okay, so with that, we will move to the next presentation. It's about the possible breed predisposing position in the vestibular syndromes using a data collected at Veterinary Teaching Hospital, Peravenia. This is presented by E. Bernard and A. Dangolla. The screen is yours, Professor Dangolla.
Good morning to all. Our research is to find out whether the vestibular syndrome is common in Rottweilers when compared to other breeds of dogs. It is a retrospective study conducted at Veterinary Teaching Hospital. Vestibular syndrome is characterized by acute onset of vestibular signs such as head tilt, nystagmus, rolling, circling, and ataxia. The objective of this research is to determine the prevalence of vestibular syndrome among the dogs presented to the VTH for a period of 2 years from 2016 January 1st to 2018 January 1st, and to find out whether the vestibular syndrome is more frequently reported in Rottweilers when compared to other breeds of dogs. Vestibular system has two components. One is peripheral component and the central component. The peripheral component is situated inside the inner ear, and it has two parts called cochlea and semicircular canals. The cochlea has two parts. One is called utricule and saccule. The semicircular canals are located at right angles to each other, and there are 3 semicircular canals, and they have an enlarged area at the end, which is called as an ampulla. Ampulla has specialized sensory cells called crista ampullare, and they detect the rotational movement of the head. While in the cochlea, there are specialized sensory receptors called macula of the utricle and macula of the saccule. Both detect the linear acceleration, deceleration, and gravitational forces, and they detect the static position of the head at any time. So there are sensory fibers originating from cochlea is called as a cochlear nerve, and the nerve originating from semicircular canals are called vestibular nerve, and both join to form vestibulocochlear nerve, which is the 8th cranial nerve. This is a simplified scheme of central vestibular system. The arrow shows the vestibulocochlear nerve, and the number 2 indicates a vestibular nuclei, while the number 3 indicates a vestibulospinal tract. Number 5 shows the vestibulocerebellar tract. Number 10 indicates the projection fibers of vestibulothalamic tract, and number 11 shows the thalamic nuclei itself. From the thalamic nuclei, there are projection fibers to the cortex, which is denoted by number 12. And number 6 indicates the abducens nuclei. Number 7 indicates the cochlear nuclei, while the number 8 and 9 indicates oculomotor nuclei and red nuclei respectively. This schematic diagram shows the peripheral vestibular system and the central vestibular system together, the nerve fibers originating from utricle, saccule, and semicircular canals jointly form the vestibulocochlear nerve and it project sensory information to the flocculonodular lobes in the cerebellum and the vestibular nuclei and other nuclei in the brainstem, from which the vestibulospinal tracts are formed, and vestibulospinal tract convey the processed information to the spinal cord and finally to the flexors and extensors of the body to maintain the posture of the body. Since the vestibular system is responsible for maintaining the equilibrium of the body, any diseases related to the vestibular syndrome causes clinical signs related to posture. So these are exhibited as circling, falling, rolling, head tilt, vestibular ataxia, and nystagmus. Clinical signs and their severity depends on whether the lesion is central or peripheral. If the lesion is central, it is usually more severe than the peripheral disease. However, with good nursing care and depending on the lesion, it can be cured. So diagnosis is almost always straightforward and almost consistent with the clinical signs. Treatment includes supportive care and specific treatment against the underlying cause if any cause is identified. This dog shows head tilt. This one shows the abnormal positioning of the eye, while this one shows the unable to stand and ataxia, head tilt. Materials and methods. This research used the case records maintained at the VTH from January 2016 to January 2018. Number of dogs and their respective breeds and the number of dogs with vestibular syndrome were noted. So repeated visit of a single animal is considered as a single observation, and all of these data entered into the spreadsheets to calculate the proportions and compared whenever possible using chi-square test. For chi-square test and for all comparisons, a p-value of less than 0.05 was used. A total of 8,748 dogs were presented to the veterinary teaching hospital, among which 77 were diagnosed as having vestibular syndrome. Therefore, overall prevalence of vestibular syndrome among the dogs presented within the study period was 0.88%. More Dobermans were diagnosed with vestibular syndrome when compared to Rottweilers. That is, the prevalence of vestibular syndrome was very high among Dobermans than the Rottweilers. However, there was a significant association found between vestibular syndrome and being a member of breeds Doberman, Rottweiler, Dalmatian, and German Shepherd. Results: Rottweilers had the highest relative risk of contracting vestibular syndrome, which is 4.97, while the Doberman and Dalmatian had the second and third relative risk of contracting vestibular syndromes, which is 4.92 and 3.83 respectively. Within this group, German Shepherd had the very low relative risk of getting vestibular syndrome. This diagram shows the percentage of dogs from each breed with vestibular syndrome. Among the dogs which had the vestibular syndrome, 27%, which is the highest percentage for any single breed, is Rottweiler. Discussion. Our suggested hypothesis is not yet disproven because Rottweiler had the highest relative risk when compared to other breeds of dogs to get vestibular syndrome, and they had the highest percentage within the affected dogs. Since vestibular syndrome is a multifactorial disease, the local environmental conditions may predispose the condition. Therefore, a conclusion cannot be arrived since they are yet arrived because of possible biases. The study used the data collected at the veterinary teaching hospital by final year students. Therefore, there is a certain possibility for some cases to be left unrecorded, and diagnosis was made by several clinicians. Therefore, it also includes a certain amount of uncertainty. As well as veterinary teaching hospital is a referral center, therefore the sample we analyzed would not be a good representative sample of the population. Therefore, a large study involving several veterinary clinics in several cities is essential to obtain a confirmatory results. And I like to acknowledge Dr. Nayana Vijayavathana as the head of the department at the time of study, and all clinicians and students at VTH past and present, as well as the administrative staffs, all academics and non-academic staffs. Thank you so much.
All right, thank you. Yeah, there's one question coming from Professor Sujay. Yeah.
Can you say whether your findings are statistically significant or not? Can you hear me? Can you say whether your findings are statistically significant or not?
Dr. Bernard, can you hear us? Is he online, Dr. Bernard?
Yeah. Okay. So can you hear us? You are getting a question from the judge panel. If you are available, you can just raise hand and answer the question. Yeah, he's there. Did you get the question?
Can I repeat?
Yeah.
So, some internet problem. Yes. Can you say whether your findings are statistically significant or not?
So we can't hear you. Can you please unmute your button, please?
Let's move to the next.
Please unmute you, please. No, sorry, we can't hear you. We go next. Sorry, Bernard, we can't hear you. Yeah. That is actually normal with this sort of technical session. So I'm sorry to say that we have to move the next presentation. Dr. Diane will continue with this from this. Yeah, please.
This presentation is on concurrent occurrences of high-grade mast cell tumor and hepatoid gland adenoma in a young male Labrador retriever. WRJP Balpola, KRK Pereira, HDS Heva Patirana, IPCS Kitsiri, AT Lianage, SU Aberatna, HMS Vijayakonan, DDND Silva.
Hello everyone. Today's my presentation is on concurrent occurrence of mast cell tumor and hepatoid gland adenoma in a young male Labrador.
Sounds very good.
Clinical case presented to the Veterinary Teaching Hospital, University of Peradeniya. There are several objectives of
So we can't hear, no?
Yeah, yes.
its mast cell tumors. Hepatoid glands are the modified sebaceous glands of the skin that only present in dogs. They can be located in perianal area, prepuce, base of the tail, groin, inner thigh and the back of the animal. Hepatoid gland adenomas are the purposeless overgrowth of hepatoid gland. A main risk factor of hepatoid gland adenoma or adenocarcinoma is sex hormones, which are testosterone or estrogen hormones. Testosterone promotes these tumor growths and therefore hepatoid gland adenomas are much more common in intact males. Estrogen inhibits these tumors and therefore these tumors are much more common in neutered females. Here we came to the case presentation. This animal was a police dog which was named as Tango, 2.5 years old, Labrador Retriever, male, one with a weight of 37.8 kilograms. The main complaint and the history was rapidly growing pink perianal masses for about 2 weeks. During the clinical examination, animal was bright, alert and responsive and all the vital parameters were within the normal range. We found well demarcated two perianal masses. This figure shows the external appearance of both perianal masses. Mass A was approximately 2 cm diameter, multilobulated, erythematous and present on the skin just above the anus. It was located on the 7 o'clock position of the perianal area, approximately 1 cm diameter, and the color and consistency was similar to mass A. Other than both perianal masses, there were cutaneous nodules present all over the body of the animal. These multiple cutaneous nodules were also consistent with a purulent discharge. This figure shows some of the locations of these cutaneous nodules, such as rump area, lateral abdomen, lateral thorax, and the caudal to the base of ear pinna. After the clinical examination, we moved for the laboratory investigations. First, we did fine needle aspiration. Fine needle aspiration of mast A revealed a mixed population of inflammatory cells, including mast cells. Fine needle aspiration of mast B confirmed it as a hepatoid gland neoplasia. Then we did the histological examination of all lesions. Hemocyanin and eosine staining of tissue samples showed the following morphological features. Here we came to the histological examination of mast cell tumor. Mast cell tumor was an encapsulated, partially circumscribed neoplasm. There were sheets of round cells streaming along a moderately thick fibrovascular collagenous stroma. Also, there were round nuclei, occasional binucleated cells, and mitotic figures. All of these features were consistent with the high-grade mast cell tumor. These red, brown, black, and orange arrows represent a binucleated cell, a mitotic figure, thick fibrovascular collagenous stroma and a round nucleus retrospectively. Then we came to the histological appearance of hepatoid gland adenoma. It was a well circumscribed, unencapsulated, densely cellular neoplasm. It composed of uniform broad trabecular and islands of polygonal cells surrounded by a single layer of attenuated basally reserved cells supported by a delicate fibrovascular collagenous stroma. This blue arrow represents the fibrovascular stroma. This brown arrow represents the islands of polygonal cells that are surrounded by the basally reserved cells which having a spindle-shaped nucleus that's named by the green arrow. Also, there were minimum nuclear pleomorphism. These histological features were consistent with the hepatoid gland adenoma. Histological examination of skin lesions confirmed them as a mild lymphoplasmavitic paniculitis and follicular hyperkeratosis. When the lesions are confirmed by the histological examination, the most suitable treatment option was the surgery. Surgery was performed under general anesthesia. Animal was placed on sternal recumbency and both perianal masses were removed by electric cauterization. Remaining perianal tissues were sutured, facilitating the fecal pathway. The left side figure shows the external appearance of both perianal masses during the surgery, and the right side figure shows the external appearance of perianal area after the removal of the both perianal masses. Then we did the post-surgical evaluation of the patient. Animal was under the treatment of doxycycline and chlorpheniramine, which is antihistamine drug, after the surgery. Follow-up was done after 2 weeks of surgery, and at that time, there were more cutaneous growth observed along the dorsal and the both sides of the neck. As I mentioned previously, the previous skin lesions were confirmed as mild lymphoplasmavitic paniculitis and follicular hyperkeratosis. But these new lesions or these new cutaneous growths were confirmed as mast cell tumors. Usually, recurrence of hepatoid gland adenomas are frequent, but no recurrence of the hepatoid gland adenoma until the last follow-up in this patient. Let me speed the discussion of this presentation. Most of the time, mast cell tumors are malignant, but hepatoid gland adenomas are benign tumors. Mast cell tumors can be very invasive, regrow after the surgery or metastasize. Surgical resection with adequate margin is the ideal treatment for mast cell tumors because incomplete removal will induce the regrowing of tumor. Combination of surgical resection with chemotherapy or radiotherapy to increase the survival chance of the animal. Mast cell tumors release histamine, and therefore antihistamine should be a choice of drug during the treatment plan. Hepatoid gland adenomas can recur in males due to the influence of testosterone hormone. Therefore, castration is the ideal option for the preventing recurrence. Here we came to the end of my presentation, and thank you all.
Paper is open for discussion. So did you do the castration of this dog?
No, madam, we didn't do the castration because no recurrence of the hepatoid gland adenoma. Yes.
Nothing online. Nothing online.
She's not online. Not online. So we have the next one.
Okay, she's not online, so we can move on. So let's move on to the.
Oh, she's there. She's there. Okay. Okay.
Are you online, right?
Can you hear us?
Dr. Walpola?
You can hear? Did you castrate this dog?
No, madam, we didn't castrate the dog because there is no recurrence of the hepatitis and adenoma until the last follow-up.
How long have you done the follow-up in this case?
Recently, I also follow up the dog over the phone. It's a police kennel one, and there is no recurrence of the hepatitis and adenoma yet.
But it can still recur, right? You can't really be sure about it.
Yes, madam, we can do the castration.
And then about the high-grade malignant mast cell tumors, you said like there were more lumps you identified. Did you do anything about them, or you just left it there? Or any treatment given?
The surgical treatment, we should start the chemotherapy agents. But the most suitable chemotherapy agents are vinblastine and the lymphosine. But we couldn't find those drugs. In the police kennel, they treat the dog with doxorubicin, and there is a mild effect for that drug because the growth is slowed by those drugs.
So what happened to the dog in the end?
He's okay, madam.
Sorry?
He's still okay.
Okay.
Yeah, I mean, when you attend the surgery of that perianal area, how did you manage after the surgery? Because it's a very highly potent for contamination with stools. And it's just below the rectum, right?
Yes, just below the rectum. We advise the owner to monitor the patient and they'll feel that one several times of the day, because we have to apply betadine and betadine solution on that surgical wound, and we want to manage that wound as an open wound.
Open wound.
Yes.
So if there are no more questions, let's go to the next one. Enucleation of filari bull under the field condition. A rare case of lacrimal gland neoplasia, WPPSI Pereira, WMTD Ratnakumura, PGAS Pallikumura, PRMKK Vijay Sundara, GDRK Pereira, and AAWK Amarasinghe.
Good morning, everyone, and welcome to my presentation. First of all, it's an honor to address you all in SLVS scientific sessions. I'm going to present enucleation of a filari bull under the field condition, a rare case of lacrimal gland neoplasia. To introduce you into my presentation, the most common bovine ocular neoplasia is squamous cell carcinoma. It also known as cancer, lymphosarcoma, lacrimal gland neoplasia. Those are very rare conditions. It can be categorized into adenoid cystic carcinoma, primary adenocarcinoma, and pleomorphic adenoma. Treatment options are cryotherapy using liquid nitrogen. We can soak cotton balls with liquid nitrogen and keep it on the tumor mass after excision to reduce bleeding and to destroy the epithelial layer. Electric cauterizer, radiation therapy, local chemotherapy. Fluorouracil and vincristine sulfate are the mostly used chemotherapeutic agents. These are made for intravenous use, but if it is a nodular lesion, we can use it for intralesion injections. Immunotherapy. The mostly used vaccines for large animals are bovine papillomavirus virus and caprine pustular dermatitis. Excision and enucleation. When it comes to our case, we had a 11-year-old Kilari bull. It lives in Peradeniya Botanical Garden, used for draft purposes. It weighing approximately 600 kilograms. The complaint was gradually developing mass on the left eye, and animal lost its eyesight slightly due to the mass, and the particular eye was tearing a lot. And we did the GCE, and there was no abnormal findings other than the mass on the left eye. Especially, there was no lymph node swelling on head area. The treatment plan was to start with local chemotherapy. Vincristine sulfate was used, 0.2 milligram. Intralesion injections were given, 2 weeks interval for 2 months. Then methylprednisolone, intralesion injection, and fusidic acid cream topical application. Then we did the enucleation because there was no response to therapy treatment. The mass was getting bigger and severe with time, and finally the animal lost its eyesight, in particular eye. And surgical procedure for enucleation was, it was done under deep sedation using psilocin. Animal was very fractious, and surgical site preparation was done, and local anesthesia was used in the eye. 4-point retrobulbar nerve block was done. In this picture, I have shown how it was done. 2% lignocaine, 10 ml was used per site in clock position, 12th position, 6th position, 3 position, and 9th position was injected. And we used a big long needle. We used a 18-gauge cannula, and after removing the stylet, we injected the solution through the cannula. Tasseraphy was done. It means closure of 2 eyelids together using sutures. And elliptical skin incisions were done around the eye margin, 1 centimeter away from the eyelid margin. And muscles, fascia, subcutaneous tissues were dissected using blunt and sharp incisions. Medial and lateral canthal ligament excision was done. Especially here I have to mention the medial canthal ligament was highly vascularized. We ligated the blood vessels and excised the ligaments. After that, optic nerve transaction was done. After the enucleation, there was a big cavity. The orbital cavity was exposed. Usually after enucleations, you can have many complications due to secondary bacterial infections in orbital cavity because there will be a lot of body fluids drained into the cavity, and secondary bacterial infections will occur. To drain out the body fluids, we applied a Penrose drain. After that, subcutaneous tissue and the skin sutures were done. This is a picture after the surgery. The white color tube is the Penrose drain we applied into the orbital cavity. Post-operative care was done with pain management. We used ketoprofen, and parenteral antibiotics were used. And Penrose drain was removed after 2 weeks with skin sutures removal. After the enucleation, we submitted the samples to pathology department and got the histopathology results. In this picture, it's a lower magnification. These are the secretory glands, the round white color areas. In this area, the secretory glands are very highly compacted due to high mitotic index in the neoplasia than this area. When we go to higher magnification, you can clearly see the myoepithelial cells. It is responsible for squeezing out the secretory gland products into glandular duct. It has a flattened nuclei and it has scanty cytoplasm than other cells. This is ductal epithelial cells. These are usually the ductal epithelial cells are cuboidal in shape, but here it has flattened and it is having a hyperchromatic nuclei due to the tumor condition. And inside the secretory gland, the glandular products can be seen. Diagnosis was adenoid cystic carcinoma with features of primary adenocarcinoma and pleomorphic adenoma. To confirm that, immunohistochemical studies are required. Conclusions are, even though this is a rare type of bovine ocular carcinoma, the adenoid cystic carcinoma, it can be easily misdiagnosed with squamous cell carcinoma, which is the most common condition in bovine eyes. And treatment options are no response to vincristine sulfate given locally, the intralesion injection, and surgical method is the best option under field conditions. The animal is still in the botanical garden and used for draft purposes. And thank you. That's all for my presentation.
Okay, thank you, Dr. Pereira. So I hope you are joining with us through online. The paper is open for a discussion.
Yes, madam, I'm here.
Yeah, okay. So nice. Good presentation, Dr. Pereira. So I have a small question. You have mentioned that the Penrose drain was removed after 2 weeks. Is that, I mean, why keep such a long time? That's the first question. And the second question is, how common these conditions? Have you ever heard about any other reported cases in Sri Lanka or outside of the country while you are doing a literature reviews?
This is the first question. Lacrimal gland neoplasia I found in Sri Lanka, and there's no literature review in world either. Madam?
Yeah, okay, continue.
And the Penrose drain removed after 14 days because the animal is very fractious. We have to do it under local sedation. We thought that it's better to sedate the animal once and do the skin suture removal and the Penrose drain removal together.
Okay, thank you. I think Dr. Erandika Gunawardena has some questions.
Yeah, it's a very good, nice attempt you have done surgically to remove the lesion. And my question is, you have put, intra-lesion vincristine. I mean, this is the first time like I heard about that. Quite new to me also. Yes. Is it in the literature to, can we put onto the surface of the lesion vincristine, because it can perfuse into other peripheral tissues and cause necrosis and can create further, cancerous lesions, like developing to cancers in the other tissues when you put onto the, soft tissues itself, vincristine.
Yes, sir. In animals, there's no literature like that, but in humans, they use vincristine sulfate as in nodular lesions. If it is very nodular, we can inject intralesion with methylprednisolone also.
But here in the eye, of course, actually it's very sensitive area. I mean, it can deeper into regions that it can penetrate, like vincristine. Anyway, I mean, but it can later on, it can happen. I mean, cause some other conditions like not now, it takes after sometimes, no? I don't know.
Yes, sir. Yeah.
Any more questions from the table? Thank you, Dr. Pereira, for joining with us. Good luck. Okay, so we will move to the next presentation. It's also the case study done by SUG Amarasena, KNA Vijayavardhana, TDND Silva, and HMK Dhananjaya. This is about the case of chronic urinary retention. Dr. Amarasena, you can start your presentation now.
Hello everyone. I'm going to present a case of chronic urinary retention. First, we will see the anatomy and the pathophysiology of the canine urinary tract. Figure 1 shows canine urinary tract. It can be divided into two parts as upper urinary tract and the lower urinary tract. Upper urinary tract consists of kidneys and the ureter. The lower urinary tract consists of urinary bladder and the urethra. The bladder can be divided into three parts as apex, body, and the neck. The trigone of the bladder is a triangular area on the dorsal aspect of the bladder neck. The ureters enter at the level of the base of the trigone. The smooth muscles of the bladder is arranged in bundles with different orientations, and the circular bundle is called as detrusor muscle. Smooth muscle bundle extend through the proximal part of the urethra, where they form the internal urethral sphincter. Further along the urethra, the skeletal muscle form the external urethral sphincter. Figure 2 shows the autonomic and the somatic innervation of the bladder and urethra. The control of urination is attained through a combination of voluntary and the involuntary components of the nervous system. The sympathetic innervation is supplied by the hypogastric nerve, regulate the filling phase. The stimulation of the alpha-adrenergic fibers, mainly present in the trigone and the proximal part of the urethra, results in the contraction of the smooth muscles forming the internal urethral sphincter, while stimulation of the beta-adrenergic fibers, mainly present in the body of the bladder, induces relaxation of the bladder. This combined effect facilitates the storage of urine and prevent leakage. As the bladder fills, the sensory stretch receptors embedded in the bladder wall are stimulated. Afferent signals are transmitted through the pelvic nerve and the hypogastric nerve to the spinal cord, which in turn increase the activation of the parasympathetic fibers within the pelvic nerve. Concurrently, the information is sent to the brainstem, cerebral cortex, and allowing conscious perception of the bladder distension. Once it is appropriate to avoid urine, the stimulation of the parasympathetic nervous system results in stimulation of the detrusor muscle in the bladder wall. Inhibition of somatic neurons in the pudendal nerve and the adrenergic fibers in the hypogastric nerve result in relaxation of the external urethral sphincter and the internal urethral sphincter respectively and facilitate voiding. The mechanism that regulates the emptying of the bladder across the urethra in specific periods event that implies the alteration of the storage phase and the emission phase is known as micturition. Any alteration in the storage phase generates the urinary incontinence, and any alteration in the emission phase generates the urinary retention. The disorders of emptying will result in the urinary retention. It could be due to abnormality of the detrusor muscle or the mechanical obstruction. The abnormality of the destructive muscle could be due to neurogenic or the non-neurogenic causes. The neurogenic could be due to injury to the sacrospinal cord S1 to S3 or the pelvic nerve. The non-neurogenic cause could be due to mechanical outflow obstruction or the functional outflow obstruction. The mechanical outflow obstruction could be due to urolithiasis or the prostatic hyperplasia. The functional outflow obstruction disturbs the urethral dyssynergy. It occurred due to an abnormality in the reflex arc. Normally, reflex arc sends signals to the urethral sphincter to relax at the initiation of the destructive contraction in urination. In upper motor neuron bladder, it occurs due to spinal cord dilation in cranial to the sacral segment. It causes loss of inhibitory signals to the hypogastric and the pudendal nerve and prevents sphincter relaxation on voiding. Canine German Shepherd female, 8 years, 26 kilogram Lisa, was presented to the veterinary teaching hospital. The complaint was animal is training but can't urinate properly, an enlarged abdomen for 2 months. History was oliguria, dysuria, enlarged abdomen, reduced appetite for 2 weeks and reduced water intake. 2 months ago, animal had urinary incontinence and treated with primary. General clinical examination, enlarged abdomen and non-painful rock hard bladder on palpation. The tentative diagnosis was atonic bladder with functional urethral obstruction. Laboratory investigation. Radiograph findings reveal the entire abdomen was occupied by the urinary bladder. Urine report. The method of sampling was cystocentesis. The visual inspection, color was yellow, turbidity cloudy, specific gravity 1.02. The chemical region strip test, blood was small, pH was 5, protein trace, leukocytes moderate, urobilinogen, glucose, bilirubin, ketone, and nitrite were negative. After cystocentesis, a sterile urine samples was submitted for culture and ABST. Culture revealed E. coli prominent role, and ABST, the ciprofloxacin, amoxicillin clavulanic acid, cefuroxime, cefotaxime, trimethoprim sulfonamide were resistant, except ampicillin. The ultrasonography, the thickness of the urinary bladder wall was 2.6 centimeters. Normally, it should be within 2 to 5 millimeter thickness. The hyperacute material in the bladder. Except mild leukocytosis, other parameters were normal in full blood count report. Neither manual bladder compression nor the insertion of the female catheter was possible due to the resistant faulty in the urethra. Therefore, cystocentesis was performed on the first day and removed 7 liters of urine. Subsequently, daily catheterization was performed. We initiate intravenous amikacin. Subsequent ABST 2 weeks later revealed resistance to amikacin. Therefore, amikacin was replaced by the nitrofurantoin. Since the animal appeared to have had functional urethral obstruction, we added tamsulosin, which act on alpha-1A receptors in both internal and the external urethral sphincters. And we added diazepam. It relaxed the external urethral sphincter. Finally, we added metoclopramide to initiate the contraction of the detrusor muscle. Outcome. 10 weeks of treatment successfully made the animal urinate without any discomfort. This video is about that. Discussion and conclusion. Alteration in normal urinary voiding mechanism will result in temporary or the permanent injury to the urogenital system and adversely affecting the patient's quality of life and ultimate outcome. Therefore, by understanding the pathophysiology of mecturin disorder and action of pharmacologic agents will optimize patient comfort, treatment outcome, and minimize adverse effects. This is the end of my presentation. Thank you very much for your attention.
Okay, thank you, Dr. Amarasena. Nice presentation. I hope you can join with us through online to answer the questions raising from the online audience or the judge panel. So any questions from the audience or our judges?
Yeah, Dr. Amarasena, you mentioned about hyperechoic mass in your ultrasonic scanning, I mean, in the bladder, but you didn't explain about it, right?
Hyperechoic materials.
Material.
Yeah. After we collect the cystosensitive urine sample, there was a it was cloudy. There were cloudy, and there were some small cells.
Flaky.
Yeah,
okay.
because 2 months, for 2 months, the animal is not properly urinating. That's why it could be due to chronic urinary retention. Hello, am I audible?
It means could be lesions of chronic cystitis, right? You said the bladder wall.
Yeah, it could be a chronic cystitis.
Any more questions? Since we doesn't have any more questions, so thank you, Dr. Amarasena, for joining with us. With that, we will move to our last part of clinical sessions. So we have 3 more papers to discuss. We move to the next one. This is also about some microbiological aspect. It's about the antimicrobial resistant pattern of Staphylococcus species isolated from canine pyoderma. This is presented by ML.W.P. De Silva, KSA Kottavatta, RS Kalupahana, PGA Pushpakumara, CB Relay, and KN Vijayadana. Dr. De Silva, the screen is yours.
Hello everyone, I'm Lalanthi De Silva, and our study is on antimicrobial resistant pattern of Staphylococcus species isolated from canine pyoderma. What do you feel when you see this? Yes, it is the intimate bond between human and dogs as companions. But have you ever thought of the common threat called antimicrobial resistance in both human and animals? According to the predictions, by the year 2050, 10 million people will die all over the world annually due to antimicrobial resistance. See how tragic the situation is. Since antimicrobials are used in both human and animal medicine, emergence of antimicrobial resistance is a challenge to both human and animals. At the same time, close contact between companion animals and human favors the risk of interspecies transmission of antimicrobial resistant bacteria. So it is clear that we need a holistic approach to combat this global health hazard. Moreover, we need to have a good understanding of the antimicrobial resistance among companion animals as well. Therefore, let me share one of our experiences as veterinarians on antimicrobial resistance in companion animals. Canine pyoderma is one of the most common conditions that is treated with antibiotics. Staphylococcus species is a common isolate associated with canine pyoderma. Therefore, aim of our study was to identify the antimicrobial resistant patterns of Staphylococcus isolates from canine pyoderma presented to the veterinary teaching hospital, Peradeniya. This is how we have carried out our study. First, we obtained the ethical approval. After that, samples were collected from 205 dogs presented with clinical signs of canine pyoderma. Samples were collected as skin swabs aseptically. After that, samples were cultured on mannitol salt agar. Then, standard microbiological isolation and identification methods were used in order to isolate Staphylococcus species. Here we use gram staining, catalase, and oxidase tests. After that, isolated Staphylococcus organisms were subjected to antimicrobial susceptibility test with the use of 9 clinically important antimicrobials. So let's move on to results and discussion. In our study, we were able to isolate 180 samples with Staphylococcus species. That means 87.8% of our collected samples were positive to Staphylococcus. This graph illustrates the antimicrobial resistant profile of 171 Staphylococcus isolates. As you can clearly see, the highest resistance was reported against penicillin, tetracycline, clindamycin, and erythromycin. 74.9% of the Staphylococcus isolates were resistant against penicillin, and more than 40% of the Staphylococcus isolates were resistant against erythromycin, clindamycin, and tetracycline. We all know that penicillin and tetracycline are commonly used drugs in companion animal practice in Sri Lanka. Literature shows the correlation between the emergence of antimicrobial resistance and the use of antimicrobials. To prove this in our study, we need to do more investigations on the prevailing antimicrobial prescribing patterns in companion animal practice of Sri Lanka, as well as emergence of antimicrobial resistance. Let's move on to cefoxitin. 31% of the Staphylococcus isolates were resistant against cefoxitin. According to CLSI guidelines, ABST results of Staphylococcus aureus against cefoxitin can be applied to the other beta-lactam drugs like cephalexin and cloxacillin. We all know that cephalexin and cloxacillin are commonly used drugs to treat canine pyoderma in Sri Lanka. So, if our Staphylococcus isolates have Staphylococcus aureus organisms, there's a risk of having antimicrobial resistance against these commonly used antibiotics like cephalexin and cloxacillin as well. However, in our study, we have done the identification only up to the genus level of Staphylococcus. But previous studies done in the same institute have reported the presence of methicillin-resistant Staphylococcus aureus in dogs. Let's move to the antibiotics to which the resistance was least. As you can see here, 7.6% of the Staphylococcus isolates were resistant against amikacin. Amikacin-like aminoglycosides are used as a solution to treat methicillin-resistant Staphylococcus aureus infections in humans. So, the presence of resistance against amikacin in our study is an alarming finding. So let's move on to multi-drug resistant patterns. In our study, we considered multi-drug resistance as resistance against at least for 3 different antimicrobial classes. In this illustration, each and every column indicates a different combination of antimicrobial classes to which our isolates were resistant. Each and every different color represents a different antimicrobial class. So let's focus to the area within this bracket. You can see each and every column has more than 3 different colors. That means all these combination of different antimicrobial classes represents multi-drug resistant patterns. Therefore, in our study, 82 Staphylococcus isolates out of 171 isolates are having multi-drug resistance. That means 48% of the Staphylococcus isolates were multi-drug resistant. At the same time, we were able to identify 37 different multi-drug resistant patterns. So you can understand that the multi-drug resistance is high in these Staphylococcus isolates associated with canine pyoderma. Let's move on to conclusions. According to our study, antimicrobial resistance and multi-drug resistance are significant problems for Staphylococcus species isolated from canine pyoderma. Therefore, prudent use of antibiotics is essential. We all know that most of the canine pyoderma conditions have primary causes like ectoparasites and allergies. Therefore, when we treat with antimicrobials, proper diagnosis is very much needed. At the same time, the use of antimicrobial susceptibility tests as necessarily must be encouraged. Finally, our study emphasizes the need for further investigations on antimicrobial use in companion animal practice of Sri Lanka, as well as investigations on other contributing factors for the development of antimicrobial resistance in Staphylococcus organisms associated with canine pyoderma. These are references. I would like to acknowledge the Massey University Research Fund and all these personnel, and thank you.
Thank you, Dr. Lalanthi. I think you are with us through the online. The paper is open for the questions. Any questions from audience or the judge panel?
Yeah. So I will ask a question. Hello, can you hear me?
Yes, I can hear you.
Yeah. So I think this is very interesting study and a very important and timely because it's not only in animal health, it's very important for human health. Your findings are very significant. So what are your suggestions or recommendations to reduce the AMR and MDR?
Yes, sir. First thing is, we need to have a proper diagnosis when we use antibiotics for this canine pyoderma. As well as we need to have a proper protocol when we use antimicrobials. What I mean is that when we consider canine pyoderma, there are primary causes like allergies and ectoparasites. So we need to use the diagnostic facilities, actually which are available at private clinics as well as government veterinary surgeons officers, like the basic microscope. But sometimes in private clinics, most of the private clinics, they have the microscope as well as the staining facility with Leishman staining. And the government vet surgeons can always get the assistance from veterinary investigation centers for these diagnostics. So sometimes this canine pyoderma is not always evident with specific lesions like pustules. It will be just dry, wet coat with some odor scratching like signs. So in such cases, if you could do use cytology, and if you can see intracellular bacteria, that's the best evidence for you to have a diagnosis of canine pyoderma. So there you can use antibiotics with.
Yes.
Sir?
For instance, if you say in the human health, so
Yes.
in Sri Lanka, so there is a society called College of Microbiology. They have a specific guidelines for
Yes.
treatment and prescription of antibiotics. So for in veterinary practice, so do they have any kind of similar guidelines or ethics in practice of antimicrobials?
So when we consider the OI have given guidelines specifically for food animals, aquatic animals, but not specific for companion animals. But according to the guidelines provided by the International Society for Infectious Diseases of Companion Animals, they have lined up antibiotics for the use of canine pyoderma as first line, second line, and third line. According to that, they recommend first line antibiotics as first generation cephalosporins like cephalexin and sulfatrimethoprim, as well as clindamycin. However, when we come to second line antibiotics, all these antibiotics should be used based on the culture and ABSD results. Actually, this study is a part of my MPhil, and we are conducting a survey all around Sri Lankan companion animal veterinarians to understand what is the antimicrobial using pattern in companion animal practice. So with all this information, we are expecting to module such kind of guidelines for the use of prudent use of antimicrobials.
Okay, Lalanthi. There is a question coming from the audience. Can you just please tell your name and
yes. Hello, I'm Roshan from VR, right? So I just want to know, have you done coagulase test for your isolate?
No, sir. We have identification was done only up to the genus level. We did not do coagulase test.
Okay, that's a problem because once step, if you do not do the coagulase test, it is quite different. It is difficult to differentiate coagulase positive step from coagulase negative step. But the methicillin resistance, the presence of McAG means coagulase is negative organism. We don't care. So we just only care about pathogenic coagulase positive staph aureus. So that is the other thing. And I think you have used kyphoxetine as an indicator for methicillin resistance. But yeah, staph aureus is better to have kyphoxetine. But for example, staph pseudointermediates and intermediates is better to have oxacillin instead of kyphoxetine. So it's better to go for the species level before interpretations of the AMR phenotypes in staph. Genus level is quite challenging, but I feel, yeah. Thank you very much.
Yes, sir. Thank you for that suggestion. And this is an ongoing study, and we are hoping to do such kind of extended laboratory tests as well.
Thank you.
Okay, thank you, Dr. Roshan.
Yeah, one question from me, actually. This your study covered these dogs, actually. The history of given with administered with them antibiotics with these dogs, who subjected to the study, or they were freely obtained from the just you met them, is it?
Sir, most of the cases presented with the VTHR, not for the first time presentation. Most of the cases came after unsuccessful treatment from treatments. So most of the cases had antibacterial therapy at least 2-3 weeks before the collection of samples.
Okay, yeah, thank you.
Okay, so thank you, Dr. Lalanthi Silva, for joining with us and having an active session at the end. Okay, so we will move to the last two presentations. We have one interesting two cases. First, I move to that the management of septic peritonitis in dogs and cat, primary closure versus open peritoneal drainage by HKUS Hemachandra and DM Silvardhana. Dr. Hemachandra, the screen is yours.
My dear colleagues, today I'm going to discuss with you all regarding one of our study, which is management of septic peritonitis using primary closure technique versus open peritoneal drainage. So septic peritonitis is an inflammation of peritoneum due to the microbial contaminations or toxins, and it can be a surgical complications, or it can be a bacterial translocation from any abscess or any infectious urinary bladder or any kind of infectious areas in the abdomen. So sepsis is a frequent contributor to morbidity and mortality. And the clinical signs are always non-specific, and you can find sometimes fever, sometimes not. And most of the time there can be an abdominal pain, and sometimes animals are in shock on the presentation. So the peritoneal fluid analysis is an essential key factor to diagnose peritonitis, and which can be done from direct aspiration of effusion fluid, or else when the fluid is not palpable or fluid is not there. But if you suspect, you can do diagnostic peritoneal lavage. So how do you do? So basically, you have to just introduce sterile normal saline, that is 20 milliliter per kg and a volume, and you have to roll the PET on the table, and you have to let it mix properly, and then you have to take a sample from there. And both sample anyway, you need to centrifuge first and take the sediment and do cytology, and you can see intracellular bacteria. In case if you notice intracellular bacteria, that may be warrant to go for an emergency surgical exploratory laparotomy. So it's highly susceptible for peritonitis, and so intracellular bacteria is the gold standard of diagnosis. And you can see here the intracellular bacteria. And in this paper, so we are going to compare two closing methods after the surgery. So which is primary closure technique. So you can see actually that is really a normal way we are using any abdominal cut, any abdominal surgery. And our there's another method called closed suction drainage. So there's a suction bag, like you have to insert to the abdomen after the surgery, and the suction when we are doing suction, the fluid can accumulate in the bottle. So the third method, that is what we are going to discuss with the primary closure technique. So it's called open peritoneal drainage. It's OPD, and in that, so we have to close the abdomen, but there will be two holes from outside to the inside. So it should be like a 1 inch gap between two sutures, like. So in here you can see the holes, and from that hole the peritoneal fluid is coming out. So to secure the dressing, you have to put tie-over sutures, and this is how you are putting tie-over sutures, and very nicely you can secure your dressing. So it will absorb all the peritoneal fluid, ideally. And this study is compare the success of OPD and PC, that is our objective. So this study follows 10 cases, 3 cats and 7 dogs. And after the physical examination done, so we have done blood test, and other than that, whenever necessary, we have done the abdominal x-rays and abdominal ultrasound. So we have collected sample when the peritoneal effusion is there, or else where there are no sample, we have just gone through the diagnostic peritoneal lavage technique. And from any of method, you have to do the cytology and stain your slides, and you have to see intracellular bacteria. So remember, that is the key diagnostic point. And you can see here the peritoneal effusions, where you can see it from the arrows. So it is very easily can identify, and then easily can take samples. So don't ever miss peritonitis. And before the surgery. So we have to stabilize the patient by giving fluid, and especially we need to do if the animal is in shock, and we have to start the broad spectrum antibiotic. So which can be third generation cephalosporin. So ideally cefuroxime or Fortum. So metronidazole with or without endofloxacin, depending on the area you are suspecting. And analgesics are really important, and then you can plan the surgical corrections. It will be an exploratory laparotomy because you don't know where the location is. And we use midazolam and ketamine as an sedative, and induction also again midazolam and ketamine, and we maintain anesthesia with isoflurane. And first we suck all the effusion fluid, and then correction of the primary cause has been done. And then we clean all the fibrin deposits and debris. And finally, we lavage the abdomen with warm sterile saline, minimum of 200 milliliter per kg. So you can use more than that even. So if you notice actually the peritoneal discharge is lot, until you get a clear sample, you can lavage. And post-lavage job has to be taken, and either we are using primary closure technique or OPD technique to close the abdomen. So we are using PDA sutures regardless of any issue, but the monocrystal nylon or nylon can be used to close the skin. And this is how we are sucking all the fluid, and this is we are sucking it with using the suction pump. And this is one of the primary case, it is ruptured gut. And this is how we have to manage the open peritoneal drainage wound, because there's nothing to do with the post-closure, the primary closure technique, but the open peritoneal drainage technique is very complicated, and you need to have a lot of nursing care, and there should be a very clean hospitalized cages, and there should be a tie-over dressings, and you have to change minimally twice daily, and or sometimes maybe more if you notice it's getting soaked. And after 3-4 days of proper abdominal lavage daily, and then you can close the abdomen. But every day you need to take cytology. So in case if the cytology get negative like 2 consecutive days, you can close before 3 days. But in case if it is always positive, so you can't close. So maybe sometimes it may need second lavage. So antibiotics, pain medication, as I told earlier, you have to continue. And there were 10 patients with 3 cats, 7 dogs. And the post-surgical complicated case were 6 cases, and there were 1 ruptured pyometra and 1 cystic ovary ruptured, and FIP complications and a GI perforation. And out of 10 patients, we have finished only with 4 OPD, and out of 4, there were 3 recovered and 1 succumbed. And we have gone through 6 primary closure technique. So out of 6, there was only 1 recovered completely, and 1 was succumbed, and other 4 had to went through the open peritoneal drainage once again, because primary closure was not successful method to stabilize them. Unfortunately, 1 was euthanized and only 3 recovered. So basically, you can see actually, so from all those 10 pets, there was 7 recoveries and the 3 deaths. So out of 4 cases, 3 were success, recovered completely with OPD only, and there was 75% success rate, and only 1 case completely recovered with the PC only, so 16.6, and overall mortality rate was 30, which is same as in literature. And the results was improved by intensive care protocols and current compliance, and OPD gives better results, but expensive and needs high nursing care. And we need to do a mental wrapping or serosal patching when you are just correcting bowel. And selection of suture material also really important, because otherwise it will fail. So presence of intracellular bacteria is the key point. I'm just reminding again, and gram stain smear, if you can do so, it will guide you to select an antibiotic before your culture comes. And post-lavage culture is really important, and it will give, give you a measured prognosis. And then try-over dressing, you have to change daily, twice at least. And cytological evaluation daily, it's a must. And analgesia is important, and patient has to stabilize before the surgery. Otherwise, the mortality rate will be high, and post-surgical protein supplementation is a must, and hospitalization required. Thank you.
Thank you very much, Dr. Hemachandra. So the paper is open for the questions now. I hope Dr. Hemachandra is with us through online.
Yes, doctor.
Yeah. So any questions from the audience? So
yeah, Umasha, very good evening to you. Actually, it's a very highly impressive presentation, and with all correct, procedures of surgical attempts. And my question is, have you done any culture-based testing for these peritoneal fluids before your administration of the antibiotics, or in between?
Yes, Dr. Andika, we have done, but anyway, it takes 3 days actually to come. So, however, we have to start. So, basically, nowadays, actually, when I refer into the literature and all, I have to tell you the correct way easily, because now we are normally giving antibiotics, cefuroxime or clavamox, and metronidazole always we are combining. But according to the literature, what I found was the third generation cephalosporin is a must. Basically, that the human surgeons now they come to a conclusion like they have to start with third generation cephalosporin. So ideally, as an example, ceftazidime. So after this research, basically after this study, we are giving Fortum, because it says actually for the veterinary patients also it will apply.
Yeah, in your presentation, once again, you said that you just open up the peritoneum and you corrected the underlying cause.
Yes.
And then you just did this, OPD and CPA close method.
Yes.
So in every case, did you find any underlying cause, as maybe for example, you said pyometra and some other cases? So every cause was there an underlying cause when you open up the surgery?
Yes, always actually, but that only one case was there. It was an FIP complication, and you know that we found intracellular bacteria, but we didn't find any cause. But we think actually it is FIP, and however it has intracellular bacteria, so we had to open, because otherwise FIP cases are no need to open and wash. But because there was a sterile actually, but in this case we had intracellular bacteria. And other than that, there was another one case. It had it is a duodenal rupture, a cat. But the thing is actually we didn't find a cause, but we found just only very hard fecal material. So we suspect it some kind of bowel, like hard bowel, maybe had something, a foreign body and ruptured. So other than that, we found usually that most of the cases are surgical complications.
Thank you very much.
Okay, Dr. Masha, so there's more question from my side. What sort of inclusion criteria you would think about when you apply this technique into your patients? You have a special inclusion criteria, or you just randomly get the patients who are having this sort of complications?
Dr. Suranji, could you please repeat the question?
I know the thing is, I'm just asking what sort of inclusion criteria you are considering when you get the cases into this study. Or if you don't get any inclusion criteria, is that,
The cases all we have actually open and suspected as peritonitis, we got into this case study.
All right. Okay. Okay. I got it. Okay.
Because
And
it's
there
a
was
rare
a
case
post-surgical.
anyway.
Yeah. Great. Thank you for sharing that experience with us.
You're welcome.
Okay. Any questions from audience? If not, we will wind up this presentation. Thank you again, Dr. Hemachandra, for joining with us today. We will move to the last presentation in the clinical session today, and the last presentation of SLBA 2021. This is also coming from the same author, HKUS Hemachandra. It's about the treatment trial for non-responsive anemia with surgical removal of retained ovaries. It's a case study. Dr. Umasha Hemachandra, the screen is yours.
My dear colleagues, today I'm going to discuss with you regarding one of our case study, which is treatment trial for non-responsive anemia with surgical removal of retained ovaries. Hope it will be an interesting case study for you. Kalu was a female dog, a native breed sterilized in 2017, and she was completely dewormed and vaccinated up to date, and she was presented to the clinic on 15th July 2017. And at the presence to the clinic, she was anorexia for 2 weeks, and she had mild vaginal discharge and lethargy and sporadic vomiting. And she had a past history of recurrence of her estrus, that is from 5 months of her post-OHG. Not more than that. She had mild vaginal bleeding, and she was positive for transvenereal tumor TVT in later 2017, and which was treated from her local vet successfully with vincristine. And before to our clinic, she was treated by her local vet, suspecting as pyometra and ehrlichiosis, because she had a total WBC count was 33,700 and mild vaginal discharge. And her blood was positive for ehrlichiosis, and her abdominal ultrasound scan revealed only splenomegaly with that episode. And after a few days, because of the ongoing anorexia, the Kalu was presented to the pet vet clinic. And when we are doing clinical examination, we found very pale mucous membrane, and she had a moderate splenomegaly and mild vaginal discharge. And we also suspect stump pyometra, or it can be due to vagina and can be due to tick fever, either babesiosis or ehrlichiosis, or else it can be immune-mediated hemolytic anemia, the common word IMHA. Yeah, so the hematology values were really interesting, that she had thrombocytopenia of 45,000 platelet, and she had non-responsive anemia because packed volume was 12 and the reticulocyte index was 0.65. So it says it's non-responsive. And other than that, the ehrlichia was parasites on the blood, and normal WBC count we encountered 17,900, and it didn't show an infection. So there was no spherocyte, so negative for slide agglutination, so we can rule out IMHA. And the biochemistry results are here. So it was only hypoalbuminemia and hyperproteinemia and hypoglobulinemia. So that might be due to ehrlichiosis. And as the dog was previously diagnosed as stump pyometra, and she was on cefuroxime intravenous and doxycycline orally for ehrlichiosis. So we had to continue the same. While we have given 3 doses of erythropoietin, 2000 international unit every 24 hours subcutaneously, because her bone marrow response was not there. So other than that, we have given gastroprotectants and polybion as a supportive medication. And we checked reticulocyte index, Paxil volume daily to measure the improvement. And those are the daily blood test results. So you can see that on arrival that blood volume is 12 and the reticulocyte index was 0.56. And after 2 days of erythropoietin, we found 13 PCV and the 44,000 platelet count. And she has been given the third erythropoietin 2 and on day 3. So that means 18th July. Again, there was no responsive and it was the PCV 12.4 and the reticulocyte index was 0.65. So we repeated the scan with abdominal X-rays because we did notice an improvement and color was progressively deteriorating. And we found only mild vaginal splenomegaly, we found only mild splenomegaly and we didn't find the pyometra, but very interesting finding was there. So it was a spherical hypoechoic structure which was behind the caudal wall of the left kidney. So this was right left retained ovary, and there was another irregular hypoechoic structure which was medial to the right kidney with no cyst and highly likely to have right retained ovary. So those are the images. So this you can see 2 centimeter by 1 centimeter. There's a spherical structure with 2 cysts. That will be the left retained ovary. And this will be the right retained ovary. And you can see actually like the spherical structure. This is the one. So we altered our treatment plan with the diagnosis of bone marrow suppression due to high estrogen concentration from the retained ovaries. So we planned the exploratory laparotomy to retain ovaries. And prior to the surgery, we had to do the blood transfusion because color was not stable with the 12 PCV and the low platelet. So other than that, we have to give mild dose of Beranil injection because she was weakly positive for babesiosis day prior to the surgery. Oh, very interesting. This is what we found on the left side of the abdomen behind the kidney ball. So that is a hard spherical shaped mass. So there were 2. This will be on the left side of the ovary and this will be on the right side. So only the left side part had 2 cysts. So this chart will show you how the PCV improved. Before the surgery, the PCV was remaining same, almost 12. And the reticulocyte index was 0.65 and the platelet count was 66,000. And the surgery date was 22nd. At that point, 20th. So at that point, the PCV was 21 and the bone marrow responsive reticulocyte index was 4.4 and the platelet was 220,000. So now the patient is okay to go for the surgery, and on 22nd, that is after 7 days. She was completely okay. And after 27 days, again, she was brought to the clinic just for a general checkup, and the PCV was 32.5 and the platelet was 205,000. As the hematology values were further improved, Kalu was discharged after 3 days from the surgery date. And this is the major events of the Kalu's life with us PET-wide. So there were 3 erythropoietin, no improvement, and the blood transfusion. And after that, extract surgery happened. And luckily, we could have discharged the fellow on day 9th. So there are a lot of things to think. Babesiosis is unlikely to be the primary cause here for anemia, because this anemia, it is a non-responsive one. So actually it was not responsive to erythropoietin either. So bone marrow toxicity is a possibility due to endogenous estrogen. So when endogenous estrogen comes, it should be in a high concentration. So what can be there for the high concentration? So it should be definitely an neoplasia. So maybe a tumor. So which can be an ovarian granulosa cell tumor. So ideally, those retained ovaries could have been sent for histopathology to confirm our etiology. So you have 3 take-home messages related to our study. So it is important to differentiate, to be aware of in this case of retained ovaries, especially is associated with chronic non-regenerative anemia. And you should send your lumps and bumps after your removal for the histopathological diagnosis, because it's really important in future. So best to repeat all the tests, basically blood test and diagnostic images and ultrasound whenever possible, and whenever you notice not responding to the treatment. Thank you.
Thank you, Dr. Hemachandra. The paper is open for discussion, and we are accepting any questions. Dr. Umasha is with us in online.
Yeah, Masha, once again, it's a very interesting story you formulated, and not formulated actually. So you presented today. Thank you very much for sharing with us and for the audience, and as well as the other veterinarians. And I have 2 questions that were there any bleeding from vagina throughout until you removal of the ovaries done? With that animal got histo signs continuously?
There were no bleeding, Dr. Andika, so just a mild vaginal discharge. So it is like mucoid-like.
If there's an estrogen, modulation in the body, there should be definitely heat signs, and I don't know, maybe sometimes, vaginal, vulval, bleeding like things to be happen, right? But it was in this case.
It had earlier, because there was a history. Actually, she is coming into heat always, like after 5 months from the initial surgery. That is in 2017, they have done the surgery. So from 2017, like after 5 months of the surgery, like she was coming into heat. While she's presenting to us, actually, she had discharge.
And my other question, have you all any time did any estrogen test in blood to trace out whether he had higher levels of estrogen in the test in this study?
No.
What is the normal values of the estrogen in the testing animal?
Actually, no, because that was like in a case presented to us. So we didn't do actually. So sorry.
Okay. Thank you very much.
Okay. Thank you very much, Dr. Umasha, for joining with us today. With that, we are coming into the end of the clinical session of 73rd Annual Scientific Session organized by Sri Lankan Veterinary Association. From the beginning and from the morning to until the late evening. So we went through different dimensions of clinical studies with 30 papers, different aspects, especially pathology, medicine, surgery, microbiology. I think we had amazing presentations. And on behalf of the organizing committee, I want to thank all the participants of the clinical session and all the the participants and all the presenters. And especially my thanks goes to our 3 evaluators who was sitting here since morning. Thank you very much for your kind contribution. With that, I will hand over the microphone to Dr. Yoshika. Thank you.
Good evening, everyone. We have come to the end of the 73rd Scientific Sessions 2021. I hope that you will agree with me when I say that it is time well spent having special participation of 6 experts from different parts of the world, with 72 abstracts presented in a vast variety of disciplines. We had animal health, public health sessions yesterday, followed by animal production, clinical, wildlife, and aquaculture sessions today. Thank you all for your participation. I will hand over the proceedings to Dr. Dilan Sathurasinghe, co-chair of the 73rd Scientific Sessions 2021, for the closing remarks. Dr. Dilan, the floor is yours.
Thank you, Dr. Yoshika. We have come to the end of the very interesting evening and end of the 73rd Annual Scientific Sessions. A very good evening to everyone present here and physically and also virtually. On behalf of the 73rd SLVA Scientific Committee, as the co-chair of the scientific sessions, deem it a great honor and privilege to stand before you to conclude this remarkable event and deliver the vote of thanks. An ignited mind is the most powerful weapon on the earth, and this is got through education and research. Research is the most profitable investment for the near future, so the scientific sessions are a key event in the SLVA calendar. First, I would like to thank the keynote speaker and 5 plenary speakers for bringing their expertise and experience around the table and engaging in such fruitful, constructive, and open exchanges throughout the 2 days on veterinary medicine and animal science. I hope everyone has gained great insights and knowledge by listening to those speeches. Further, I want to extend my generous appreciation to the chief guest, Dr. Nimal Samaranayaka, guest of honor, Dr. Hemali Kotalawala, and Dean, Dr. Madhura Munasinghe, and all the invitees for gracing the occasion and their cooperation. Next, our foremost sincere gratitude is extended to the reviewers for their thoughtful comments and efforts towards improving and reviewing the abstracts. We are supremely grateful for the time and support of our judges and session chairs have generously given. Our sincere thanks is to all the authors and presenters who are the recent editor of this event. This is a unique opportunity and platform for Sri Lankan veterinarians to learn and share the experience and knowledge. On behalf of the scientific committee, I would like to extend a very hearty vote of thanks to all speakers and authors for presenting and sharing your important work with us. As usual, there is no event without an audience. Thank you very much, ladies and gentlemen. On behalf of Scientific Committee of 73rd SLVA's Scientific Sessions, we thank President and 73rd Executive Committee of SLVA for their guidance and financial support. Further, I would like to thank hotel staff of Oakland Regency and service rendered by Smart Techno Solutions for organizing this event successfully. An event like this cannot happen overnight. The wheels started rolling months ago. It requires planning and a bird's eye view and all the details. We have been fortunate enough to be backed by a team of very motivated and dedicated colleagues who know their job and are result-oriented. I cannot thank everyone enough for their involvement and their willingness to take on the completion of tasks beyond their comfort zones. So I would like to thank President-elect and Secretary of SLVA, Conference Coordinator, Track Chairs, Conference Secretary, and members of the Scientific Committee. Special thanks to Prof. Neil Allas, Conference Co-Chair, for his leadership commitment, dedication, support for making this event a success. So Let me conclude by thanking all of you for your time and valuable insights. Indeed, you are shaping an important dialogue and putting tools and offering options for advancement of science and policymaking in place that country can use for sustainable development. Finally, I hereby announce that 73rd scientific sessions were concluded and hand over the floor to SLV Executive Committee. Thank you.
Thank you all for your participation. It's the end of the 73rd annual scientific sessions. I would really like to appreciate all your participation. Thank you so much.